तो हम यही तरह से इस्तेमाल ये करेंगे ना.
Yeah, no problem, no problem. I am always with you all here. Don't worry.
Okay, Priya आ गया. It is on YouTube now live.
Yes.
Great. Where is our president?
હું છું ને. I am there.
नहीं, for us, ask president.
Ask president. अच्छा अच्छा अच्छा. Hey, she must be busy.
That we have also learned lot of many things in these 2 years because of online platform.
Yes, yes.
The last year we did with two stations only because of the less number. This time we had to do with the 4 stations, and still we'll have to have 24 examiners. So this time Apurva has kept 3 examiners for each session. We have cut down the session and increased the number of examiner. So एक आध जन कॉफी पीवा जाए तो चाल है. And just for informally, I telling you, the Kaushik Bhai will be telling, we are also giving prize for paper and poster both.
Okay.
અપૂર્વ કેમ આવું રીતે કર્યું છે તે?
અપૂર્વમાં કંઈક સરસ કર્યું છે અને વચ્ચે આમ દેખાય.
અચ્છા એવું છે. બરાબર. એક
ઇનવોલન્ટરી થઈ ગયું છે. હા હા. જંગલમાં ગયો.
હા, now it's fine. આખો અપૂર્વ દેખાય છે હવે. આવી ગયા, આસના પ્રેસિડેન્ટ આવી ગયા.
ઓકે, I cannot see still. Yes, connecting. Arey Shashank, unmute yourself for a minute. I would like to talk. Yes. You change your direction of your video because it is a glare is coming from behind. Your face is not seen.
પંકજભાઈ, શશાંકભાઈ બહુ જોઈન થયા નહીં, ઓછા એટલે જોયું નહીં હોય એમ. Now શશાંકભાઈ,
now it is much better. Yes, because he may not be knowing actually what is happening. That's all. Okay, Priya, let us start. Okay, Kaushik bhai, shall we start?
whatever you say, sir.
Okay, so it is neither. Priya will start it. Thank you.
Good morning, respected faculties. I welcome you all to the current GSC-ASI conference. Sir, actually, we have received a total number of more than 130 entries, and we have divided all of them into 4 stations, which will be having 2 sessions each of 2 hours each. A total of 3 faculty will be judging each participant for a period of 2 hours in each session. So currently, I would like to hand over to Apursha sir to welcome the faculty.
Thank you, Priya. Good morning, friends. Thank you all for sharing this Sunday morning with us. First of all, I would like to welcome our President, ASI, Dr. Abhay Darvi sir, who has been synonymous with the word as a guide or a teacher. I would like to welcome our own head of the department, surgery, and our additional superintendent, Dr. Rajnish Patel sir, and our local Gujarat State Chapter ASI President, Dr. Kaushik Gajjar sir. Over and above that, I would like to welcome all surgical faculties, experienced as well as our budding aspirants. We have a plethora of scientific presentation has already been told by Priya. The presentation are by all postgraduate students of all 14 medical colleges all over Gujarat. These includes all the medical colleges, including government institutes, GMERS, municipal medical colleges, private sector, as well as DNB institutes like Apollo Hospital. There will be 4 stations running simultaneously in 2 sessions, morning and after 11:30. Each session will be judged by 3 senior faculties. That total of 24 judges with a seniority of almost, we have likes of Dr. M.M. Achela ma'am, who is an ex-HOD of surgery, Civil Hospital Ahmedabad, Dr. G.H. Rathod sir, who is also an ex-HOD of surgery at BJ Medical College, Dr. S.C. Mehta, who is an HOD at Jamnagar Medical College. I would also like to say sorry to those entries which I have to deny due to late responders. Most of all, and most importantly, I would like to take this opportunity to thank my teachers, Dr. Kukreti sir and Dr. Pankaj Modi sir, whose never-ending endeavor of teaching and guidance has helped us achieve such an excellent feat. I'll hand over the mic to Dr. Kaushik Gajjar sir as our local GSC-ASI president to say a few kind words.
Good morning, dear friends and colleagues. On this warm Sunday morning, on behalf of Gujarat State Surgeons Association and Gujarat chapter of ASI, we welcome respected President of All India Surgeons Association, Dr. Abhay Dalvi. Dr. Dalvi sir, and he is a senior professor and ardent teacher at KEM Hospital, Bombay. We also welcome our very own Dr. Rajnish Patel, Head of Department of Surgery at BJ Medical College and Additional Medical Superintendent of Civil Hospital. Respected colleagues, this paper and poster presentation is a part of GSC-Con 2021 and it is a pre-conference event for the convenience of resident participants. This conference is hosted by Association of Ahmedabad Surgeons, that is AS, and Gujarat State chapter of ASI and GSC-ASI. All the residents who participate in this paper and poster presentation are requested to register at earliest for the conference of GSC-Con 2021 in December. There will be 3 prizes, first, second and third in both paper and poster section. Best paper selected will be sponsored as representation of Gujarat State chapter in the National GSC-Con 2021. Prize and presentation certificate will be given to all the registered delegates in GSC-Con 2021 on December 26th in the afternoon at the validatory function. Welcome Dr. Dalvi sir, welcome Dr. Rajnish Patel. Thank you. Thank you very much all colleagues. Mic is hand over to Dr. Apurva. Dr. Apurva sir.
I'd like to ask Dr. Rajnish Patel sir to give his blessings before Dr. Dalvi sir inaugurates the event and gives his blessing. Dr. Rajnish Patel sir.
Yes. Please sir. Yes sir.
Good morning sir. Good morning Pankaj bhai. Good morning Apurva. Good morning Kaushik bhai. It is such an auspicious day today that I have been invited to be here present. However, I could make it, and it is nice seeing such a august collection of great surgeons around me. Thank you. Let us go ahead. Thank you, Apurva.
Okay. Dr. Dalvi sir, your blessings. Please inaugurate the event.
Yeah, very good morning, Apurva bhai. Very good morning. And great effort you are making. Hello.
Merely, don't know the
Yeah, good morning, everybody.
Hello, Apurva, very good morning.
Priya, mute all of them. Asavda, please going. There is a inauguration going on later on. Please mute everybody else. Mute.
Online Zoom platform on.
Should I start?
Please continue. Apurva. Yes, sir. Sorry.
Okay. No problem. It happens on Sunday mornings.
Yes, sir.
Yeah. Good morning, everybody. It's a great pleasure for me as the president of the Association of Surgeons of India it's not me, but it is the executive of the Association of Surgeons of India that I represent. That is, I represent all of you all who have joined this program. Let me congratulate Gujarat for being the first state chapter to come out again, starting the academics on the right time. Maharashtra, from where I come, is close second, but Gujarat has, as usual, started it all along as the first state chapter to start the academics for the benefit of the PGs. Corona is declining. As I visited UP state chapter conference, nobody was wearing mask. Here, at least on Zoom, I can see nobody is wearing mask, but there it was absolutely physical, where there was no mask. I was the only person who was actually wearing a mask. That's okay. On the benefit of the PGs, 130 papers, very nice. And I think 2 hours is going to be a very good academic program every Sunday that will lead to development of the postgraduates to become very good surgeons. We have got 3 senior faculties every time who will really guide people on to hopefully the importance of history and clinical examination over investigations and treatment. And that should be the crux of the academic teaching. That's what I feel is lacking today amongst the PGs. With this small thing, I would appreciate if I can be given, because I will not be the president on the 25th and 26th of December, to be involved in any of the academic activity during 25th and 26th, which I can vouch that I will be there to maybe deliver a small lecture. Most of you all whom I am seeing on the screen right now, I know personally. They are very good friends of mine, and I'm sure that I will be involved in the academic activity. Let me again wish Gunwan Bhai specifically a belated happy birthday, which was yesterday. And thank you for responding to my wishes of the birthday. So with this, I am happy to inaugurate this academic session and continue to do the same thing so that our PGs benefit and become good surgeons. Thank you so much, everybody.
Thank
very
you,
much.
sir.
Thank you, sir. Thank you, sir. Thank you very much.
Apurva, continue.
Yeah, that is great, sir. Thank you, and we definitely look forward to seeing you in our academic meets, sir, accordingly. I hand over the mic to all the 4 students. There will be 4 Zoom stations
Apurva,
just to
Apurva.
avoid any kind of... Yes, sir.
Apurva.
Yes, sir.
Vote of thanks.
Yes, sorry, sir. Nina ma'am, please. The president of Association of Ahmedabad Surgeons, Dr. Nina Shah will give a vote of thanks.
Okay, thank you, Apurva. Respected Dr. Dalvi sir and seniors, my dear friends and residents. I am thankful to Dr. Abhay Dalvi sir for accepting invitation to inaugurate ECME for papers and posters. He is always there if we request for academic programs. Thank you, sir. He also gives some hint to the residents in last RRC, and I appreciate all those hints, and I have conveyed to my residents also. Thank you, sir, for that. I am thankful to Dr. Kaushik Bhai Shah and Dr. Pankaj Modi, sir, for being a backbone for all the academic activities of association. Thank you, Pankaj Bhai, for your guidance and always ready and available for the academic programs in spite of your busy schedule and taking interest for smallest events of the CME. Even as junior to senior, anybody can contact him for guidance for any academic activity. Thank you, sir. Thanking Apurva for his untiring work to make this program successful. He did very hard work for making this program very effective, and he created 4 stations for that. I am thankful to Dr. GHR sir, Kaushik Gajjar, Dr. Narendra Sangvi, and Dr. Rashesh Solangi. Those are the GSSA, GSC-ASI, and Association of Ahmedabad Surgeons President and Secretaries. Thankful to them. They helped to organize this session also. We started this all the activities in 2020, and during this activity we found out lots of hurdle, and we solve all these hurdle, and because of that we are able to do this activity nationwide also. I am thankful to all 24 examiners who are ready to attend as an examiner in this session, and all of them are senior professors and the HODs, and so I am thankful to them for remaining present today. I am also thankful to senior resident Dr. Priya Gupta, Rinav, Jhansi and Swati, who will handling this all 4 sessions. Thank you, everybody. I am handing over the mic to
Apurva.
Yes,
Thank you,
sir.
sir. Dalvi, sir, thank you very much. Rajneesh bhai, thank you very much. Thank you for joining and starting the day on a good note. Apurva.
Yes, sir. I think we'll start now. It is
Okay,
about
but
time.
actually I request all the respective examiner to join their station as well as the students. The post holder of the AS and core committee can jump from one station to another station as per their wish. But the 4 stations will run simultaneously, simultaneously, session 1 and session 2. And for station 1, Dr. Priya Gupta will be looking after routine thing, and Dr. Vinit Chauhan will be in overall charge. Station 2, Dr. Rinav will be looking after it, and Dr. Nina Shah will be in charge. Station 3, Dr. Jhansi will be looking after the station, and Dr. Apurva Shah will be in charge. Station 4, Dr. Swati will be looking after it, and Dr. Prujal Parekh will be in overall charge. So any query from anybody will be solved by these 2 people. In anticipation that everything will run smoothly, but let me tell you, there is bound to be some small hitch and hurdles. We have done a dry run yesterday night, but still there can be some. So excuse us and have a patience. So I request all 4 to start their respective station and do the preliminary work, and we will start exactly at 9:30 with the first poster. First 10 will be the poster and 7 next will be the papers. Anybody has to say? Kaushik bhai, Kaushik Shah.
Sir, only
Yes.
only one more point.
Yes,
I think Pankaj bhai, you have an Apurva and whole team of the BJ Medical have arranged very nicely, and everything is as according to schedule. And I must congratulate Apurva because and his team because of his tiredness efforts, these things can be possible, and this will be the, as Dalvi sir has said, Gujarat is always first as national level. So we are the first, and we will guide the India in future. That I think so. You can understand what I mean to say, Pankaj bhai.
Anyway, Apurva, what were you saying?
Yes, sir. Only for the specifically for judges, please see to it that the programs and the posters are completed in time, and for a good and juicy discussion. We have given 4 minutes for posters with plus 2 minutes for discussion, and same thing 6 minutes for papers and 2 minutes for discussion. Please excuse us if the time does not permit some more discussion. I am really sorry if because in spite of all our efforts, the whole event will take at least 4 to 5 hours on a Sunday morning. We'll start all the 4 stations now. It will take a few 5 minutes or so in running it smoothly.
Apurva, trial should be started at present.
Yes, sir.
Because
I would like to say to
at 9:30
residents,
you can start
anchors,
actual paper and posters. So all examiners are requested to join to their respective group and start the discussion with our coordinator, so that everything will go smoothly.
Yes, sir.
all residents, please see, there are 4 to 5 hours. All the examiners are spending behind you. We specially request to get registered for the conference and make a conference great success. Please register yourself as soon as possible. Thank you.
Sir, with your Dalvi sir, with your permission, we are starting all stations now.
Please, please.
Okay, thank you, sir.
So this station 1 we have Dr.
Please be with us for the session.
Sir, on this station we have Dr. Pankaj Modi sir, Dr. Dharmesh Vasavada sir. and Dr. Jitendra Darshan, who will continue as a judge. Priya will introduce to them. I'll be switching on to the other station, my station,
Okay.
sir.
Bye, Apurva. Thank you.
Fine. Thank you, sir.
Good morning, faculty. I would kindly like to ask you to kindly join your respective stations. Now we'll be beginning with this is station 1 currently, and now we'll be beginning with session 1. The judges for this session are Dr. Pankaj Modi, who is a professor in Department of General Surgery in BJ Medical College, Ahmedabad. Then we have second examiner will be Dr. Dharmesh Vasavda. He is professor in Department of General Surgery in Guru Gobind Singh Hospital and MP Shah Medical College, Jamnagar. Our third examiner will be Dr. Jitendra Darshan, who is professor and head of department in Department of General Surgery from Smimar Hospital, Surat. Sir, I would like to say the general rules. I would like to ask all the participants to kindly keep their mic on mute and their video off. Only switch them on when their turn has come. In the first session, we have 10 posters followed by 7 papers. Time for each poster will be 4 minutes for presentation, then plus 2 minutes for discussion or question answer round. And for paper, there will be 6 minutes for presentation, then 2 minutes for question answer round. I would like to ask the examiners to kindly stick to the timings, and they have to grade the participant out of total of 50 marks. Our first participant is Dr. Sneh Joshi.
Priya,
Yes, sir.
also,
Yes, sir.
also clarify how to send 5 points and how to send back the mark sheet.
Yes, sir. The examiners have been sent a list of the schedule as well as the marking scheme. The examiners will be marked out of the participants will be marked out in 5 areas. That is originality of their topic, the presentation of their topic, the quality of their slides, conclusion, and the whatever, and 10 marks on the question answer round, how they defend their question. The list has been sent to the examiners. Either they can take a printout of the Excel sheet, enter the marks, and take a photograph and send it to me, or they can write the name of the participant on a piece of paper, and in front of that the marks they can write and then send it to me after taking a photograph.
Okay.
Sir, we'll begin with the first presentation. I'll be sharing the yes, sir. Sir, one more minute. Sir, I'll be sharing all the presentations in a sequence, and the participants only have to read out their presentation.
And rules regarding if participant does not respond immediately.
I'll be calling in the sequence. I'll be calling out the name of the participant a maximum of 3 times. If the participant is not there, they'll be shifted to the last place in the same session. Kindly note, the participant in one session, if they are not present, they won't be allowed to present in any other station or any other session.
Great.
I'll be now sharing the screen for the first presenter. Just please give me 1 minute.
Okay, please don't. We are before time, so actual time is 9:30. So if the participant is not there, we'll have to wait. And please, Dr. Vasavda, are you there? First, confirm that the examiners are there and Dr. Jitendra Darshan.
Yes, sir. I saw, sir, both of them.
Okay. So please unmute and show your video so we can know. The only 5 people will be showing: Priya, 3 examiner, and candidate.
Sir, is the screen first poster visible?
No, just now we are seeing your screen. It will be seen. Yes. Now zoom it. That's better. Still little zoom. Yes, yes, little less. That will be, so the candidate name should be seen lower down. Very good. Excellent. Excellent. Great. Okay. So I am there. Where is Dr. Vasavda? I think I heard him also. Dr. Vasavda.
Yeah, sir.
Please.
Very good morning. Very good morning, sir.
So show your video also. We would like
Yeah,
to
I
see.
started.
Okay, great. And Dr. Jitendra Darshan? Dr. Jitendra Darshan, HOD Smimer Surat. So if it's not seen, Vasavda will start anyway.
Yeah, sir. Yeah.
No problem. You have got the mark sheet and everything?
Yeah, sir.
So communication was all right from our side?
Yeah, very correct, sir. Very correct.
Okay, great. Why I'm not able to see you, Priya?
Sir, you
So
are
we
not able
can
to
see
me.
him. So we can see him. I can see him, sir.
I'm not able to see. I don't know why. What may be the reason?
Okay, I'm
Yes.
starting.
I think I'm seeing you. No problem.
Okay,
Yes,
sir.
I can
So
see
nice.
now Jitendra. Dr. Jitendra, welcome. Please say something so we know that your audio is working well. Yes, we can see you, but we are not seeing the. And I request all of other candidate to switch off their video and audio, except the candidate who is being judged. Dr. Jitendra Darshan.
Yes, sir. I'm here.
Okay, now yes, I was great. So okay, Priya, now we are ready.
Yes, sir.
Dr.
Dr.
Roshan
Sneh?
is there. I think please switch off
Yes.
your videos. There should not be any confusion regarding that. When your turn comes, then only you do it. Dr. Roshan, I can see his video, please. Yes, thank you very much. Okay, so call the first candidate. Shall we start? Dr.
Yes, sir.
Vasavda and Dr. Darshan?
Yes, sir. Yes, sir.
So from our side, I will not be asking much of a question. Or we can do like that, one candidate, one examiner, so there will not be much confusion, whatever you suggest. So or by turn, anyway, let us see what happens. Anyway, Priya, call the first candidate.
Dr. Sneh, please start your presentation.
Yes, am I visible and audible properly?
Yes, you are visible and audible.
Okay.
Good morning, everyone. Good morning, the judges and my fellow residents. I am myself from Smimer Medical College, a third-year resident. Today, I'll be starting with my case presentation that I'm doing for a poster, case report of a right-sided submandibular gland excision in case of the submandibular duct sialolithiasis. I am the author of this poster, and my co-author would be Dr. Dinesh Prasad sir, who is additional professor at my institute. The keywords for this poster are submandibular gland, Wharton's duct, and sialolithiasis. As I start with the introduction, the submandibular gland is the mixed, predominantly mucous gland with large superficial section and small deep lobes that connect around the posterior border of the mylohyoid muscle at the angle of the jaw. The submandibular duct arises from the deep part of the gland from the floor of the mouth along the lateral side of the frenulum linguale. The Wharton duct rests at the lower level of the oral cavity, and the location allows for the retrograde infection of the gland by oral flora. The pH of the saliva in the submandibular gland is alkaline, which may lead to the formation of the calcium salts. Clinically, the calculi appear as generally yellowish, round or oval masses and can be rough or smooth. Here we are going to discuss the case of the submandibular duct sialolithiasis. We had a patient for the same. The case presentation will be as follows. A 38-year-old female was presented with the swelling in the right side of the neck since last 2 years, which was insidious in growth and later become painful while having meals. After meal, the pain usually used to increase. The USG of the patient was unremarkable and with evidence of the right-sided level to cervical lymphadenopathy, which suggested of having infection. The CT scan neck was suggestive of the right submandibular gland mildly small compared to the left side, and showed approximately 4.2 by 4 millimeter size and 4.2 by 3 millimeter size of two calculi within the Wharton duct. approximately 1 centimeter distal to the entry margin of the submandibular gland with resultant dilatation of the submandibular gland proximal to the calculi. We chose to operate this patient for the same. In the surgical procedure, patient was placed in the semi-fowler position with left lateral orientation. The inframandibular approach was made. The facial, while dissecting the area, the facial vein was identified and ligated, and the deep cervical fascia was exposed, beneath which the gland was lying. The fascia was open to expose the superficial part of the gland. The mylohyoid muscle was identified, which was separating the gland, the deep and superficial parts, which was identified and dissected to expose the deep part. While doing this, the lingual nerve and the hypoglossal nerve were identified separately and they were secured. The both part of the gland were excised along with the duct. As we move to the discussion, the sialolithiasis are the condensation of the salt, calcium salt, primarily the calcium phosphate in form of the hydroxyapatite with small amount of the magnesium carbonate and ammonium. The salivary calculi related to the submandibular gland are more common than the parotid gland due to some factors like direction of the salivary flow against the gravity, a longer and more tortuous structure of the Wharton duct, and the higher calcium and the mucin content of the saliva produced in submandibular gland are other factors. The diagnosis for the same can be done by following methods. When nose, primarily the imaging the occlusal radiographs are extremely useful when no stone is palpable clinically, and the radio-opaque stones, unless otherwise there is a radiolucent stone. And CT delineates the better anatomy and exact location and of the same. The next investigation is sialography, which is used widely for the detection of the duct stricture, the stenosis or the sialolithiasis. It is a method of the injecting contrast material into the Stenson's or Wharton's duct for the visualization of the duct. In sialoendoscopy, in addition to the radiolucent
Dr. Sneh, your time for presentation is over. I would like to ask the judges to please ask questions now.
Okay. Dr. Sneh, okay,
yes,
case. So was it a single case, right?
Yes, sir, it was a single case for us.
Okay. So what was the incision actually against the landmark? Where did you put an incision? Exact incision.
Sir, the exact incision was made in the inframandibular region, from the mid part of the ramus of the mandible up to the angle of the mandible.
No,
it was
still one
approximately
important point left.
Yes, sir. It was on the left side.
No. What distance from mandible?
It was 2 centimeter inferior to the mandible.
By 2 centimeter.
Sir, the deep part of the submandibular gland lies inferiorly to the and posterior to the mandible.
No, that is no. It has nothing to do with the submandibular salivary gland. It has nothing to do. Incision has nothing to do with that. Why it should be at least 2 centimeters below. Second point, which is the commonest complication of this surgery?
The commonest complication of this surgery is the injury to the nerve, that is lingual nerve, the lingual nerve, and the injury.
I have not seen a single injury to lingual nerve till today. Which is the commonest complication? Hypoglossal nerve does not come in a picture also. What do you mean by semi-fowler position?
In semi-fowler position, the support was kept at the below the neck, and the neck extension was promoted.
Okay, which ganglia comes in your dissection?
Sir, so
okay.
I don't have any.
Which artery need to be ligated? Is there any artery which needed to be ligated? Have you done intraoral examination? Have you mentioned anything about intraoral examination?
Yes, sir, we have done intraoral examination.
Is it important or not?
Yes, sir, it is important.
Why you have not mentioned? It is one of the most important. What is significance of intraoral examination?
Sir, in intraoral examination, if the stone is in a proximal duct, it can be the intraoral approach for the removal can be done.
One. Second, how do you differentiate clinically that it is a salivary gland and not lymph node.
Sir, lymph node would be regular and
No,
round
clinically,
and
we are talking of clinically.
The time for questioning is over.
Okay, thank you, Dr. Sneh. Please
I would-
share the second slide. Thank you very much. Okay.
thank you, sir.
I would like the next participant to please come, Dr. Hiteshwari.
We are
One
not-
minute, I'm just sharing her presentation. 1 minute. sir.
Okay. Okay, no problem. We understand it takes some lagging, no problem. Don't worry.
Sir, is it visible?
Yes. Where we? Please, Dr. Vasavada, take over for this case. Okay, Dr. Hiteshwari.
Good morning. Good morning to all. Am I audible, sir?
Yeah.
Yeah. Can I start?
Yes, start please.
Okay. I am Hiteshwari Patel, second year resident from BJMC. Today I am presenting a rare case of left thigh hydrated cyst. Hydrated cyst is a parasitic disease caused by Echinococcus granulosus that is endemic in the Mediterranean countries, the Middle East, South America, Australia, New Zealand, and East Africa. It is a zoonosis that occurs primarily in the sheep grazing area, with dog being the definitive host, sheep the intermediate host, and the humans being the accidental host who contact the disease from dogs, but there is no human-to-human transmission. More than 90% of the hydrated cysts occur in the liver, lungs, or both.
We have lost his audio.
He is not there. Dr. Hiteshwari? Yeah, please unmute yourself.
And accidentally she muted.
Yes.
Yeah.
Kindly continue. Some internet problems, sir. Dr. Hiteshwari, kindly continue.
Okay, thank you. More than 90% of the hydrated cysts occur in the liver, lungs, or both. Peripheral organ hydrated cysts is less common, as only few embryos can escape the capillary filtrating system of the liver and the lungs. Theoretically, the high lactic acid level in the muscle tissue is considered unfavorable for the survival of the parasite. Primary hydrated disease of the skeletal muscle is hydrated cysts are low. The most these can also helpful. The treatment is
Hiteshwari, what you can do, stop your video, then the audio quality will improve. Stop your video, no need for video.
Sir. The aim of this study is to report an unusual case of
Your internet connection is unstable, Hiteshwari.
That's why we told everybody to be present where there is a good internet connection. This is the problem. We cannot do anything from our end. When your connection is not good, we can't do anything. So, are you ready to now?
Are you there, Hiteshwari?
I think
Your internet connection is unstable. We can't hear you. Sir, shall we add her in the last
yes,
session?
yes, we will take her again. Go to 3.
Let's move on to the third
And
participant.
instruct her that she should be present in a with good internet connection. This is the problem going to be there. Okay.
Dr. Kavan, kindly be present. I'll share your poster.
Hello. Am I audible?
Yes, you are audible. Just give me 1 minute. I'll just share your poster. Is it visible?
Yeah.
Okay.
Can you make it full screen?
Yeah, kindly start.
Should I start?
Yeah, start.
Good morning. I am Dr. Kavan Takwani, third year resident in Sri Krishna Hospital. I am presenting a case of primary vesical actinomycosis with changes of cystitis cystica presenting as a bladder mass. My guide is Dr. Nagendra Mishra. The most common etiology of vesical actinomycosis is a direct extension from infection in the pelvic organs. The occurrence of primary vesical actinomycosis, that is, without a primary focus of infection elsewhere, is extremely rare. The clinical and radiological features usually point towards bladder malignancy. A case of 60-year-old male presenting with chief complaints of painless hematuria with clots and burning maturation for 15 days and low-grade fever for 5 days. No complaints of weight loss, loss of appetite, lower abdominal pain or backache. Patient has no significant past history and general and systemic examinations were normal. Routine laboratory investigations were normal. Ultrasonography of abdomen and pelvis was showing a large soft tissue mass involving right posterolateral bladder wall of approximately 6 into 5 centimeters. The CT scan was suggestive of a large irregular shaped contrast enhancing soft tissue mass of approximately 6 into 5 into 5 centimeters involving the right lateral wall of the bladder, having multiple thick walled cystic lesions with irregular frog-like margins and pockets of fluid collection. Marked perivesical fat staining was noted with preserved fat planes with surrounding structures. So our provisional diagnosis was of bladder malignancy. On cystoscopy, a large mass projecting into bladder with edematous hyperemic wide base was seen. We took superficial biopsy cuts which showed focally hyperplastic and ulcerated urothelial lining, squamous metaplasia, keratin pulse, and brood nests. Changes of cystitis cystica were seen with the urothelium invaginating into the lamina propria. There was no evidence of malignancy. On gram staining, plenty of bacterial colonies consistent with the actinomycosis with areas of calcification and neutrophilic exudates were seen. So based on these histopathological findings, our final diagnosis was of primary vesical actinomycosis with changes of cystitis cystica. We gave intravenous cefoperazone with sulbactam for 2 weeks and intravenous ampicillin for 1 week. On discharge, patient was prescribed oral amoxicillin with clavulanic acid for 3 months. Patient was asymptomatic and a CT scan showed reduction in the size of the bladder mass on a 3-month follow-up. This improvement is persistent even after 18 months on a recent follow-up. So common features of vesical actinomycosis include suprapubic pain, abdominal mass, burning maturation, increased frequency, hematuria, fever, and weight loss. In our case, patient presented with hematuria with clots and irritative urinary symptoms. CT scan usually reveals a solid mass infiltrating locally with cystic lesions and dense contrast enhancement on the walls or solid components of the masses. Due to its infiltrative nature and proliferative pseudotumor pattern, actinomycosis is often misdiagnosed as a malignant disease. Hence, histopathological examination is the gold standard method for diagnosing actinomycosis. It shows central suppurative necrosis with sulfur granules surrounded by granulomatous tissue and intense fibrosis. In our case, the report also showed changes of cystitis cystica. According to our literature search, this is the first reported case of primary vesical actinomycosis with changes of cystitis cystica. So cystitis cystica is a chronic inflammatory hyperproliferative condition wherein the submucosal masses of epithelial cells known as brood nests undergo cavitation to form fluid-filled cystic structures. Antibiotic therapy is the gold standard for treatment of actinomycosis. Dosing and duration of antibiotics should be tailored according to the individual needs. Surgical intervention is usually limited to excision of abscesses and fistulas, decompression of the closed space infection, and establishing correct diagnosis of the infection. So preoperative diagnosis of actinomycosis is a clinical challenge as there are no clinical, laboratory, or radiological findings that are specific to the infection. Hence, we have to rely on histopathological examination or culture reports for a confirmed diagnosis. There are very few reported cases of vesical actinomycosis and with one published literature on primary vesical actinomycosis in India. Thank you.
Dr. Darshan, Dr. Vasavada, please take over.
Yeah, sir. Just let me. Hello.
Hello.
So kindly begin the questions.
Hello.
Yes, sir.
Yes, man. Tell me. You have done a very good, very rare case of the vaginal actinomycosis. Why suspicious is there for all this pathology? Why? What was the main complaint of the patient?
Sir, actually, patient presented with hematuria with clots and burning maturation, and symptoms were of irritative and frequency symptoms. So primarily, as there was hematuria and it was painless and total, so we were suspecting bladder malignancy only. And plan was made for transurethral resection and taking for the bladder mass biopsy, that is TURBT. But it was accidentally found out on the histopathological report that patient has actinomycosis other than the malignancy.
So there is no
and clinical.
On no ground, clinical suspicion was made for actinomycosis, yeah?
Yes, sir. On clinical features and on radiological features, it was very much suggestive of bladder malignancy only.
Okay. So pathologists made it remarkable difference.
Yes, sir.
Any particular examination inspection finding retrogatedly, can you think that it is not a malignancy actinomycosis? Any particular findings?
So the symptoms were of short duration and patient had associated low-grade fever for 5 days. That's all on the basis of history that we can say that some infection is there and in the underlying case. Otherwise, sir, no clinical findings were there.
During TURBT, during inspection, everything looks like malignancy only.
Sir, in TURP also there was proliferative pattern. So that is what I was told, that it was a pseudo tumor proliferation. The proliferation was similar to the bladder malignancy. So first we could only take superficial bites. When that histopathological report came as negative for malignancy, we redo a TURBT, and on that we tried to take a deeper biopsy. At that time, we found a pus-filled cavity, and from there we took the pus and sent for the gram stain, and also we took the deeper biopsy cuts. So we had to do a repeat TURBT, sir.
Okay. Over to Jitu. Over to Darshan.
Time for questioning is over, please.
Okay, fine. Karan, only one question. What is difference in granule between actinomycosis and Madura mycosis?
Sir, it is a sulfur-containing granules in case of actinomycosis.
Okay, Priya. Thank you. Next candidate.
Thank you, sir.
Ben. Kakri.
Yes, sir. Sir, for it takes time, sir. No, sir. Patient had ileostomy done at the past private hospital, and it is a on pure trauma. They have not done this.
Hello, sir.
Yes. What is going on?
Am I audible and visible?
Yes. No, not visible. I think last case is still seen.
Who is this?
Sir, myself, Dr. Rajvi Goyal, third-year resident from SSG Hospital, Baroda.
Okay. Now, yes, you are saying Zoom it, Priya.
He can come to our hospital after 9 months.
What is the background noise, Priya?
Sir, everyone else is mute. I think it's from Jitendra sir's.
Okay, fine. No issue.
I think some, because I can't see anyone else speaking.
Okay, fine. Okay,
Dr. Raji, please start your presentation. Okay. Good morning, everyone. Myself, Dr. Rajvi Goyal, third-year surgery resident. I'm presenting a poster on a rare case of retained guide wire spontaneously emerging from skin near right knee 8 months after central venous catheterization. Introduction. Central venous catheterization is used to monitor central venous pressure and administer intravenous fluids. Retained guide wire is a rare but dreaded complication of it. In our hospital, a case of 22-year-old female patient with symptoms of knee pain and swelling with guide wire emerging out below right knee joint 8 months after procedure. Using artery forceps, guide wire is withdrawn from the protruding site in operation theater. Attention and proper guidance to trainee during procedure are required to minimize such preventable complication. Case profile. This is 22-year-old female, came with the complaint of knee pain and right lower limb swelling with guide wire emerging out just below right knee joint since 2 months. Past history of right femoral central venous catheterization in intensive medical care unit before 8 months. Past history of cerebral venous thrombosis about 10 months back. On examination, there is swelling and tenderness over right knee joint. After that, we have done this investigation of X-ray of right knee, X-ray of pubic PBH, X-ray of right hip with proximal femur, which is shows abnormal radio opacity noted in the soft tissue shadow, suggesting of foreign body, which can be guide wire. Duplex scan of right lower limb was done, which shows linear echogenic line noted in its course of right femoral vein, extending distally in great saphenous vein and proximally up to right external iliac and inferior vena cava. Possibility of foreign body. Hypoechoic material filling of the lumen of common femoral vein, great saphenous vein, right external iliac partially, which gives patchy color flow on application of Doppler. Possibility of partial thrombosis. This is the image, shows the guide wire emerging out from skin near right knee. This is X-ray of knee joint, and this is X-ray of PBH. And after that, we have done under spinal anesthesia in operation theater with the help of artery forceps. The guide wire was slowly withdrawn from the protruding site. There was no bleeding and patient was started on anticoagulation for thrombosis and discharged after 5 days of removal. On follow-up, patient is asymptomatic. Now the discussion. Retention of guide wire is rare but potentially serious complication of central venous catheterization. In our case report, guide wire is detected when it emerged out from skin to outside of the body below right knee, which is an extremely rare occurrence. Complication due to retained wire when detected were pain and right lower limb swelling and partial thrombosis in femoral vein. The proximal end of the wire was slightly bent but not adherent to vascular wall and removed without breaking of wire. Primary reason in the design of guide wire, absence of marks and straight proximal end, leading to difficulty in ensuring that the end has been secured. Fear of losing vascular access, use of circular advancer, and concerns over contamination of proximal end also contributes to excessive introduction of guide wire. Operators' inexperience, fatigue, inattention, and inadequate supervision of trainee were suggested as other predisposing factors. Now conclusion, it is very unusual presentation of retained guide wire by protruding outside the body at 8 months after placement of a central venous catheter. This complication can be minimized by measures to train personnel under the supervision of expert operators.
Dr. Rajvi, please unmute yourself.
Sorry, am I audible?
Yes. I think there are some background music or whatever it is you call it. Okay. Please continue, Rajvi.
Sir, conclusion, it is very unusual presentation of retained guide wire by protruding outside the body at 8 months after placement of a central venous catheter. This complication can be minimized by measure to train the personnel under the supervision of expert operators, confirming that the guide wire has been returned to the catheter kit after insertion of a central venous catheter. These are the references.
Okay, great. Good presentation. And you have completed within time. Dr. Darshan, please, would you like to ask?
Yeah, Dr. Rajvi.
Yes, sir.
It was a good presentation, but I would like to ask you, as this is a rare case, what is your message from this poster?
Sir, my message from this poster is as we are residents in residency, we have lack of time, very hectic schedules. So due to lack of sleep, due to lack of guidance, the we are in when we are in hurry, we left to check that the guide wire has been written in the kit, or we can do the central venous catheterization by USG guidance.
What the sir is asking, can you apply it to our day-to-day procedure also? A message, this is more important.
Yes, sir.
Yes.
No
Hello?
step you can skip. There are written steps for each procedure.
Yes, sir. Yes, sir.
Right. So what message you want to convey with this poster?
So my message for this that we should go by step, and without hurrying, we should do the procedure, which is ideal way of doing it.
Okay, great. The point
Thank you,
here
sir.
is that why this guide wire came out. It is a foreign body, but why
Yes,
it came
sir.
out? What is the reason?
Sir, because sir, the length of the catheter is long. Maybe to
Okay, why it has come out? What happens? What is the reaction of body which makes the foreign body come out?
sorry, sir. Hello.
What is his we can call pathology which makes the foreign body to come out? What are the steps? What happens? That's why the foreign body comes out from the skin or anywhere. What kind of reaction from body? What do you call it?
Sorry, inflammation.
The inflammation is fine. That's all right.
Yes.
I can give you a hint. When we put a proline mesh, why it doesn't come out normally?
Yes, yes. Sir, because it is inert.
Yes, one is a inert. If
Inert.
material is inert, it may stay. What else?
Time for questioning is over, so sorry.
Okay, thank you.
Thank you, sir.
Rajvi. Next
Thank you,
candidate,
sir.
please.
Next candidate, Dr. Rohan.
Hello.
Just give me 1 minute. I'll share your presentation.
Let Priya share your presentation. You are there, fine. Actually, Priya, there are 2 Rohans in the list, I think so.
This is Dr. Rohan Chaudhary.
Yes, great.
Yes, sir.
Yes.
Is it visible?
Yes, the presentation is visible. Rohan, you can start.
Yes, sir. Yes, sir. Today I am presenting a poster on insulinoma, a pancreatic endocrine tumor, a rare case report. Start with the introduction. It is a pancreatic endocrine tumor. Incidence is 0.001%. It is distributed between 25 to 75 years, equally distributed in female and male. 97% in pancreas with equal distribution in head, body, and tail. Rarely it occurs in duodenum, splenic hilum, gastroiliac ligament, 3%. Average size is 1 to 1.5 centimeter. Weight varies from very tiny to over 1.5 kg. Chances of malignancy is 10%, multicentric 10%. Associated with man, 1, multiple endocrine neoplasia 1. Clinical features, symptoms of sympathetic overactivity response to hypoglycemia may present. For example, fatigue, weakness, fearfulness, tremor, hunger, diaphoresis, tachycardia. CNS symptoms may predominate: apathy, irritability, anxiety, confusion, excitement, loss of orientation, blurred vision, delirium, stupor, coma, or seizure. Patients with insulinoma often reported significant weight gain associated with the onset of symptoms, as they compensate by eating frequently to prevent the hypoglycemia. Diagnosis: Whipple's diet precipitated by fasting induced neuroglycopenic symptoms of hypoglycemia. Second is low blood glucose level. And third is relief of symptoms after administration of glucose. Others are inappropriate increased level of insulin and C-peptide. Increased insulin glucose ratio greater than 0.3. Gold standard is diagnosis is 72-hour fasting monitoring test. CCT and endoscopic ultrasonography can help in localizing the tumor. Insulinoma management, clinical suspicions, Whipple's diet, diagnosis with 72-hour fasting monitoring, biochemical markers, insulin, C-peptide, glucose, localization of tumor with USG, CCT, MRI, and EUS. Unlocalized tumor may require angiography with or without stimulation simultaneous study. Surgical resection is the treatment of choice. Preoperative care prevent severe hypoglycemia. Administration of diazoxide decrease the insulin release from beta cells. Surgical options enucleation as well as splenectomy, subtotal pancreatectomy, pancreatoduodenectomy. Postoperative care prevent rebound hypoglycemia, pancreatic fistula, persistent hyperinsulinism in metastatic tumor. In such cases, administer streptozotocin plus 5-fluorouracil, somatostatin analog, for example, ectretide, retiotide. Case report: a 58-year-old female present with history of fainting, giddiness, weakness, anxiety, irritability, sweating, loss of orientation. Patient had recurrent hypoglycemic attacks since last 2 years. Twice she was admitted in unconscious state and ongoing ungiving with IV dextrose. She regained consciousness. No history of chest pain, palpitation, hypertension, or diabetes mellitus. History of hysterectomy before 10 years. On examination, pallor is present. Patient is obese. Uh, Patient is febrile. On admission, patient is febrile, tachycardia, mild tachypnea. Blood pressure is normal. Per abdomen is soft and tender. On lower on per abdomen examination, lower abdomen, large 10 by 5 centimeter size abdominal lump is present. Lab investigation, routine blood investigations are normal. ECG, CX are normal. USG abdomen suggestive of small ill-defined hypoechoic lesion in pancreas, well-defined echoic cystic lesion, 19 by 90 centimeter in right adnexa, suggestive of ovarian cyst. CECT abdomen suggestive of a 2.5 centimeter size, strongly enhanced lesion in the body and tail in a body and tail junction. It is well defined, enhanced in arterial phase and shows early washout, suggestive of pancreatic endocrine tumor. Serum peptide level is 5.02 microgram per ml. Serum insulin level is 213
Dr. Rohan, your time for
Hello?
presentation is over. I would kindly ask the judges to ask questions.
Rohan, the problem with you, you spent lot of time in introduction. To all candidates, do not spend too much of time. Come, because this is case presentation. This is not a thesis of insulinoma. So straight away come to your that. If you have to discuss genetics, molecule, that comes after your case presentation. We have not seen what actually you did in your case presentation. So keep that in mind. What was the weight of patient pre-operatively?
Weight, sir, 80 kg.
And what was the weight post-operatively?
Post-operatively, sir, 72.
So how much before patient was operated?
Sorry, sir.
When was patient was operated?
Patient, sir, operated after, sir.
No.
Hello.
1 month back, 6 months back. So this much weight loss occurring how much time?
One month, sir.
So 1 month there was a 16 kg of weight loss. You want to say?
No, sir.
10
6
kg.
to 7 kg. 6 to 7 kg, sir.
6 to 7 kg. So what is the typical clinical features you see in an insulinoma?
Sir, patient on fasting, patient becomes unconscious. Sir, symptoms of hypoglycemia, sir.
No. How the patient will say this is happening to me? Very typical features of insulinoma. You have written, but you are not speaking. Okay, which is the commonest complication after surgery?
After surgery, sir, rebound hypoglycemia or pancreatic fistula.
Hypo or hyperglycemia?
Hyperglycemia, sir.
Okay. Surgical complication rather than physiological?
Pancreatic fistula.
Pancreatic fistula. So if patient develops pancreatic fistula, how will you treat it? What is treatment of choice?
Sir, if it is a mild pancreatic fistula, it will treat manage conservatively.
Okay.
Then
That is only what else? Suppose patient has a persistent 200 ml after 3 months. You have treated conservatively. What will you do? Treatment after 3 months of a pancreatic fistula. Okay. What are the chances of patient having multiple insulinoma? Is it a known thing or not?
Sir, please let this be the last question as the time is over.
Great. Are you knowing or not?
No, sir.
Okay. What was the age of patient?
It's, sir.
Okay.
58
Thank
years,
you.
sir.
Thank you.
Thank you, sir.
Next presenter is Dr. Rishi. Are you there, Dr. Rishi?
Yes, am I audible?
Yes, you are audible. I will just share your presentation. Just give me 1 minute. Is it visible?
Yes.
Thank you.
Kindly start.
My topic for presentation is median arcuate ligament syndrome. It is a rare case of chronic postprandial abdominal pain. Introduction. It is a rare condition in which the arcuate ligament compresses the celiac artery, which in turn leads to the impaired blood flow to liver, stomach, and other organs. It may mimic the symptoms of mesenteric ischemia or gastritis. The typical triad which with the patient presents are postprandial abdominal pain, bowel function disorder, and weight loss, often misdiagnosed and ultimately confirmed by vascular imaging. Ligamentous compression of the celiac trunk can also be present in asymptomatic patients in around 10 to 20%. It mainly affects the young ectomorphic females between the age of 20 and 50, and the male-female ratio being 4:1, primarily treated with surgery. In our case, there was a 20-year-old female who presented to the general surgery department with complaint of abdominal pain and nausea since 2 months and 3 episodes of vomiting in the past 3 days. The pain was persistent and aggravated after the meal, localized at the epigastrium and burning in nature. Pantoprazole therapy was given, but it failed to relieve the severe pain episodes. The vomiting, which was just 3 episodes, were non-projectile and contained food particles and water. The patient has no other history of diarrhea, constipation, burning, maturation, hematemesis, or fever. There was no significant history of weight loss, no other past significant or personal history. On inspection, the abdomen was flat and centrally placed umbilicus with no visible scars and no dilated veins. On palpation, the abdomen was perfectly soft, non-tender, with no guarding and rigidity, with normal temperature and no organomegaly or palpable mass. Tympanic node was heard on percussion. There was no abdominal bruit. Normal bowel sounds were heard on auscultation. CBC, LFT, amylase, lipase, urine analysis were all normal. The USG was done primarily, which was again normal. X-ray with contrast study also was normal, and upper GS scopy was performed, and biopsy was taken for H. pylori, and it was again negative. Then finally, contrast CT abdomen was done. It was suggestive of short segmental stenosis of the celiac artery in its proximal segment with post-stenotic dilatation, made likely representing median arcuate ligament syndrome. There were no other abnormality in the CT. A USG Doppler was also done because we suspected this disease, which showed the peak systolic velocity of the celiac artery more than 200 centimeters per second. The discussion. The median arcuate ligament is a fibrous arch that unites the diaphragmatic crura on either side of the aortic hiatus. The location of the ligament is highly variable, sometimes causing the downward angulation of the celiac trunk, which can be non-obstructive anatomic variation of mesenteric ischemia. MALS was first described by Herzola in 1963, and it is non-specific presenting symptoms, and it is a diagnosis of exclusion. It is due to the celiac trunk compression by median arcuate ligament with ganglionic pre-aortic tissue. Pathophysiology still remains uncertain. It is based on the theory that might be on higher origin of the celiac trunk from the aorta. Other pathology theory remaining the exuberant coat of neurofibrous tissue originating from the celiac plexus causing the compression. The compression worsens with expiration as the diaphragm moves cranially, worsening the compression of the trunk. Sustained compression of the axis may lead to changes in vascular layers such as intimal hyperplasia, proliferation of the elastic fibers in the media, and disorganization of the adventitia. The symptoms are typically postprandial pain associated with nausea, vomiting, and unintentional weight loss. It could be due to the postprandial theft of blood, which causes pain. CTA usually demonstrates a characteristic focal narrowing of the proximal celiac axis with a hooked appearance caused by the inferior displacement of the celiac artery by the median arcuate ligament, most optimally as noted on a sagittal view. Imaging is best acquired during an end respiratory phase where the compression can be identified since cranial distension
Sorry,
of the
doctor, your
diaphragm.
time for presentation is over. Can we start the discussion questions?
Dr.
please?
Vasavda or Dr. Darshan, please.
Very good morning.
Good morning, sir.
Yeah, tell me, man. It's an accidental finding.
No, sir. The patient was symptomatic, and when we did a CT scan, then they diagnosed it on the CT scan, and we can see that in the image that there is a post-injected dilatation and hooked appearance of the celiac artery origin.
Okay. Do you think the CT is reliable?
Better would be a CT angiography, but we cast upon the CT contrast, so then we didn't go forward.
Okay. So it is usually present in which age group of the patient?
20 to 40 actually in young thin females.
Okay, fine. Do you think operative treatment will cure the symptoms?
Not always, sir, but in this patient we have a follow-up for the 6 months, and then the patient did not have the original postprandial pain which she had previous to the surgery.
On which ground? Only CT scan investigation or any other features deciding the operative treatment?
Sir, mainly the symptoms of the patient, CT scan, and the Doppler here also showed the peak systolic velocity was more than 200 centimeters per second. So that we decided to operate the patient.
Okay, fine. Over to Darshan. Jitu.
What is the novelty in this poster?
These cases are very rare, sir, and operating them was.
That is for poster is.
Yes, sir.
That is that is the poster requirement, na? Rare cases have to be presented as posters.
Yes.
So, what is the novelty in this particular case?
What
you have presented.
It was a rare case, and we operated it openly. We did not go for a laparoscopic because.
So, how you are adding to the literature?
That the patient was symptomatically improved. Not all cases of post-operative median arcuate ligament syndrome improve post-operatively.
So what you did over and above what is written already in the literature, so that patient is improved?
Timing for questioning.
I should take as a message now.
Yes, sir. But we removed, sir, we skeletonized the neurofibers, the celiac axis. Around the celiac axis, we have the neurological fibers. We removed that also.
Okay, take it.
Time for questioning is over. We like to move on to the next participant, Dr. Himadri.
Are you there, Dr. Himadri?
Yes.
Okay. Share her slide.
Yes, sir. Just 1 minute. I'll share her screen. Is it visible?
Not yet. There is some lag behind. Don't worry. Okay, great.
Good morning, everyone.
Yes.
Am I audible, sir?
Yeah, clear.
Good morning, sir. I am Dr. Himadri Joshi, third-year resident from the SSG Hospital, Baroda. I am reporting a case of urinary bladder stones due to long-standing catheterization in a 78-year-old male patient. Urethral catheterization is an important aspect of management in case of bladder outlet obstruction. However, if left unchanged for a long time, it can lead to encrustation and subsequent stone formation. This is a case report of 78-year-old male patient with a retained catheter for 1.5 years leading to bladder stone formation. A 78-year-old male patient presented to us with a complaint of burning maturation since last 2 to 3 months. Pain
in suprapubic region since last 1 month, and a dribbling of urine from the surrounding of catheter since last 15 days. Patient has a past history of catheterization 1.5 years back due to acute urinary outlet obstruction at local PHC. After that, there was no catheter change done. He is not a known case of any major medical or surgical illness and having no any past operative history. On examination, indwelling catheter, perurethral catheter was present with pericatheter urine leak and no urine outcome from the catheter on attaching urobag. In per-abdominal examination, there was bilateral direct reducible inguinal hernia present with rest normal abdominal examination and enlarged prostate palpable in per-rectal examination. In investigation, complete blood count, renal function test, liver function test was done, which was normal. X-ray KUB was done, which suggestive of abnormal radio opacity in pelvic region, which is suggestive of bladder calculi. In ultrasound, KUB, prostate, and postvoidal residual, there was approx 4 cm size of bladder calculi within. Bulb of catheter cannot be appreciated separately. An enlarged prostate measures 76 cm with median lobe projecting into the base of bladder. Postvoidal residual was 30 cc. USG bilateral inguinoscrotal was suggestive of bilateral direct inguinal hernia with preperitoneal fat coming out of the defect site. On intervention, there was open cystolithotomy done under spinal anesthesia and multiple bladder stones were removed, which was of different size, which include the biggest stone of size 5 into 3 into 3 centimeter, which is attached to the tip of catheter and it is removed along with the catheter. Suprapubic catheterization was done and prevesical drain was kept and bladder and skin was closed. Post-operative period was uneventful. On conclusion, there is a perurethral catheterization used in management of acute urinary retention, even at the primary care centers. But it is necessary to educate the patient regarding catheter care and timely changing of catheter, as long-standing unchanged catheter can lead to encrustation, stone formation, cystitis, UTI, pyelonephritis, etc. Then surgical removal is the option for long-term block catheter and subsequent stone formation. Thank you, sir.
Okay, good. It looks, what I want to say is your presentation of poster is good. That is the font as of ideal size in a figure and not much clustering. This should be the way of presentation of poster. Your poster gets lot of mark. That is good poster, I would say.
Thank you, sir.
Apart from that, material is okay. So what is it, a rare or a common condition?
Not very rare, sir, but this much long-time catheterization is a rare because generally patient came early. 1.5 years is a very long time, and it is only few cases reported about this much long time of retained catheter, sir.
Which other places you will find similar kind of stone due to retained devices?
Sir, ureter, if stent is there for long
Yes, yes.
Then, sir, gallbladder.
Gallbladder, which device you put in gallbladder?
Any stent there? Any stent there in the gallbladder?
Not, sir, in gallbladder, but cystic duct, sir.
Not cystic duct, beta. We never put stent in cystic duct. CBD, common
CBD,
bile
sorry,
duct.
CBD, sir. CBD, sorry.
CBD. That is rather more common than this.
Yes.
Why
Sir.
stone has developed here?
Because there is a in bladder urine bacterial encrustation occur over the tip of catheter or over the retained part of catheter. And
which type of stone will it be?
Sir, mainly phosphate stones.
Why? Why
Because,
phosphate stone?
alkaline nature of urine leads to the encrustation.
So for urinary tract infection, we give urine alkalizer. Is it a good thing or bad thing?
Sir, it is a good thing, but in this case, it can lead to stone formation if catheter is long standing or foreign
No,
body.
without catheter. Forget about without catheter. So the answer should be, it should be infected urine. That is a very important point.
Okay.
Right? Any foreign body, the infection is the prime source of its rejection.
Yes, sir.
Right? Which other way there can be a foreign body stone formation in bladder? apart from catheter?
Uh,
Is there? Okay. Another thing. Suppose the patient did not have a stone and catheter is inside. How will you remove it then? Bulb is not deflating.
Sir, if there is no stone, then we can first first we can just insert a needle at above the channel from which we are trying to deflate. Then even we can cut the channel line of that catheter from the outside.
That is the message. Never ever cut.
Okay, sir.
What is the best thing to do in present scenario?
Sir, USD guided.
Yes. So that should have been the first answer.
Yes, sir. Yes.
Right?
Thank you for questioning is over. Please, we'll like to go on to the next participant.
Thank you.
Thank you, sir.
Dr. Vishakha, are you there?
Yes, I'm here.
Just give me 1 minute. I will just share your slide.
Dr. Vasavada?
Yes, sir.
You are there?
Yes, sir.
Everything is fine. Any suggestion or anything?
No, sir. Everything is going good.
Please ask. So I will be there, not there for 5 minutes. So next thing you can ask for. Okay, please
100%,
carry
sir.
on. Okay.
100%. 100%. Modi sir.
Okay, thank you. Thank you.
Should I start?
Is the poster visible?
Yes, visible very well, and start. Vishakha, please start.
Good morning, everyone. I'm Dr. Vishakha Limber, third-year general surgery resident at Pramukh Swami Medical College, presenting a case of superficial venous aneurysm of great saphenous vein under guidance of Dr. Jayesh Patel. Unlike arterial aneurysm, venous aneurysm are much rare abnormality. Although found in all major veins of the body, venous aneurysm are uncommon in lower extremity and can be divided into superficial and deep aneurysm, of which superficial venous aneurysm of lower extremity are extremely rare, and their clinical significance has been poorly defined. As this is rare, it can be misdiagnosed as soft tissue mass, inguinal or femoral hernia. Here I am presenting a case of 69-year-old male presented with chief complaint of growing mass over medial aspect of left thigh since 1 to 1.5 months, which were gradually increasing size and presented here with approximately size of 3 into 4 centimeters. Patient also complained of pain and discomfort while walking. He had no any history of trauma, fever, weight loss, or similar swelling in other parts of the body. On examination, it was a single 3 into 4 centimeter swelling, 5 centimeter below and lateral to the pubic tubercle on left side, as shows in image 1. On palpation, it revealed a single, tender, non-mobile, non-reducible swelling with hard inconsistency and normal overlying skin, no impulse on coughing appreciable. Routine blood investigations were normal. USG local part suggestive of a large, well-defined oval, thick-walled outpouching of approximately 3 into 3 into 3 centimeter arising from left great saphenous vein, having no vascular flow on CDFI. Hypoechoic area noted within the lumen with suggestive of thrombotic occlusion. On CT scan, it shows evidence of round, well-defined lesion, soft tissue in anterior compartment of inguinal region, suggestive of aneurysmal dilatation as shows in image 2. Patient has been explained about the surgery. Under left femoral block, a vertical incision was made over the swelling and the mass was identified and excised as shown in image 3. The thrombus GSV was traced up to the saphenofemoral junction and ligated, and the distal GSV was also ligated. Traditionally, venous aneurysm is defined as dilatation of venous segment 1.5 times the diameter of normal segment, proximal and distal to the disease segment. Venous aneurysm is a solitary area of venous dilatation which communicate with the main venous structure by a single channel. Most common location in lower extremity is the popliteal vein. Second most common is saphenous vein. The venous, the most causes are primary, divided in primary and secondary. Primary, that is congenital aneurysm, are caused by weakness in the venous wall, secondary to the inherited conditions such as connective tissue disorder, and secondary is acquired aneurysm, which can be due to trauma, inflammation, degenerative processes, medical stress, or venous hypertension. Diagnosis can be made by gold standard is duplex, investigation of choice is duplex ultrasonography. We can do CT scan and MRI also.
in management, conservative management is indicated for small or asymptomatic aneurysm, while the surgical treatment for large aneurysm, which can be tangential aneurysmectomy, aneurysm resection with primary anastomosis, aneurysm resection with interposition of grafting or ligation of the affected venous segment. Thank you.
Okay, it's really a rare case. Just tell me what might be the reason for venous aneurysm.
It may be because of trauma or any venous hypertension. As in our patient, it was because of thrombus.
Thrombosis causing venous aneurysm, yeah?
Yes, sir. Secondary to thrombus, post-thrombotic syndrome it leads to aneurysm.
Okay. Any intervention was done for thrombosis?
No, sir. We have excised the whole segment.
Okay, okay. What is the chances of the leak? Any case you come across in the literature where a venous aneurysm leaks?
No, sir.
Okay. Have you seen any other venous aneurysm before?
No, sir. This was the first case which we encountered.
Okay. It's a accidental diagnosis, yeah?
Yes, it is an accidental diagnosis, sir.
Okay, fine. Yes, over to Jitu.
Dr. Vishakha,
yes,
what is the incidence of deep venous system aneurysm?
So it is very rare, approximately 2 to 3% only.
That's high. Okay,
Yes.
then because superficial venous aneurysm are easy to manage comparatively. So what will you do for deep venous aneurysms?
Sir, we have to we can do aneurysmectomy, or we have to put graft for deep venous aneurysm.
Graft. Okay.
Yes.
What is difference between varix and aneurysm?
So varix can be pulsatile. Well, in this case, aneurysm was non-pulsatile. It was not impulse on coughing was not present in this case. Well, in
Don't say
varix,
pulsatile.
sorry, yes, sir.
Pulsatile is a
Impulse on
different.
coughing is differential diagnosis. In
Okay.
varix, impulse on coughing is present, while in aneurysm it was not.
So how did you differentiate that it is not a varix and it is aneurysm?
So on clinical examination, varix was disappears on palpation, but it was not disappearing. The aneurysm was not disappearing, and the cough impulse.
Okay, it was in superficial system. So
Yes,
simply get away. Can you do excision and don't do anything else?
Sir, please let this be the last
aneurysm
question as time for questioning is over.
Okay, let her answer this last question.
Yes, sir. Aneurysm, we can excise this aneurysm, tangential.
So what you did?
So we have as our aneurysm is thrombus, we have excised the whole segment.
Okay, thank you. Next.
Thank you, sir.
Dr. Sachin. Dr. Sachin Jivani, are you there?
Yes.
Just give me 1 minute. I'll share your screen.
Answer loud and clear. That is the important part. Sachin, you are there?
Okay, sir.
No,
good morning.
More loudly.
Good morning, teacher.
Yes, that's better.
Myself, Dr. Sachin, second year resident. Today I am presenting a case report of esophageal perforation due to foreign body. Background: esophageal perforation is a potentially lethal condition that can have a poor outcome if there is a delay in diagnosis or treatment. Is causes broadly classified into traumatic and non occurs caused by instrumentation, or in other common cause being spontaneous rupture of esophagus. Diagnosis: high degree of suspicion with thorough clinical examination is enough in majority of cases for diagnosis. Once there is a suspicious diagnostic workup must be processed basis of index of suspicion. Esophagography is a standard for diagnosis, but CT scan with contrast can be used, or patient may require evacuation with a direct laryngoscopy or endoscopy, depending on clinical circumstance. Case presentation. A 60-year-old male patient presented to trauma center with history of accidental swallowing of denture before 2 days in intubated state, with clinical examination revealing subcutaneous emphysema extending up to lower chest wall with bilateral air entry decrease. Before proceeding to tertiary care setup, patient was taken to nursing care where endoscopy was performed, which showed badly impacted denture in upper esophagus. Retread was tried with red tooth and snare, but during the procedure, subcutaneous emphysema was noted, so procedure was amended. On admission, patient was adequately ventilated and bilateral ICD tube was inserted, and patient resuscitated before shifting to operation theater. Intra-op patient was positioned in a left lateral position with right lateral thoracotomy was performed. In intra-op, right azygous vein was ligated at T4 level, and swelling found at T1, T2 level, which 10 to 12 cc tank pus was drained. Approx 5 into 1 centimeter square perforation was found on right lateral aspect of esophagus, which denture with metal band were found impacted, which were meticulously dissected and removed. Esophageal perforation was repaired in intermittent patient with a feeding jejunostomy was performed. Patient was post-operatively elective ventilated up to third post-op day and gradually taper. Post-operatively, significant prolonged discharge from thoracotomy site, which was managed by thoracostomy and regular dressing and higher antibiotic coverage, which was site was repaired primary after 1 month. A patient was discharged after 1 month after esophageal dye study was performed, and which reveal normal esophagus, feeding jejunostomy tube was removed after approx 1.5 months after discussion. Decision between surgical and non-surgical management rest on 4 factors. There are site of perforation, event of causing the perforation, underlying pathology, or status of esophagus before the perforation. For patient requiring surgery, choice is direct repair or deliberate creation external fistula, or sometime esophageal resection with reconstruction or required. Direct repair is performed by many surgeons. Perforation is recognized early, and extent of mediastinal or pleural contamination small. Primary repair is inadvised with late perforation in the presence of widespread mediastinal pleural contamination. These patients tend to be more ill, and as a result of the delay, and the aim of the treatment should be achieve wide drainage with recreation of a controlled fistula and distal and enteral feeding.
Dr. Sachin, your time for presentation is over. I'll ask the judges to kindly ask questions. Hello.
Hello.
Yes, sir. Kindly
Yeah.
ask.
Sachin, you operated on the which ground? Hello.
Sir, patient developed subcutaneous emphysema, and endoscopy was performed outside, which saw foreign body impacted in upper esophagus, or
Okay.
failure during retrieval during endoscopy.
Okay, fine. So this patient is referred from periphery to you, yeah?
Sir, private hospital. From private hospital.
Okay. Usually in what was the finding on operative side?
Sir, 4 by 1 centimeter square perforation, sir, right lateral aspect for present, or sir, denture impact.
Any pneumomediastinum?
Yes, sir. Pneumomediastinum is with pus swelling found. Pneumomediastinum. Sir,
So patient overall
before
condition is
operated,
favorable
sir,
for
we
the
insert
operative
ICD for that for DSC.
Oh, is there any conservative treatment that you may not operate?
Yeah, very correct. Very correct.
Yeah, sir, is if sealed perforation was there, we can with
So
higher antibiotic.
sir is asking what were the ground? Why did you operate? That was the actual question. So tell me 1, 2, 3, 4 like that.
Sir, how sir, pneumoidiastinum was there or unable to retrieve during endoscopy.
Very good.
And subcutaneous emphysema developed, sir.
Was the patient in septicemia or not?
Yes, sir. Yes, sir.
Yeah, that is the one important point.
At the presentation, the patient was on inotropic support, sir.
Support. What is esophagostomy?
Sir, if cervical perforation found, then we can.
Indication of esophagostomy. Okay, fine. What is the spontaneous esophageal perforation?
Sir, it's called a Borau syndrome. Sometime during emesis or hyperemesis or spontaneous rupture.
What is iatrogenic esophageal perforation?
During endoscopy or direct laryngoscopy, sir.
So out of all these three, which is commonest?
Instrumentation.
That is iatrogenic esophageal perforation is commonest. What is endoscopic management of esophageal perforation? Now we are doing pair and everything, so perforation can be managed.
Sir, stenting is esophageal.
One is stenting. Anything else?
Sir, after this question, we would like to move on to the next participant.
Okay, no issue.
After this question.
Okay, Dr. Dikesha, are you there? Please come, go to next. Thank you. Dr. Dikesha, are you there? Okay, anyway, call the next schedule.
Hello.
Yes?
I am here only.
Okay, please unmute yourself, keep yourself unmute and show your photo. Video, I mean. Not the photo. Photo is... Okay, Priya, continue, please.
Dr. Janvi. So, Dr. Janvi, are you there?
Dr. Janvi.
I can't see. I don't think she has joined. We'll contact her personally. By that time, we'll like to get on to the next participant.
I think Hiteshwari is left still.
Yes, sir. Hiteshwari, sir, we'll add her in the end at the end of the session, sir.
Or you can end at the end of poster if she is ready or not ready.
Sir, she is not. She's there. Dr. Hiteshwari, are you there? So she has joined. I don't think she is listening. So we'll call her also.
Okay. So let us move to next now.
So start with paper presentations. Dr. Lakshman.
Okay. For examiner, Dr. Vasavada and Dr. Dikesha. Now we are starting with paper. So it will be 6 minutes for presentation and 2 minutes for judging. Okay.
Okay, sir. Okay.
And the second point is that he will not be allowed more than 8 slides at the most. And if the 6 minute completes and his presentation incomplete, we'll have to stop it. Okay, Lakshman, understand. I think rules has been told you. Let us start. Good. Okay, we are seeing the slides very well, Priya.
Okay.
Okay, Lakshman.
Lakshman, start, please.
Good morning, all of you. I am Dr. Lakshman Bhammar, third year resident from BJ Medical College, Ahmedabad. I am going to present a paper on prospective study of various non-operative modalities of management of rupture liver abscess under guidance of Dr. J.V. Parikh sir and Dr. P.R. Dalal sir. Liver is the commonest solid visceral organ prone to abscess formation. Liver abscess are of two types. First one is pyogenic liver abscess and second one is amemic liver abscess. Pyogenic liver abscess is common in Western country and amemic liver abscess is common in India and Asia country. Until the discovery of antibiotics, rupture liver abscess was fatal. With the advent of newer imaging techniques like USG and CT scan and availability of broad spectrum antibiotic, the mainstay of liver abscess management is without surgery. Laparotomy can be avoided by accurate and targeted percutaneous drainage under USG guidance. The objective of study is to evaluate safety and effectiveness of various non-operative modalities of treatment in rupture liver abscess. Next page, please. Materials and methods. The study was carried out on 30 patients having rupture liver abscess in the Department of General Surgery at a tertiary care center in Ahmedabad between June 2019 to January 2021. Inclusion criteria: all patients with USG or CT finding suggestive of rupture liver abscess, patients managed non-operatively, and hemodynamically stable patients, and patients without feature of peritonitis at admission. A patient who did not give consent for any intervention whenever required, it was not included in the studies. Over liver abscess were treated with percutaneous needle aspiration, and also patients were grouped into 3 categories. First one is patients having only subcapsular rupture of liver abscess, and second one is patient having a rupture into pleural cavity, and third one is having rupture into intraperitoneal. Patient with intrapleural rupture underwent additional ICD insertion, and those with intraperitoneal rupture underwent a USG guided 28 to 32 French closed drain insertion, and patient with subcapsular rupture of liver abscess underwent only percutaneous needle aspiration with a disposable trocar needle of 16 gauge. Persistent symptom even after 3 successful percutaneous needle aspiration was considered as a failure of non-operative treatment. Drain was kept until the cavity was fully evacuated and removed if the collection was nil or minimal in the last 24 hours. If patient had to undergo surgery due to development of peritonitis or persistent or a worsening of the symptoms during the same admission, it was considered as a failure of non-operative treatment. Patients were evaluated with respect to progression or regression of symptoms, length of hospital stay, procedure-related complication, and readmission rates within 6 months. Out of total 30 patients, 20 patients have subcapsular rupture, and 7 patients have intraperitoneal rupture, and 3 patients had intrapleural rupture. In a subcapsular group, 3 patients had a thick pus. So in this patient, the needle aspiration was not possible, and they were managed by pictal catheter insertion under USG guidance. And in 7 patients having a intraperitoneal rupture of liver abscess, 1 patient developed a peritonitis after, in spite of drain insertion, and they were managed by subsequently by abdominal exploration. And this patient was unfortunately died on the post of day 2, and mortality was reported in this group. In a intraperitoneal rupture group, okay, next page. 20 patients underwent a percutaneous needle aspiration, 7 patients underwent abdominal drain insertion, and 3 patients underwent ICD insertion. Average duration of hospital stay was 6.9 days, and average duration of stay was highest in ICD group. Readmission rates were 55% in percutaneous needle aspiration group, 28.57% in abdominal drain group, and 33% in ICD group. 1 mortality was reported in patient undergoing drain insertion with subsequent surgical exploration. From our perspective study, analytic study, it seems that intraperitoneal rupture and intrapleural rupture treated with respective drain along with percutaneous needle aspiration of liver abscess are more efficient and required lesser number of readmission at the cost of longer hospital stay. The PNA only has a less hospital stay, but require multiple repeated admission for the reaspiration. The limitation of study was smaller sample size and short-term follow-up.
Okay, Dr. Vasavada, Dr. DK Shah.
Hello.
Yes.
Hello. Actually, why the abscess ruptured? You just narrate the thing. Hello.
Yes, sir. Hello.
Why the liver abscess will rupture?
Sir, due to the delayed diagnosis of the liver abscess and delayed in the treatment, sir.
Okay. So what steps you will take to prevent the rupture of the liver abscess?
Sir, early diagnosis and early drainage under USG guidance.
Okay, because many times your ultrasound report is suggestive of non-liquefied liver abscess. So what will you do in that case?
Sorry, sir.
In
Sorry,
most
sir,
of
your
the
voice is
cases,
breaking.
in early cases, the ultrasound report is suggestive of non-liquefied liver abscess.
Okay,
In
then.
that case, you may not be able to even aspirate. You are saying
Okay,
that the
sir.
aspiration after ruptured liver abscess, when the pus is thick and you may not be able to aspirate it out.
Then first of all, sir, we are giving, sir, antibiotic coverage, cephalosporin and metronidazole group. Then after the liquefaction of abscess, we are going for aspiration under USG guidance.
What advice you will give to the patient? Because you may not be admitting the patient for the long time. So what advice you will give to the patient? Prevent the rupture.
Okay. Sir, complete the course of antibiotic and on follow up and look for the symptoms like the acute abdominal pain, fever with chills.
Regular follow-up is very essential. Even if you are not admitting the patient should be advised regarding the regular follow-up of the case. Okay. Okay.
What was used as a follow-up? Which investigation tool was used as a follow-up?
Sir, follow-up USG to see the size of the abscess.
At what interval?
Sir, initially it was a interval of, sir, 14 days, and then, sir, every month. Sir.
So did you also notice what was the status of colon on right side colon, particularly cecum
Yes.
and ascending colon?
Yes, sir. In approximately, sir, 30 to 40% patient have a, sir, ileocolitis.
Ileocolitis. So what is the impact of that on your study? Means, does it change your management pattern or same?
Sir, management pattern was same, sir. Instead of keeping patient initially NBM, sir, for 2 to 3 days, sir.
Okay. Was there any perforation in any case?
No, sir.
There was no perforation, cecal perforation, I want to say, which you might have used as exclusion. Okay.
No, sir.
What was the duration of drain you kept? Mean duration. Means suppose in one patient
mean
you have to
duration
give
of
5
that-
days. Yes. For how long average? You mean the mean duration of drain you had to keep. Am I audible?
Yes, sir, you are audible.
I think he has lost voice. What
There is
happened?
he is frozen, sir, some internet connection. I think.
That is the problem.
Hello.
Okay. Yes. Answer it, please.
Sorry, sir, I could not hear the.
So what was the mean duration of drain cap? Whether it is a pigtail or abdominal drain? Total average duration.
Sir, longest duration is, sir.
No, that is the longest may be 5 months, shortest may be few days. I mean to say when you are presenting a paper, mean duration, average duration, that is important.
Okay, sir. Average duration is, sir, abdominal drain is, sir, 6 days, sir. And
6
in,
days.
yes, sir.
Okay. And
sir, ICD group, sir, average duration is, sir, 8 days.
Okay. Thank you.
Thank you, sir.
Dr. Aditya.
Good morning. Good morning, teachers. Am I audible?
Yes.
Is your presentation visible?
Yes.
My today's paper presentation is on observational retrospective clinical study regarding management of locally advanced carcinoma breast at Tertiary Hospital of South Gujarat. I am myself Dr. Aditya Bareya from GMC Surat. Next slide, please. Locally advanced breast carcinoma is a subset of breast cancer characterized by most advanced breast tumors. It includes large breast tumor measuring 5 centimeter, more than 5 centimeter in diameter, and tumors that involving skin of breast or underlying muscle of chest, and cancer that involves metastatic metaed ipsilateral axillary lymph node
and inflammatory breast carcinoma. Although likelihood of curing locally advanced breast carcinoma is lower than it would be if cancer were small and confined to the breast, still cure is possible with aggressive treatment. In most cases, this requires combination of chemoradiotherapy and surgery. Our aim is to find out effect of neoadjuvant chemotherapy in management of locally advanced breast carcinoma. This was an observational retrospective study of 40 cases of LF in Tertiary Care Institute of South Gujarat from May 2020 to April 2021. Stage 3 AJCC stage 3 locally advanced breast carcinoma were included, and female who have taken chemotherapy and radiotherapy in this very much institute of New Civil Hospital Surat were included, and patients who have not taken chemo radio at our institute were excluded, and case paper of locally advanced breast carcinoma admitted in 1 year was analyzed, and if information was inadequate or data was missing, these patients were excluded from the study. Next slide. Data collection from indoor case sheet from record section of institution was done, and information regarding finding of history, clinical examination, radiological examination, histological result, and response to neoadjuvant chemotherapy with its complication and operative management in form of modified radical mastectomy was done. Next slide. In our study, most of the patients belong to 41 to 50 year of age group. 65% of patients were in this age group. Second was 31 to 40 year age group. And in consideration of a gonadal activity, most of the patients, 62.5% patient was postmenopausal. And most common symptom was breast lump, followed by pain at lump site, and nipple retraction was third most common. Next slide, please. And according to description of tumor, most patient presented at T3 level, that is tumor lump palpable more than 5 centimeter in diameter, and nodal stage, N1 stage was most common at presentation, and most of the patient responded to neoadjuvant chemotherapy with partial response, that is more than 50% of size reduction, and only 10% patients showed complete response, that is complete disappearance of lump. And most common morbidity after surgical intervention, that is open close MRM, was surgical site infection followed by flap necrosis. Next. Management of locally advanced breast carcinoma remains a clinical challenge, as the majority of patients with diagnosis develop distant metastasis despite appropriate therapy. Patients with locally advanced disease encompass a wide range of clinical scenario, including advanced primary tumors, that is T4, and advanced nodal disease, that is fixed axillary nodal nodes, and involvement of ipsilateral supraclavicular, infraclavicular, and internal memory nodes, and inflammatory carcinomas. The prognosis of women with locally advanced breast tumor are also heterogeneous and depend on tumor size, extent of lymph node involvement, and the presence or absence of inflammatory carcinoma. Successful neoadjuvant chemotherapy will shrink the tumor before surgery, making it easier to operate. This treatment will also decrease the chances of recurrence, and for a small number of women, having neoadjuvant chemotherapy may allow them to have breast conserving surgeries such as lumpectomy rather than a mastectomy. Next slide. Maximum number of cases with locally advanced breast carcinoma belong to age group between 35 to 54 years of age. Considering the literature, with the maximum incidence of CA breast in Indian women belongs to the age group of 45 years, with age group maximum patient were of perimenopausal period. The mean age was 45, which is comparable with other study. And in present study at first visit, 36% cases were premenopausal, while 63% were postmenopausal, which was also comparable with previous other studies conducted by other researchers. And in the present study, maximum case belonged to T3 stage, that is 56%, while T2 and T4 were 26% and 16% respectively. while in study, other study conducted, T3 was T3 stage was 37% and T2 and T4 were 4 and 57% respectively. And in present study, about 93% of cases responded to neoadjuvant therapy. That is 10% patient showing complete clinical response and other 83% patient showing partial response. Only 7% patient were non-responder. That is less than 50% size reduction in tumor. And next slide, please. To conclude, in our study, most common presentation of patient at admission was T3N1, that is stage 3A, and greater portion amongst them were subjected to neoadjuvant chemotherapy, followed by modified radical mastectomy, and majority of patients subjected to neoadjuvant chemotherapy responded partially to it. Above mentioned observation and results suggest that most of the locally advanced breast carcinoma respond to neoadjuvant chemotherapy with minimum post-operative morbidity and mortality.
Okay. Aditya, what was the biggest problem with your paper? See that you have talked a lot about observation. I did not understand a single thing. So your presentation was very poor. There should be a chart, graph. That is the basic concept of paper. Do you understand?
Yes,
just
sir.
go on describing as an essay is useless. I did not understand anything what you were talking about, right? So that is the one important point. When you are presenting a paper, there should be a lot of the boxes, graphs. So it should be immediately will catch the eye of your examiner or whoever is grading. So that way you will get for presentation, I think not more than 1 or 2 marks. That was a very poor presentation. It should be properly displayed. You saw the last paper there, you showed a graph, so I can understand out of this. Second question is, what was the bias in your paper?
Sir, we can get observer bias that neoadjuvant chemotherapy will always benefit the patient.
No, that is the observation. Bias means you can call it negative part. So was it the same chemotherapy in all patients?
Yes, most patients were.
No, there is nothing like most patients. It should be exact number in paper.
Sir, patients were undergone cyclophosphamide and erythromycin neoadjuvant chemotherapy.
Have you mentioned it in your paper?
No, sir, I have not mentioned.
Why? Is it not important? Which anterior chemotherapy patient gets?
Yes, sir, it is important.
Because the type of chemotherapy, so you have not mentioned, that is a bias. Do you understand?
Yes, sir.
If patient has taken different kind of chemotherapy, you have to exclude them. Because
Yes,
it should be same chemotherapy, then only you can reach to some conclusion. Because the response of individual chemotherapy was different. One more point. Did you also consider histopathological part, ERPR and ploidy study in favorable, unfavorable? One more point is, did you consider for a diagnosis, which tool was used for a diagnosis?
For diagnosis, sir, true cut biopsy was used.
So in all patient true cut biopsy was done?
Yes, sir. All patients were subjected to true cut biopsy to determine the hormonal.
Did you consider the histopathology of that patients in your study? Because some will have an aggressive tumor, some will not have an aggressive tumor.
Yes, sir.
Was mammography done in all cases?
Yes, sir. Bilateral sonomammography was done on all the patients.
So was it considered as a part of deciding factor or not?
Sir,
so you understand that there were so many biases in your study.
So can we please move on to the next participant?
Okay, thank you, Aditya.
Thank you, sir.
Dr. Dharmesh, are you there?
Yes, I'm there.
Okay, just.
I am here, madam, only.
Sir,
yes,
Dr.
both
Dharmesh
Dharmesh are there.
Kahan,
Don't
please.
worry.
Oh, there is two Dharmesh. Sorry.
Yes, sir.
She will not call you Dharmesh, Dr. Vasavda. That's why I was specifically saying Dr. Vasavda.
Yes, sir. Yes. Sorry.
Priya, his name is Dharmesh Vasavda. So
Yes,
just don't worry. Okay, fine. No
Is it
issue.
visible?
Yes, very well. You are conducting very well. More than what we did in dry run. This looks very smooth. Thank you.
Kindly please start, Dr. Dharmesh Chauhan.
Yes, sir. Good morning, everyone. I am presenting a paper on a retrospective study of a different approaches to management of cholelithiasis in tertiary care hospital. Myself is Dr. Dharmesh Chauhan. My co-author is Dr. Rohan Ariwala, Senior Resident, and Dr. Devendra Chaudhary, Associate Professor, and Dr. Nimesh Verma, Professor and Head of GMC Surat. Introduction. A common entity in the Western society, gallstones are found in approximately 15% of adults. CBD stone have been noted in 10 to 15% of patients with cholelithiasis. And this incidence increases with the age over the 80% in those who are more than 90 years of old. Biliary stone are mainly classified into the three groups, like the cholesterol stone, mixed stone, and pigmented stone. The objective of my paper study is to determine the various modes of presentation, various treatment options available for the disease, and the various effective outcome of the surgical treatment by means of recurrence or operative complication. Next slide, please. My inclusion criteria is the all patient presented with the common bile duct calculi managed in the Department of General Surgery at Tertiary Care Hospital with the age group of 16 to 18 years of age or with or without comorbid condition. All the data, clinical presentation, investigation, procedure findings are all collected from the case papers retrospectively, and all data is compiled and results are analyzed. Next, these are my observational. And the most common my observationally and the age-wise distribution, mainly my all present patients presented in the all age group, mainly 50 to 70, age of 50 to 70, 22 patients are presented. Out of 50 patients, 22 patients are presented with the complaint of CBD calculi and the abdominal pain. In the 70 to 80 age group, only 4% are presented. In the younger age group, there is a less number of patients. This is my observation age-wise. On the presentation, all 50 patients are presented with the abdominal pain, and only 25%, approximately 25% presented with the vomiting, and only 6% presented with the fever, jaundice, and nausea and other symptoms. In the operative procedure performed, we have the two options. The first is the ERCP followed by laparoscopic cholecystectomy or open CBD exploration with choledochoenterostomy. After 50 patients, 33 patients are managed with the ERCP followed by partial laparoscopic cholecystectomy, and 16 patients presented with the open CBD exploration. After the operative procedure, the complications are the pancreatitis, perforation, retained stone, bile leaks, wound infection, and sepsis. Most common complication in my study is the wound infection after the open surgeries mainly. And the retained stone in the two patients. After the 50 patient retained stone in the two patient. In the discussion part, in the my present study, 64% are in the female. And the compared to two other study like a Desai and Manimaran study, it is approximately one the same. The 55% and 43% in the female patient. In the comparison of presenting complaint, abdominal pain, jaundice, vomiting, and fever. Compared to Desai and Sukon and Manimaran, my study data is almost similar, except the jaundice part. Jaundice is less presented in the my study, while in Desai and Manimaran, there is a jaundice ratio is slightly higher. In the ERCP procedure, ERCP guided laparoscopic, ERCP plus laparoscopic cholecystectomy. In the my study, 66% patients are operated with the ERCP and laparoscopic surgery, while in Desai and Sukhoi, 35%. Because in Desai and Sukhoi, they have operated with the laparoscopic ERCP, laparoscopic CBD exploration, which is not as far available in the our institute due to the lack of instrumentation and all. That's why we have a more number of ERCP with laparoscopic cholecystectomy rather than the laparoscopic CBD exploration. In the complication of the study comparison, the retained stone, cholangitis, bile leak are almost the same, except for the wound infection. Wound infection is more in my study, while in Marimaran study, in the 9% cases, there is a wound infection. The female preponderance reflects.
Dr. Dharmesh, I'd like you to conclude, please, as the time is over.
Yes, sir. In my study, mainly the ERCP guided endoscopic management is the most commonly specific and sensitive, as well as it is the diagnostic as well as the therapeutic for the clearance of CBD stone. Endoscopic method has successful rate of 80 to 90% with the duct clearance and proper expertise. And after follow ERCP, we can follow with the laparoscopic cholecystectomy to prevent the occurrence and recurrence of the episodic symptomatic cholelithiasis.
Okay, thank you. Dr. DK Shah, Dr. Vasavada, please.
Hello.
Yeah.
Yes.
Hello. Hello.
Hello. Dharmesh, can
Yes,
you?
Yeah. Hello.
Yes, sir.
Hello. Tell
Hello.
me, what is the reason for open CBD exploration? What is the main indication you preoperatively decided?
Yes,
We
sir.
explore
Preoperatively
CBD.
decided, sir.
What is the
Because
main reason for it?
because of, sir, we are unable to retrieve the stone ERCP guidance. There is a large impacted stone which is not retrieved on the ERCP, and there is a problem in the ERCP guided stenting due to the fibrosis, or stent is not placed properly, or we can not able to clear the CBD ERCP guided.
It's ERCP failure followed
Yes,
by
sir.
open or directly open?
ERCP failures in most of the cases. So my study after the almost 16 cases, 12 cases are ERCP failure, and the 4 cases we have operated after the before ERCP guided, we have planned for open only.
Okay.
Hello. Hello.
Yes.
Dharmesh, have you decided in which case you are going to do ERCP?
In the sir, yes, sir. In the preoperative investigation, the cases of CBD calculi with the CBD diameter more than 7 mm, which is most probably suggestive of CBD calculi or CBD slush, or alkaline phosphatase level is raised. Alkaline phosphatase level is raised. We have planned for the pre-op ERCP.
Have you done MRCP in any case?
Good question. I was going to ask same.
So I have no data available for that, sir, in the retrospective. MRCP.
Why MRCP should be done?
For the anatomical anomalies, to rule out anatomical anomalies or any aberrant vessel or aberrant ducts along with it.
No. Suppose if the patient has stricture lower part, and you may not be able to negotiate. So in that case, if you do the MRCP, you can able to judge whether there is actually stricture is present or some other malignancy is present or not.
Yes, sir.
After how many days did you do lab choline after doing ERCP?
Within 48 hours.
All cases?
Yes, sir. All cases within 48 hours. Sir.
So was there any complication of ERCP?
And in the ERCP complication, there is a pollen.
No. In your patient.
In my study, sir, only sir fever, sir.
Only fever. So what is the ratio of ERCP complication? Suppose you send 100 patients for CBD stone for ERCP.
Yes, sir.
So what is the ratio? Percentage wise, how many percentage there will be likelihood of the complication? Second question is, in all the ERC patients, stent was put?
Yes, sir. In over ERCP patient, stent was put, sir.
Okay. Did you have to convert any patient taken for lab choline?
Yes, sir. In the 3 to 4 patients.
No, 3 to 4. This
open.
is
no,
you should say
4
exact.
patients, sir. We have converted 4 patients in the.
So you have shown that data. It is there.
Not in my paper, sir.
Not in your paper. It's not part of your paper.
Yes, sir. Yes, it is part of.
Why not? It should be part. The conversion is also part of modality of treatment. And what was the cause of conversion?
Due to difficult separation on the calloid triangle.
No theory. You said 4 patient had. So what was the cause? 1, 2, 3, 4.
Can you please move on to the next?
Okay, thank you. Dharmesh Chauhan and Dharmesh Masavda.
Yes, sir. Yes, sir.
Thank you. Next.
Dr. Rohan, are you there?
Yes, ma'am.
Okay, just give me 1 minute.
Till now, very smooth running. Dr. DK Shah, what do you say?
Yeah, absolutely. Good presentation, and I enjoy this.
And that is very smoothly running. Good work.
Very smoothly running. Very good arrangement has been done.
Yes. Apurva is the person. He is the key person.
Really, I appreciate his effort.
A lot of effort they had gone, and these 4 residents, they are doing tremendous job. Okay, let us start.
Is it visible?
Good morning, everyone. Good morning, everyone. My topic is a prospective comparative study of closure of clean operative wound by zip closure method versus subcutaneous method and staplers. Myself, Dr. Rohan Sachdev, a third-year surgical resident from GMC Bhavnagar, and my PG guide is Dr. Samiram Shah, head of Department of General Surgery and Sarti Hospital, Bhavnagar. Please next. Abstract main introduction. In this era, the one of the most important outcome of the wound. Sorry. In this era, the one of the most important outcome of the wound repair is cosmetic appearance of the scar. The goal of surgery is to achieve such healing with minimal edema, no any discharge or infection, or minimal scarring. Closing a wound in infant differs from the elderly patient with comorbidity or any thin skin. Skin itself varies throughout the body in terms of thickness, elasticity, speed of filling, or tendency to scar. Suture techniques that avoid the suture mass, such as railroad tracks, especially in the skin exposed in the normal clothing, are generally more aesthetically pleasing to the patient. In selection of the suture, patient's health status, age, weight, and comfort, and the presence or absence of infection are the most important biomechanical properties of the suture. Individual with this characteristic anatomical location or surgical preference to the experience in handling the suture material, this is more often appropriate method of closure. In this present scenario, people are aware of various diseases and modalities of treatment available in the market. People avail treatment at very early stage of the disease, expect a best outcome in terms of disease treatment and cosmetic appearance. Clean skin closure is the last step of surgery, where much time should not be spent as to avoid unnecessary exposure of the anesthetic risk to the patient. The ultimate responsibility for the choice of best material lies within the surgeon. In view of that, we decide to study the various skin closure technique in surgery with aim of which type of the wound closure is best, fast, simple, tension-free, with no any adverse reaction, with protective barrier to the pathogen, has simple in postoperative management, suture removal, and cosmetic appearance of the scar. Next. I studied this study in Sarti Hospital, Bhavnagar from June 2020 to October 2021. I have taken 30 patients and divided into 3 groups: Group A, Group B, Group C. Group A being to be zip closure method, Group B being to be stapler method, Group C being to be skin closure by subcutaneous method. I have taken follow-up and I have taken inclusion criteria. I have taken inclusion three inclusion criteria with normal patient with normal blood coagulation profile, patient with including clean operative surgical wound, and patient age more than 18 years. Exclusion criteria. There are 3 exclusion criteria: patient with non-allergic skin disease, patient having keloid formation or any scar hypertrophy, patient having immunocompromised status, patient age 18 from 80 years are going into clean operative surgery are included. In the pre-surgical visit, we exclude the patient do not meet this criteria or condition the investigation deemed to be ineligible, or patient without capacity to give information consent. Before the surgery, patient received a skin preparation with beta scrub solution. Subcutaneous tissue was closed by absorbable interpreted suture. Patient were randomly designed to give these 3 conditions: skin in Group A, zip method; Group B, skin stapler method; and Group C, where skin closed by subcutaneous method. Next. I have taken the photo. I have taken this photo for zip closure method, which is patient will randomly distributed by envelope method, and at the time of surgery, each enrolled patient to be selected. Patient satisfaction regarding the method of incision closure was the primary endpoint at the hospital discharge. And after the post-operative day 14, patients were asked about more extensive about incision-related questions regarding pain, comfort, wound, anxiety towards the discharge device removal, and overall satisfaction with the wound closure method. I have taken feature exact test and student test for the statistical analysis. Result. In my result, group mean age of Group A is 39, Group B is 52, and Group C is 51. In Group A, male patients and female patients are equal. Group B, 80% are male patients and 20% are female patients. Group C, 90% are male patients and 10% are female patients. My objective of the study is, first objective is time required for the skin closure. Mean time of zip closure method is around 2.24 minutes. For stapler method, 5.4 minutes, and subcutaneous method for the 8.8 minutes. So time taken for the zip closure method is less than compared to stapler and subtutorial method. For the postoperative pain, I have taken the VAS score to evaluate the postoperative pain. In my study, p-value is less than 0.05, which was significant. So on the basis of VAS score for the pain, zip closure method is better in skin closure compared to the stapler and subtutorial method. In the postoperative complication and hospital stay, there is no any significant difference in postoperative complication in and hospital stay, because there are so many postoperative complications. We can't say which one is better in postoperative complication and hospital stay. In appearance of the scar and after zip removal or stapler removal, in my study, p-value is less than 0.05, which was shown significant difference. Appearance of scar after zip or stapler removal and subtutorial method discussion. The result.
Dr. Rohan, kindly skip to the conclusion as we are running short of time.
Okay, ma'am. Conclude. In my conclusion, zip method is more preferable option on closing of surgical incision, easy in speed of incision, no need of removing suture and bandages, similar incidence of postoperative complication, less discomfort in patient, and better cosmetic result in wide spectrum of surgical areas. Thank you.
Hello, Rohan.
Yes.
Hello, I want to ask you, what are the limitations of study?
Limitation of studies not included the contaminated wounds, contaminated surgery like obstruction, perforation, or any cellulitis and STSC dressings.
No, actually, number of cases are also too small. And one more thing I want to ask you, whether you have taken the length of incision into consideration, because you have considered time taken. So have you considered what is the length of incision also?
Approximately 5 centimeter incision I have taken, and I have compared all the 3 groups.
So only 5 centimeter incision.
I have taken on average 5 centimeter incision.
In all the groups, it is 5 centimeter?
Yes, sir.
And what regarding the obese patient?
Obese patient.
Do you think 5 centimeter incision is too small incision for any general surgical procedure?
Yes, sir. But on average, I have taken. There are various incision in centimeter, but I have taken on average.
Which surgery is commonly done with the 5 centimeter incision in the abdomen?
Hernia.
I don't know. Another question: what was the cost? Have you considered cost factor?
Yes, sir. Zip closure method is one box. In one box, there are 20 zips, and cost is about 20,000.
20,000. So suppose you put in a appendicectomy incision, what will be the cost?
It will be 1,000.
1,000. Okay. So have you any picture of actual result? Because we are talking of result as far as cosmetic is concerned.
I have this in my mobile, but I have taken does not enter in the slide.
Why? Not good?
No, yeah, it is good.
But that is what was the aim?
My aim
you
is
are comparing with stapler and zip. So cosmetic is rather one of the most important factor.
Yes.
Second, I think what advantage you are saying is a time factor.
Yes.
How come you can apply the zip in 2 minutes?
How can I apply?
So you said that it is even a speedier than stapler in
Yes,
your
sir.
study. So it takes
Sir,
that much less time.
Sir, in zip, there are only you have to apply and you have to remove the gum and you have to just apply.
So you think if it is a larger wound, will it be possible to apply gum within 2 minutes?
Yes, it is possible in larger one.
Okay.
Sir, please let's move on to the next participant.
Okay, thank you.
Next participant is Dr. Roshan Walvi. Are you
Yes,
there?
ma'am.
Yeah, okay.
Yes, ma'am.
It was interesting, huh, Vasavada? I think actually, yes.
Very interesting.
The point here is well taken that yes, it is one of the newer one, but actually the jeep is recommended for a whole abdominal wall closure. rather than for skin. So there is a special zip available and which has its own indication. This is for resident. For a skin closure, it is one of the method. It is a superiority still to be proved over the other method of skin closure.
And
one
sir,
more point. Yes.
Meaning of the zip is different. Purpose of the zip means you have to reopen the thing frequently. That is a
exactly.
zip.
Exactly. So it is a misnomer, company misnomer. Right. One more point, he has not compared with the simple suture. I think he has used as an exclusion criteria. Okay, thank you.
Dr. Roshan, kindly begin.
Okay, sure. Good morning, everyone. Good morning, judges. Good morning, my fellow residents. My topic is to compare central venous catheter and peripheral intravenous catheter in patients of laparotomy as an observational comparative study. Me, as a presenting author, I'm a third-year resident in General Surgery Department at GMC Bhavnagar, and my PG guide is Dr. Firdaus Dekhaiya, Associate Professor at the Department of General Surgery, Sarati Hospital, Government Medical College, Bhavnagar. As the introduction part, laparotomy is a major surgical procedure involving an incision through the abdominal wall to gain access to the abdominal cavity, and the patient undergoing laparotomy must be pre-optimized in terms of IV fluid, blood products, parenteral nutrition before operation, during operation, and post-operative period also, to provide IV fluids and the other drugs, nutrients, safe and dependable intravenous access is a necessary thing, which may be in peripheral veins or in large central veins in form of two types of intravenous catheter. Peripheral intravenous catheter or central venous catheter type of access is selected on basis of duration of intravenous therapy, type of medication or solution, and patient's specific consideration, both of them having advantages and complications. The most commonly used catheter for central venous access is 3-lumen catheter. They are preferred particularly in ICU patients for their free infusion channels to allow for the multiple therapies to be administered simultaneously. A peripherally inserted central catheter or PICC line is a central venous catheter inserted into a vein in the arm via basilic or cephalic vein. The basilic vein is usually better target for cannulization, as the cephalic vein is larger and runs a straighter course through the arm. Complications like infection, phlebitis, extravasation, infiltration, air embolism, hemorrhage, and formation of hematoma or bruise. Complications of central venous catheterization include arterial puncture, hematoma, hemothorax, pneumothorax, arterial venous fistula, air embolism, nerve injury, as well as infection and thrombosis. Methods. A prospective comparative randomized study was conducted on patients of laparotomy in the Department of General Surgery in Sarati Hospital, Government Medical College, Bhavnagar. Sir, I would like to correct here, is from March 2019 to October 2020 to March 2020. 50 patients of scheduled laparotomy surgery who required intravenous access in the form of central venous catheterization or peripheral intravenous cannulation were taken up for the study. The patients were randomly allocated to one of the two groups, 25 in each group. Patients of first group had central venous catheter, while patients in second group has peripheral intravenous catheter. It was conducted in our hospital. Inclusion criteria is patients undergoing laparotomy in general surgery department in Sarati Hospital, Bhavnagar, who has been put peripheral or central venous catheter, who are between age of 18 to 80 years. Exclusion criteria is patient already is known case of any coagulopathy in patient having pregnancy or skin infection at the insertion site. All patients were randomly assigned in two groups, Group A and Group B, using online random number generator, which is commonly used for such research purpose. This study was done in consultation with independent statistician. Patient was a group A was subjected central venous catheter, and patient of group B was subjected to peripheral intravenous catheter. Evaluation parameters: lifespan of central venous catheter and peripheral venous catheter from the date of insertion to the date of removal, hospital stay of the patient by the data obtained from the date of admission and date of discharge, and the rate of the complications were assessed in 25 patients with peripheral and 25 patients with intravenous, central venous catheter undergoing laparotomy was observed from time of insertion to the removal on every alternate day, followed with examination was done for the complications like pneumothorax, hemothorax, thrombophlebitis, extravasation, arrhythmias, any hematoma, cellulitis, catheter dysfunction, or catheter-related bloodstream infection. Statistical methods applied was Microsoft Excel spreadsheet was used for numerical data reports, and standard deviation and mean was got from that, and categorical variables were reported as number and percentage. Students t-test was used to compare the numerical variables, and chi-square test or Fisher's extract was used to categorize the variables. For all statistical tests, a p-value was less than 0.05 was taken to indicate the significant difference. The results, the study carried out in Sati Hospital and the Government Medical College Bhavnagar between March 2019 and March 2020 of 50 patients were divided in two groups. As we can see the age-wise distribution, in group A, the most patients were in the younger age group, and in the group B, the patients were more or in the middle age group from 41 to 60 years. In present study, the mean age of group A was around 20 with a 14 standard deviation. The group B was 19.2. The difference in the age between central venous catheter and peripheral venous catheter was not statistically significant, as both groups were with comparable with respect to age, as all were the adults. Most of the subjects in group A belong to 18 to 30 years, and the group B belong to 30.
We'll go on to the conclusion of the paper.
Okay, for that I will need this graph, the lower one. When we talk about the complications that was associated with the insertion of these catheters, we can see that the peripheral venous catheter has more complications related to it as a. Sorry, sir.
Go on.
Okay. As major complications were more in peripheral venous catheter, such as thrombophlebitis and cellulitis, whereas hematoma and phlebitis was also there. Rate of major complications in group A, which are central venous catheter, was lesser as 12% as compared to 40% in group B. Rate of intermediate complications was also higher in
kindly stop. We'll go on to the questions, please.
Yes.
Okay, sir.
You stop the screen ready. So what was the aim of your presentation?
So just to compare the central venous catheter and peripheral venous catheter in our planned operations of laparotomy, sir. As which is better.
Okay, what is your conclusion?
So conclusion, central venous catheter are superior in the patients of laparotomy, as we need a trained profession to insert the peripheral venous catheter, and is also difficult, and its lifespan is also short, just like a IV cannula is 2 to 3 days.
I don't understand. In any circumstances, central CVP is always better.
Yes, sir.
What is the disadvantage of CVP? Have you highlighted it?
Yes, sir. Main complication, disadvantage of CVP is, sir, also we have to be careful about the complication like pneumothorax or hemothorax or any
So in your study, how many patients had a pneumothorax?
Sir, two patients, sir. One was.
How many had a hemothorax?
No, sir. Hemothorax was not a pneumothorax.
What was how many patients had a fever?
Fever, sir, for central catheter, central.
Central. We are talking of CVP. I am just talking of CVP.
Sir, wait a second, sir.
No, it's okay. Just offhand.
Well, sir.
Okay. So how did you differentiate that fever from local wound infection? Because you are talking of laparotomy.
Yes, sir.
So,
sir, the post of fever for the wound infection would be on the 4th or 5th day of post op day, sir.
Okay. What was the length of CVP catheter you used?
The central venous catheter of 4.5 watts, sir.
I'm talking of length.
Length.
Which different length CVP catheter comes?
Sir, there are, in our hospital, sir, there are only two lengths available. One is 3.5.
Tell me the length of those both.
Sir, in adults, there is 15 centimeters.
Are you sure? Are
Yes,
you
sir.
sure?
Sir.
Okay. So how many you use the jugular and how many you use the brachiocephalic?
Sir, as of sir, we mostly prefer the.
Sorry, I mean subclavian. I'm sorry. Okay.
Sir, we prefer IJV more as subclavian has a higher.
Number. I want number because this is paper. I want number.
One second, sir. 1 second. In this
Okay.
study, sir.
Please move on, Priya.
Thank you. Next, I'd like to call Dr. Virang Shah. Are you there?
Yes, I am there. Here. Can I audible?
Yeah, you are audible. Just give me 1 minute. I'll share your presentation.
Okay, no problem.
Just give me 1 minute. Yeah. Is it visible?
Not yet.
Not yet.
Now is it visible?
Yeah.
Yes, it's visible.
Okay.
Can I
Great.
start?
Continue.
Yeah.
Can I start?
Yes.
Please.
Myself, Dr. Virang Shah, third year resident doctor at Swimmer Hospital. I am presenting a paper on surgical site infection at tertiary center under guidance of Dr. Harish Chauhan sir at additional professor Swimmer Hospital, Surat. Introduction. 100 million of people around the world undergo surgery each year. Infection of the surgical site is a consequence of surgery, but it is not inevitable. Surgical site infection are the commonest nosocomial infection and are responsible for the morbidity, mortality, and significant.
Virang, stop just a minute. Just keep introduction.
Okay,
Do you understand?
sir.
You will not have more than 6 minutes, so the important part will be missed. Introduction should be a 1 or 2 line. You are, I think, whole paper will be introduction then. Okay, same thing for material method. Again, the same problem. Priya, do not include this is in presentation. I'm just again the same problem. Can you see that what you are going to talk? There is an essay there. No examiner will be able to see what you are. So you have to change when we are in online platform. The slide should be presentable very well. Here he has written whole essay. I can see only one, that is 37 case. Nothing else I can appreciate. Right? So it is the important part of your presentation. Your material may be great, but presentation, we give an organization, we give 20 marks out of that. So this is the important for all, for future. It's all right, doesn't matter. Your time is not started yet. So understand, as far as possible, skip the introduction. Don't give. And even your name is sufficient. Don't speak name of all teachers and we can see it. Do you understand? And that is cut from your time. So for a next session, it should be very important that presentation, you have to practice it beforehand. Am I right, Dr. Vasavada?
Absolutely right.
Yes, sir. Yes, sir. Very
so the
clear.
point here is that I cannot understand what he is talking about, but it should be very clear and never essay. It is when you are presenting PPT, it should never be an essay. Okay, please start again. Now, now your time starts now.
Okay, sir. Can I start from materials and methods?
Yes.
This study was conducted in Department of General Surgery in a tertiary care hospital. Elective and emergency general cases were taken up for study. Surgeries on several immunocompromised patients with incomplete primary closure of the wound and relook surgeries were excluded from my study. A total number of 150 patients admitted in general surgery wards for elective and emergency surgery in the study period, out of which 100 were elective cases and 50 were emergency cases, fulfill our study criteria. Surgeries were classified as a clean, contaminated, and dirty wounds. The elective surgery fall under first two categories, while emergency procedure came under the contaminated and dirty wounds. All patients received preoperative antibiotics, injection of aminoglycoside and metronidazole 1 hour before surgery. Total 37 cases had surgical site infection, which had taken up for this study. An elaborate study of these cases with regard to date of admission, history, clinical feature, type of surgery, emergency or elective, preoperative preparation, type of incision, contamination, procedure done, intraoperative findings, drain used and its type and duration of operation, and post-operative management and post-operative finding, which which included day of first dressing and frequency of changing of dressing, day of wound infection, signs of wound infection were noted, which included fever, edema, discharge type, and color of exudate till patient is discharged from the hospital, and then follow patient for 6 weeks on OPD basis for any signs of wound infection. All patients with discharge of wound culture and sensitivity of the discharge was done and treated accordingly. Results. In our study, the overall post-operative SSI rate in elective clean and clean contaminated cases is 70% and emergency cases is 40%. It shows that the superficial surgical site infection are the commonest type and accounted for about 52.94% in elective and 60% in emergency of all the SSIs, and deep surgical site infection accounted about 23% in elective and 30.55% in emergency cases. There is a age-wise distribution of elective and emergency surgeries. 26% under age of 20 years undergone elective surgeries, and 12 patients are emergency surgeries. 29 patients are in age group of 21 to 40 years, and 16 patients are in age group of 21 to 40 years. In age group of 41 to 60 years, 23 patients in elective surgery and 12 patients in emergency surgery. More than 60-year age group, 22 patients in elective surgery and 10 patients in emergency. Total 100 patients for elective and 50 patients for emergency surgeries. Age-wise distribution of SSI. In age of less than 20 years, 3 patients in elective surgery got SSI. 20 to 40 year age group, 4 patients in under elective surgery goes to SSI infection. 40 to 60 year age group, 4 patients have SSI in elective surgery, and more than age of 61 years, 6 patients goes SSI in elective surgery. There are 17 patients, total 17 patients in under elective surgery gets SSI. In emergency, 20 patients goes SSI. Elective for based on superficial deep and intra-abdominal abscess. 9 patients patient have superficial SSI, deep 5 patients have deep SSI, and 3 patients intra-abdominal patients. In emergency cases, 12 patients have superficial SSI, 6 patients has deep SSI, and 2 patients has intra-abdominal abscess. From the above observation, it shows that superficial surgical site infection is the commonest type and accounted for about 52.94% in elective and 60% in emergency of all the SSI, and deep surgical site infection accounted for 29.41% in elective and 30% of emergency cases. Based on drain and infection rate, wound without drain, 16 cases developed SSI, and wound with drain, 21 patients has get SSI. Comorbidity with SSIs, patient with diabetes, number of patients as 5 patients got SSI. 3 patients with obesity get SSI. 1 patient with anemia get SSI. 1 patient get with hypertension get SSI, and 2 patients other comorbidities. Discussion. In the present study, the post-operative SSI rate in elective clean and clean contaminated cases is 4.34%, and emergency cases 12.41%, accounting for overall SSI rate of 7.32%. Reports of SSI from different workers gave different infection rate. Number of studies carried out in India indicate overall infection rate is 30% for clean surgery cases. In prospective study conducted in Ethiopia, out of 105 patients who undergo surgical procedure, 20 patients develop SSI, which give overall incidence rate 19.1%. The findings was similar study done in India, Nigeria, and Egypt. The findings was higher compared with study done in USA, France, and Egypt, and Sudan. Studies done in Egypt and Sudan included only elective surgeries, but in our study, we get done in elective and emergency both. Based on age, in our study, almost 69.7% and 77.7% of the cases with SSI were in age group of 20 and 60 years in elective and emergency cases respectively. The study conducted in Ethiopia revealed that
Dr. Virang, please.
Okay,
let us go directly to the conclusion, please.
Okay, no. SSI being one of the most common cause of nosocomial infection. It was the most important factor responsible for significant morbidity, mortality, unwanted prolonged hospitalization, and additional cost of treatment in surgical patients, which can be reduced by strictly following the guidelines of infection control along with Jurassial and rational use of antibiotics. A pre-existing medical illness like diabetes mellitus, prolonged operating time, class 4 wounds, emergency surgery, and wound contamination strongly predisposed to surgical site infection, which has been taken care of. Limitation of study. Our limitation in this study, we cannot, I have not included high risk factors such as smoking and increased BI not taken in account, and we have not cultured the anaerobic bacteria. Hence, SSI with negative culture can be maybe positive for anaerobic bacteria.
Dr. DK Shah, Dr. Vasavada, please take over.
So what do you want to compare, whether the elective surgery, maybe VS elective surgery or elective VS planned surgery?
Sir, I have compared elective versus emergency.
Yes.
I have compared elective with emergency surgeries, a ratio of SSI in elective and emergency surgeries.
What is the new? What is the new in your study? Whatever you said, that is the old theory. What is the new? What is the take-home message? Any take-home message?
Sir, in my I have drain used in elective and emergency surgeries. It can, if it is required, then it's placed. Otherwise, don't try to place drain. It is also it's lead to it increase the rate of SSI.
Then your title should be drain.
No, sir, I have included factors in SSI.
There are multiple variables even for the SSI.
Yes, sir, there are multiple variables.
Okay.
Because it's not leaded only with the drain only cannot be cause this SSI.
Yes, sir.
Drain
You are
talking about? All the variable has to be elective surgery, all the variable, and that will be very difficult. Or you have to use some other statistical methods to compare it.
Yes.
Yes, sir.
So how do you divide count wounds?
Sir, wounds are divided into 4 types: clean,
Okay.
contaminated,
So have you,
dirty
I
wound.
got it. Have you used that as a variable or not?
Yes, sir. I have included elective surgery is a clean and contaminated, and emergency surgery is contaminated and dirty wound.
Okay. Which drain you are talking about?
Sir, the first in emergency surgery, we are doing exploratory.
No. I am asking you whether you are talking of intra-abdominal drain or a wound drain.
Sir, wound drain, subcutaneous drain, negative suction drain.
Negative suction in emergency?
No, sir, we can't play. We try to avoid placement of negative drain. Emergency surgery.
Don't try anything. What I want to say, which drain you have used for an intra-abdominal, fine. It has no relation with surgical site as far as I am concerned. There are variables. What about the wound drain? Which drain you would prefer and which drain you have used? So if you are taking that as a variable, how many patients had been given drain? Wound drain was put in how many patients?
In my study, I have placed in 41 patients drain.
Okay.
In both emergency and elective surgery.
Okay.
Out of them,
so
21
you put in emergency in a wound negative drain?
Negative suction drain, sir, is asking.
Yes, sir. In some cases.
Sir, let's please move on to the next participant.
Last paper.
Thank you, sir.
Thank you.
Dr. Kavan, are you there?
Hello.
Yes, he is there.
Okay, just give me 1 minute. I'll share your presentation.
So again, what I want to say is the selection of topic was very vague many times because it's a very big topic. SSI, you can write down book. Do you understand? The Dr. D.K. Shah was wanting to say the same thing. It should be take one variable and highlight on that. Then it will become a paper. This was a more of a thesis.
This is correct. Some take-home message, sir. Some take-home message after paper.
And take only 1 or 2 handles. That will be useful. Suppose if you concentrate on drain. If you want to say emergency, concentrate on emergency, like that. This is very vague and okay, fine. Now,
the next paper visible?
Yes.
Okay. Dr. Kavan, kindly start the presentation. Yes, you are audible.
So once again, good morning to everyone. I am Dr. Kavan Takwani, 3rd year resident in Sri Krishna Hospital, Karamsad. I am presenting a case series of spontaneous hemothorax in patients with COVID-19 infection under guidance of Dr. Pranjal Sangole. Spontaneous hemothorax is a rare disorder characterized by pleural fluid hematocrit greater than 50% of the peripheral blood hematocrit without natural or iatrogenic trauma to the lungs or pleural space. Spontaneous hemopneumothorax is defined as presence of more than 400 ml of blood accumulation in pleural cavity along with pneumothorax. COVID-19 is a pandemic which has involved 25 crore cases approximately worldwide, and the deaths have reached up to 49 lakhs. Fever, cough, and dyspnea are the most prevalent symptoms of COVID-19. Spontaneous hemothorax is a rare occurrence, and only 3 such cases have been reported worldwide till date. Here we present a case series of 3 such cases of spontaneous hemothorax with varied clinical presentation and outcomes. Next. First case is of a 64-year-old male patient with complaints of chest pain and shortness of breath since 7 days, which aggravated since 1 day. Patient is a known case of CL larynx since 3 years, having taken radio and chemotherapy for the same. Patient had no history of trauma, fever, cough, and was a smoker since 40 years. Vitals were pulse rate of 108 per minute and respiratory rate of 32 per minute. Blood pressure was 100 by 70 millimeter of mercury and oxygen saturation was 63% on room air, for which patient was kept on non-rebreathing mask on 15 liters O2. Patient was afebrile. On examination, patient was under moderate distress with reduced breath sounds on left side. Lab reports showed mild leukocytosis of 12,700 per ml and hemoglobin was 9.8 milligram per deciliter with COVID PCR positive. Chest X-ray showed left side pleural effusion with blunting of the costodiaphragmatic recess and mild displacement on the mild midline shift on the opposite side. Next. HRCT was suggestive of moderate to gross loculated hyperdense pleural effusion in left lower zone. Tube thoracostomy was performed and 1400 cc frank blood was drained. Repeat chest X-ray showed expansion of lung, reduced pleural effusion, and chest tube in position, as can be seen in the X-ray plate. 2 units of packed cell volume were given on the same day. Patient drained 200 cc blood on second day, 150 cc on third day, and 50 cc on fourth day. From fifth day onwards, drain output was 5 to 10 cc serohemorrhagic. Patient was discharged on 12th day after removal of the intercostal drainage tube. Second case is a case of 75-year-old male presented with complaints of chest pain, fever, cough, and shortness of breath since 4 days. Patient was a known case of ischemic heart disease on tablet Ecosprin 75 milligram once daily. Patient had no history of trauma or hemoptysis. Vitally, patient's pulse rate was 132 per minute and respiratory rate was 48 per minute. Blood pressure was 90 by 60 millimeters of mercury and oxygen saturation was 76 on room air. In view of severe lung involvement in X-ray and poor GCS, patient was intubated and kept in ICU on noradrenaline support. Lab report showed leukocytosis of 34,100 per ml and hemoglobin was 12.4 milligram per deciliter with COVID PCR positive. Patient's D dimer was more than 10,000, hence patient was kept on injectable enoxaparin 0.4 sub-QBD for thromboprophylaxis. Next. HRCT was suggestive of gross loculated hyperdense pleural effusion in bilateral mid and lower zone. Tube thoracostomy was performed bilaterally and 600 cc frank blood was drained on each side. Repeat chest X-ray showed minimal expansion of lung, reduced pleural effusion, and chest tube in position. 1 unit of packed cell volume were given on the same day. Patient on next day went into multi-organ dysfunction syndrome, which led to bradycardiac arrest on next day and was declared dead after failed resuscitation. Next. Third case is of a 34-year-old female patient presenting with complaints of sudden onset breathlessness since 1 day. Patient had history of dry cough since 7 days. Patient has no significant past history and no history of trauma, fever, or chest pain. Vitally, patient had pulse of 78 per minute and respiratory rate was 36 per minute. Blood pressure was 120 by 70 millimeters of mercury and oxygen saturation was 93% on room air. Patient was afebrile. On examination, patient was under mild distress with reduced breath sounds on right side. Lab report showed total leukocyte count of 8,300 per ml and hemoglobin was 13.2 milligram per deciliter with COVID PCR positive. Chest X-ray showed right side pleural effusion with no mediastinal shift. Next. HRCT was suggestive of moderate loculated hyperdense pleural effusion in right lower zone. Tube thoracostomy was performed and 400 cc frank blood was drained. Repeat chest X-ray showed good expansion of lung, reduced pleural effusion, and chest tube in position. No packed cell volume were needed to be given. Patient drained 150 cc blood on second day, 50 cc on third day, and from fourth day onwards, drain output was 5 to 10 cc serohemorrhagic. Next. So spontaneous pneumothorax is a rare complication of severe or untreated COVID-19 infections. It presents as an emergency condition. Usually the causes which are reported in the literature are due to rupture of the apical bleb, which is usually due to the infection in the lungs. This bleb along with the vessel which ruptures can cause spontaneous pneumothorax, which can be from mild, moderate to massive according to the patient. Patient needs urgent drainage of blood to relieve symptoms and prevent hemorrhagic shock. In cases of untreated COVID-19 infection, sudden onset chest pain with worsening breathlessness may point towards the underlying spontaneous pneumothorax. Chest X-ray is sensitive enough to diagnose pleural effusion, but one may take assistance of USG thorax or HRCT. Pulmonary contrast angiography in such cases leads to underlying cause, which is usually a bleed from the intercostal or communicating artery due to rupture of the infected apical bulla. But usually pulmonary contrast angiography is only indicated if there is persistent bleeding and worsening symptoms or worsening hemoglobin after a treatment by the intercostal drainage tube after 5 to 7 days. If hemorrhage continues with drainage tube in situ or patient worsens hemodynamically, then visually assisted thoracoscopic surgery or open thoracotomy and control of ongoing bleed is the treatment of choice. Thank you.
Can you please begin with the question?
Okay, I want to ask you one question. What is the condition of the lung in both the, because you included the pleural part, there is effusion or the hemorrhage inside the pleural cavity.
Yes, sir.
What was the condition of the lung?
Sir,
What
in
was the
first
finding?
case, sir, in first case, the score was 15 out of 25. In second case, the score was 22 out of the 25. And in third case, it was 10 out of 25. The
Because
HRCT severity score.
what city you have shown, it doesn't
Yes,
look
sir.
like to be.
Sir, in the third patient, the HRCT score is 10 reported out of 25, but we only have this single plate. The whole scan is not available, sir.
All the patient, all the patient receiving enoxaparin?
No,
Heparin
sir.
was going on?
Sir, in the first and third case, the patient's D-dimer level were normal, and patient has clinically no evidence of any pulmonary thromboembolism or peripheral thromboembolism. So patient was not given injectable enoxaparin as patient presented with the hemothorax. In second case, patient was already admitted in the ICU with D-dimer more than 10,000, so was kept on enoxaparin. But after we diagnosed the bleed on 7th day of the ICU, enoxaparin was stopped.
Okay.
So in all the patients, you have done the COVID RT-PCR after the patient presented with the pulmonary complication.
Sir, in the first and third case, patient presented with complaints of shortness of breath and chest pain during the pandemic situation. So in every case, we used to do COVID RT-PCR in the trauma itself. And in second patient came with severe lung infection. So COVID RT-PCR was done. So on all the cases on presentation, COVID RT-PCR was done.
Okay. I think we should conclude this part, paper part. Thank you, Kavan. Good presentation.
Thank you, sir.
Okay.
So for participants which were not which were unable to log in earlier, next we'll go on to Dr. Hiteshwari for poster presentation.
Is she there? I cannot
Yes,
see.
sir, she has
Yes,
joined.
I'm there.
Okay.
Am I audible?
Yes, now very well. I think you have changed your page. Okay.
Yes, sir.
Okay,
Good morning to all.
Let there be a screen share of her poster. Yes. Yes, start.
Okay. Good morning to all. I am Hiteshwari Patel, second year resident. I am presenting a case, a poster of rare case of hydrated cyst over left thigh. Hydrated cyst is a parasitic disease caused by Echinococcus granulosus that is endemic in the Mediterranean countries, the Middle East. It is a zoonosis that occurs primarily in sheep grazing areas, with dog being the definitive host, sheep the intermediate host, and the human beings as an accidental host who contact the disease from the dogs, but there is no human-to-human transmission. More than 90% of the hydrated cysts occur in the liver, lungs, or both. Peripheral organ hydatidosis is less common, as only few embryos can escape the capillary filtrating system of the liver and the lungs. Theoretically, the high lactic acid level in the muscle tissue is considered unfavorable for the survival of parasite. Primary hydrated disease of the skeletal muscle is present in approximately 3% of the patients. Approximately 75% of the hydrates are located in the right lobe of liver. The ultrasonography is most commonly used for diagnosis worldwide. CT scan and MRI scans are also helpful. The treatment is primarily surgical. In selected patients, the puncture, aspiration, injections, and re-aspirations has been accepted. Albendazole or mebendazole therapy is given pre-operatively as well as post-operatively. The main aim of the study is to report an unusual case of intramuscular hydrated cyst in the left medial side of the thigh. Moving to case summary, a 65-year-old male presented to the OPD with painless swelling in the inner aspect of the left thigh for the past 10 months, which was gradually increasing in size. There was no relevant history of trauma or fever. On examination, there was two non-tender firm swelling of approx 10 by 7 centimeter and 3 by 2 centimeter with smooth, well-defined margin on the left medial aspect of the mid-thigh with no fluctuation or transillumination in the swelling. Routine blood investigations were done, which was normal. Ultrasonography revealed a large, well-defined multiloculated cystic lesion of 120 by 86 mm with multiple internal smaller cysts and intervening septa in muscular plane of the medial compartment of thigh, suggesting a possibility of the hydrated cyst. Since my patient was stable, he was further investigated to confirm the diagnosis. MRI revealed a 55 by 75 by 137 mm size multicystic lesion in the adductor compartment in medial part of the left thigh, extending into the subcutaneous plane with no extension into intraosseous or adjacent joint cavity with peripheral post-contrast enhancements, suggesting possibility of the hydrated cyst. On exploration, multiple cystic masses were revealed once the incision was placed over the swelling and content was sent for the histopathological examination. After drainage, the cavity was instilled with the scolicidal agent, cetrimide. Histopathological examination revealed the same finding. The post-operative period was uneventful and the patient was discharged on albendazole 400 mg twice daily, and he was found daily 2 months after operation. Moving to discussion, the prevalence of the muscular hydrated disease is not well determined. It has been postulated to be around 3%. Muscular hydrated disease could be secondary or primary. In secondary cases, the type of hydrated disease should be reported in at least one of the common site of the hydrated disease like liver, lung, or spleen. In this case, there was no evidence of hydrated cyst in any of primary sites. This suggests it could be a case of primary muscular hydatidosis. Up to date, 18 cases of hydrated disease of thigh have been reported in the literature, and this is in the age range between 8 to 61 years. 10 patients were female.
Very kindly, please conclude your poster.
Okay. In my conclusion, hydrated cyst of thigh is very rare parasitic manifestation presenting as a painless swelling, diagnosed typically by MRI and managed by the radical excision to avoid the recurrence.
What was your clinical diagnosis when the patient presented to you first?
It mostly, sir, different. In my provisional diagnosis was, sir, lipoma, but there was no slip sign or any. So I further investigated in the form of sonography.
No.
Suggestive of.
Sir is asking.
Yes.
What were you suspecting? Even on your photo doesn't look like lipoma. I can see two
it is
swelling. So what are the similar? It was a cystic swelling according to you. So what
Yes.
are the differential diagnosis? Sir is asking clinically.
Abscess over the medial aspect of the thigh,
Okay.
but it is excluded as it is non-tender and painless swelling.
One is then enumerate the diagnosis. Other diagnosis which
Other one,
present as a muscular cyst. What is cystic-sarcoidosis?
it is infection caused by Echinococcus granulosus or any other species of Echinococcus.
No. That is the problem, Hiteshwari. When you are presenting a muscular cyst, you should have read all other possibility. Huh?
Okay, sir.
Tinea soleus, have you heard?
Yeah, yes, sir. Yes, sir. Yeah.
Cystis, what is cystic-sarcoidosis? Okay, fine. Next, Priya.
Yes, sir. Next, we have
Janvi,
Dr.
I think.
Vishakha. Sorry, yes, sir. Dr. Janvi.
So is she there? Dr. Janvi?
Was there Dr. Janvi?
I
She
think
has
I saw-
joined, sir.
I saw her.
Good afternoon, sir.
Yes, she is there. Okay, share her slide, her poster. Dr. Vasavada, Dr. DK, this is the last case candidate we are going to judge. Then we will leave and hand over to session 2, right?
Okay, sir. Okay. Sir.
Dr. Vasavada, you send your mark sheet to Priya, and Dr. DK Shah, number of cases you have judged, you send them only.
Okay,
Right.
on the email. Yeah, same email.
And rest will be by Darshan. Okay, fine.
Is it visible?
Yes, very well visible, but bring it to top.
Yes.
Okay. Dr. Janvi, please start.
Good afternoon, all. I am doing a case presentation of cranioplasty done for growing skull fracture. A growing skull fracture or craniocerebral erosions are rare to cranial fractures where progressively growing cranial defects follow lacerations involving the dura mater. And the most common site for this lesion is parietal region. It presents as a non-tender cystic swelling with a palpable bony defect. Other symptoms may also include seizures, vomiting, discharge from ear or nose, and focal neurological defects. It is characterized by a progressive diastatic enlargement of fracture line. It is also known as leptomeningeal cyst because of frequent association with cystic mass filled with CSF. Moving to case presentation, a 3-year-old female child presented to neuro OPD with complaint of swelling in scalp since 2.5 years, which was progressively increasing in size with no history of seizures or focal neurological deficit. The patient had history of head injury when she was 6 months of age and had swelling in the right parietal-temporal region since then. On CT scan imaging, there was a defect in the right temporal parietal region with cystic herniation through the defect. Intraoperatively, the defect in the dura mater was repaired primarily, and the defect in the bone was repaired using titanium mesh. The patient was discharged without any immediate post-operative complications. In discussion, the incidence of growing skull fracture is 0.05 to 0.1%. It usually occurs in children below 3 years of age and never after 8 years of age. During this stage, the brain volume is increasing rapidly, which is in part responsible for the development of craniocerebral erosions. Through the development is multifactorial. The predominant factor is the presence of lacerated dura mater. A fracture with diastasis of more than 4 millimeters can be considered as a risk factor for development of growing skull fracture. The pulsatile force of brain during its growth causes the fracture line in the
Someone's phone is on, I think.
I think her phone. She's doing from mobile, I think.
Kindly continue, Dr. Janvi.
Sorry, sir. The resorption of the adjacent bone by continuous pressure from the tissue herniation through the bone gap adds to the progression of fracture line. The craniotomies that were done and which had not seen closure of dural lacerations have been found to be leading to growing skull fracture throughout the years. Another risk factor is the severity of underlying trauma. The brain at the growing skull fracture site is usually showing a cerebromeningeal cicatrix formation. These support dural tears as being one of the major risk factors for growing skull fractures, and a CT scan is the modality of choice for diagnosis of growing skull fracture. So these are the images that I have included. The one of them is the preoperative, the lump that was in the right temporoparietal region of this patient, which was soft, non-tender and cystic. And on CT scan imaging, there was a lesion, a bony defect, which with a cystic lesion in the right temporoparietal region. And the intraoperative photo shows the defect in the dura mater, which was closed primarily, and then a titanium mesh was put on the bone for a primary cranioplasty.
Okay.
How
Dr.
you
Vasavada.
secured the titanium plate? How you secured? Have you used any material to secure it, whether it should keep at the same place? Nothing has been used.
No, sir. No material was used primarily.
Just left it like that? Okay. Which other material can be used? Have you gone through literature? Any other material which can be used except titanium mesh?
Sorry, sir, I don't have any idea.
Okay. Which material you use in denture? Okay. What is dural hitch stitch? What was the age of patient?
Sir, the patient was a 3-year-old female child.
Okay. So why growing fracture is common in 3-year-old?
Sir, because below 3 years of age, whenever there is a lactation in the dura, there is progressively enlargement of brain in growing children. And the
One
linear
is that. Any other reason? In pediatric, it is much more common.
sir, because linear fractures are more common in children below 3 years of age.
No, it can linear fracture occur at any age. Okay, I think we should say it today for us. Thank you, Doctor.
Thank you.
Thank you, Dr. Vasavada. Thank you, Dr. DK. And
you,
special thank you, Priya and Vinit, sir. Vinit is there or?
He's there, sir, but
He is there, but he is our backbone because he is looking after everything. Vinit, please show yourself for a minute so we can end it. Okay.
Thank you, sir.
Okay, Vinit. So he will be there till the end and he is looking after all this end. Okay, thank you very much. Thank you all candidates.
Thank you.
Whoever has completed presentation can remain present here or can join other station if they want. But please remain unmuted. Priya. Okay. Thank you.
Thank you, sir. Thank you, Dr. Pankaj Modi, Dr. Dharmesh Vasavra, and Dr. Jitendra Darshan. We'd like to start with session 2 now. I would like to introduce the judges for this session. I welcome Dr. S.G. Mehta, Professor and Head of Department of General Surgery from GGS Hospital and MPSHA Medical College, Jamnagar. Our second judge will be Dr. Rajan Somani, Professor in General Surgery Department from CERTI Hospital, Bhavnagar. And our third judge will be Dr. Harsh Trivedi, Professor in Department of General Surgery from GGS Hospital and MPSHA Medical College, Jamnagar. Sir, in brief, I would like to repeat the instructions to the candidates as well as the judges. We have 10 posters followed by 7 papers in this session. I would like to ask all the participants as well as the viewers to please mute their mics except the one who is presenting and the 3 judges. The time for poster presentation is 4 minutes, followed by 2 minutes discussion or question answer round. Time for paper presentation is 6 minutes, followed by 2 minutes discussion or question answer round. And the candidates will be marked out of a total score of 50. If any participant is missing or is unable to join, we will give them one more chance when the session ends. But after that, if the participant is not present, he or she will be disqualified. We'll like to begin with the first
Sir
presenter.
Mehta Sahib, Sudhir Bhai, are you there, sir? Harsh, I saw her. Sir is there?
Had joined initially, but I think we were running late, so they might have logged out.
So that's
Dr.
why let
Harsh
us
is there,
confirm.
sir.
Sir is there, sir.
Rajan Somani was also here, sir.
Rajan, are you there? Harsh, yes, welcome. Sahib, kya hai? Unmute yourself, Harsh, unmute yourself. Yes.
Yes, sir. Good morning.
Very, very good morning. Rajan Somani.
તમને કેવડાવું છું, sir.
Rajan.
He was just
Priya, he was my resident one time before 22 years.
So he had joined about 10 minutes back. I'll just call him up once and check on him.
Okay, till then, Vinit, will you take over?
Okay, sir.
Okay, Harsh and Vinit, you start the work,
Yes,
okay?
Yes, sir. Yes, sir.
Okay,
And then once
thank
they
you.
join, I will hand over to them.
As soon as they come, because the Harsh is there, so he will be the best person. Okay. So thank you very much. I'll be leaving now. I want to see the other station, what they are doing. Priya, carry on.
Yes,
Thank you.
Thank you, sir. Our first participant is Dr. Mithilesh. Are you there?
Yes, ma'am.
Okay, just give me 1 minute. I'll share your screen. Is it visible? Is the poster visible?
Poster present. Yes, we can see it.
Hello.
Kindly start, Dr. Mithilesh.
Good afternoon, everyone. Today I am representing a case report of invasive papillary male breast carcinoma. I am Dr. Mithilesh Rathod, third year resident doctor of the PDU Medical College, Rajkot. First, introduction. Male breast carcinoma represent less than 1% of all cancer diagnosed in men. The predominant histopathological type is the infiltrated ductal carcinoma. It is accounting for 70% of the all cases. Even in the female patient, invasive papillary carcinoma is a rare morphological type. We present the case of a 60-year-old male with a invasive papillary breast carcinoma. This is the case report of the rare case of the papillary breast cancer we had experienced. So first we discuss about the case review. The 60-year-old male present
presented in the PDU Medical College, Rajkot, with complaint of a mass in the left breast since 5 months. He was addicted to smoking tobacco since 10 years. He had no significant past medical or surgical history. He was not taking any medication. Patient was a vegetarian by diet, smoked 20 BDs per day for last 20 years. Patient is married for last 35 years. There was no history of mumps, testicular injury, cirrhosis of liver, or any contributed family history. On physical examination, he was a averagely built, mildly pale, and non-icteric. The rest of the systemic exam revealed no abnormality. On local examination, there was no gynecomastia of 5 by 4 centimeters square size. The retroareolar mass, which has hyperareolar complex, eroded with fungation, formed non-tender and not fixed to chest wall. Fine needle aspiration cytology of the mass revealed the cluster of the columnar cells in a papillary configuration, suggestive of the papillary carcinoma of the breast. The USG of the bilateral breast with axillary, suggestive of the 5 by 2 centimeter size cystic area at the retroareolar region and 5 by 4 centimeter size satellite lesion at the upper outer quarter region, 50 mm distal to the nipperareolar lesion with a few small suspicious hypoechonuclear load at the left axilla. As per oncologist opinion, they started the neoadjuvant chemotherapy, 3 cycles of the paclitaxel, and with supportive treatment with antiemetics, emetics, and analgesic, and 10 doses of the injection GCF 300 mg subcutaneously OD. After the NSCT completed, we given very good clinical response with active. So tumor size decreased by the half and freely mobile, and then patient underwent for the left MRM in our hospital. Left side MRM with STG was done. Patient was started orally on the same day. Patient discharged on the post-op day second with the drain in situ. Average drain output was 30 cc, zero hemorrhagic daily, and drain removed on the post-op day 19. On histopathological specimen of the left side MRM procedure, as suggestive of the malignant lesion, invasive papillary carcinoma of the left breast involving multiple ducts with nodal metastasis 1 by 20, and Nottingham's count 3 + 1 + 1 is 5, grade 1, and TNM staging YT1 N1 MX. This on discussion. This is the picture of the A left side MRM. The B is the specimen after the procedure of MRM, left breast with axillary lymph node, and C is the post-operative image with done with the STG. On discussion, risk factor. Risk factor include the increasing age, radiation exposure, and factors related to the estrogen androgen imbalance, including the testicular disease and infertility, obesity, and cirrhosis. Risk factor related to genetic predisposition include the Klinefelter syndrome, family history, and BRCA gene mutation, particularly BRCA2 mutations. And gynecomastia is not a risk factor one. For a woman having a family history of breast carcinoma is in a first degree male relative is associated with an increased risk of breast carcinoma, but is also confirms the increase the risk in the male in the family. It is estimated that 15 to 20% of the male breast carcinoma patients have a family history of the disease, but only 7% of the whole male population in affected family member. A family history of breast carcinoma in a female relative is also a predisposing factor for the male breast carcinoma. Men with a family history of breast carcinoma in a female relative are 2.5 times more commonly likely to develop breast carcinoma. There is a strong link between the hormonal imbalance such as the relative estrogen excess and as a relative androgen deficiency and the development of male breast carcinoma. Exogenous estrogen intake has been shown to increase the risk of male breast carcinoma. Men in the highest quartile of the circulating estrogen level are 2.5 times more likely to develop breast carcinoma when compared to those within the lowest quartile.
So time for presentation is over. The floor is open for questioning. Hello.
Hello.
Yes, sir. Please ask questions to the participant.
Hello.
Yes, sir.
Myself, Dr. Rajan Somani. Hello.
Good afternoon, sir. You are audible, sir. Please ask the question.
Mithilesh.
Yes, sir.
What are the indication of MRI in case of breast?
Hello, sir.
You have done the MRI in your case, okay?
No, sir, we have not done MRI. We have done only ultrasonography of bilateral breast with axillary.
Okay. So what are the indications of MRI in case of breast lesion? Hello. Hello.
Hello, sir.
Then after MRM, you put the skin grafting, okay?
After MRM, we done the skin grafting, scrap taken from the
What are
middle
the
side.
other methods to cover the defect in breast surgery?
Other method.
What are the other methods with which you can cover the breast defect after surgery? Skin defect. What are the other better methods? Which
Sorry,
can
sir.
withstand with the radiation and air?
Hello.
Hello.
Here.
Hello.
Yes, sir, you are audible.
Dr.
He is not
Dr.
answering
Arjun
any
Subramani is
question.
asking
That's
that
it.
what are the other methods to cover the breast if the flaps cannot be opposed. Can you hear Dr. Mithilesh?
Yes, sir. Sorry, sir. I don't have.
If you don't know the answer, please say that you don't know so that we can move on to the next question.
Sir, don't know answer.
Am I audible?
Yes, sir.
Okay, Dr. Mithilesh. Right, start from the beginning. What are the risk factors in this case? You have discussed, mentioned about various risk factors in your discussion. In this case specific.
In this case, the specific risk factor is, sir, the
Hello.
Yes, I'm waiting for the answer.
Dr. Mithilesh, please answer. If you don't know the answer, please say that you don't know so that we can move on to the next question.
In this case, the specific risk factor is after the patient has genetically.
No, when you in your history, in the history taking, have you found any risk factors in this patient?
Sir, smoke the 20 BDs per day.
Smoking. Okay. Your discussion says your risk factors include increasing age, radiation, exposure, factors related to estrogen androgen imbalance, testicular disease, infertility, obesity, and cirrhosis. And
The time for questioning is over. Can you please move on to the next poster?
okay.
Sorry, sir. Dr. Radha, are you there?
Hello.
Just give me 1 minute. I will share your slide. Please begin with your presentation.
Yes. Good afternoon, sir. I am presenting a poster presentation on a large peritoneal mesenchymal simple cyst, a case report under guidance of Dr. D.K. Shah, sir. Introduction. Peritoneal simple mesothelial cyst is a rare mesenteric cyst of mesothelial origin. It is varying between few centimeters to up to 10 centimeters of size, and it is usually asymptomatic, but occasionally present with various non-specific symptoms, which can make preoperative diagnosis difficult. I am presenting a case of giant peritoneal simple mesothelial cyst, which was managed by complete surgical excision. A patient presented to us with 20-year-old Indian Muslim married nulliparous female with having no significant past history, with diffuse abdominal pain, discomfort of previous 1 month, and burning maturation of since past 2 months. On physical examination, there was a single mobile, painless, relatively firm abdominal lump was palpable in the left lumbar fossa, or approximately 5 by 6 centimeter size, with smooth surface. When the investigations were carried out, the blood investigations were within normal limits. Urine examination suggestive of plenty of pus cells and anaerobic bacterial infections of suggesting of urinary tract infection. Abdominal ultrasound was done, which was suggesting 6.5 by 8.6 by 12 centimeter size anorectic cystic lesion, possibility of simple cyst. Then the abdominal radiological imaging.
Dr. Radha, please unmute yourself.
Hello.
Yeah, continue.
Then the CCT abdominopelvis was done, which was suggestive of well-defined non-enhancing cystic lesion, which was in right-sided paracolic gutter, which suggests of benign mesenteric cyst. Then the excision for the cyst, the decision was taken to perform laparotomy. So the midline laparotomy incision was kept, and there was found one singular well-formed cystic lesion from the retroperitoneum of approximate of size 15 by 9 by 6 centimeter size. It was non-adherent to any abdominal organs. The histological examination revealed there was a smooth lining, yellow watery gelatinous content, and the layer is covered with benign mesothelial cells. So this suggestive of benign peritoneal mesothelial cyst. And that patient's gynecological examination was also not significant, and the symptomatic treatment were given for vaginal discharge and a burning maturation. The conclusion of my case report is the peritoneal simple mesothelial cyst is quite rare abdominal tumor. So when there is patient present with cystic lesion and pelvic inflammatory disease, this is to be considered as a differential diagnosis, and for the treatment of choice, complete surgical excision of the cyst is to be done.
Okay, so on the basis of, have you completed?
Yes, sir.
Okay. On the basis of a clinical examination, history taking an examination, what were the differential diagnoses you would like to?
Yes, sir. On clinical examination, it was a cystic lesion. So differential diagnosis was kept as a mesenteric cyst or any.
How did you decide? How did you decide that an intra-abdominal lump is cystic in consistency?
Sir, it was an intra-abdominal test that the test of leg raising test was also performed. So it was suggested that cystic lesion is intra-abdominal, so not superficial.
So leg raising will decide whether it is intra-abdominal or intraparietal or extraparietal.
It will decide it is extraparietal or intraparietal.
Okay. How did you decide that it is cystic in consistency?
Sir, it was well formed, then non-compressible. And on palpation, the consistency was, sir, firm, but
yes, that's what I'm trying to tell you.
Yes,
that intra-abdominal lump, you will not be able to say that it is cystic in consistency. It would be either firm or soft or hard.
Soft to firm consistency was there, sir.
Okay. So what are the differential diagnoses you should keep? What are the site of the lump?
Site was in left-sided lumbar fossa.
Left lumbar.
Lumbar region, sir. Lumbar region, sir.
Left lumbar region and abdominal lump, which is relatively firm, as mentioned in your poster. What are the differential diagnoses you want to keep?
So differential diagnosis was initially kept as a mesenteric cyst, sir, which can be of androgynous cyst or a chylogenic cyst.
What were the
others, sir?
What were the findings on which you said that this could be a mesenteric cyst? What are the
cyst was mobile in the all directions, sir. It was a firm in consistency, and it was a smoothing surface, sir. Then
characteristic of the mobility.
Yes, sir. Hello. Hello.
Sir has asked what is the characteristic of the mobility of the swelling.
Yes, sir. The lesion was mobile in all directions, the craniocaudal also and side to side.
So what is the typical finding in a mesenteric cyst regarding the mobility?
Sir, after this question, we'll like to move on to the next candidate after she answers this question.
Sure.
Mesenteric cyst is the mobile in a side to side direction.
What is the attachment of the mesentery? Direction of the attachment of mesentery.
Yes, sir.
Whether mesenteric cyst mobile parallel to it or perpendicular to it?
Cystic perpendicular to mesenteric attachment, sir.
So what is in your case?
Sir, in my case, the lesion was mobile, sir. Lesion was mobile in all directions.
All direction.
Yes, sir. It was.
You are telling it is left side, but your CT plate is suggestive on right side in poster. You are telling it is in the left lumbar. Some
No, sir. It's actually mistake, sir. Patient. It was on right side, sir.
no, in CT it is suggestive on right side.
Yes, sir. Patient is having on right side, sir.
There should be side is very important.
Yes, sir.
Can we please move on to the next presentation as we are running already late?
Okay.
Thank you, sir. Next presenter is Dr. Mehul. Dr. Mehul, are you there?
Am I audible?
No, your audio is very low. Can you increase the volume?
Hello.
Still, it's quite low.
Hello. Good afternoon, all of you. Myself, Dr. Mehul Ladauja, third year resident in PDU Medical College, Rajkot, and I'm presenting the case of congenital diaphragmatic hernia under guidance of Dr. Bhavesh Sosnani. A 30-year-old male patient was admitted to Rajkot Civil Hospital with history of abdominal pain since 3 days and multiple episodes of vomiting since 2 days. Patient having no other any significant history. On examination, his vitals were normal and per abdomen mild tenderness over epigastric region and left hypochondric region. On auscultation, bilateral eventing slightly decreased on left side with presence of bowel sound in left throat. Investigation, blood investigation, all blood investigation were with normal level. That's why we do chest X-ray. In chest X-ray, opacification in left lung lower zone. Then CCT, thorax abdomen, left-sided diaphragmatic hernia is noted posterolaterally and wall defect approx 64 mm and 47 mm with herniation of bowel loop, omental head, tail of pancreas and spleen through the defect. And we operate the patient for open diaphragmatic hernia by mesh plastic. In intra-op, stomach, transverse colon, mesocolon, spleen was herniated through left diaphragm. Reduction of content was very difficult due to intestinal adhesion and adhesion with pleural cavity. The sac was not identified. Content was reduced and defect was closed and reinforced by proline mesh plastic. First, we attempt laparoscopic hernia repair, but due to adhesion, it was very difficult. So then we open the then we go for laparotomy. This is the intra picture. And post-operatively, we start orally post of the third and RT remove and post of the third, bilateral vein remove and post of the fifth, and ICT remove post of the seventh. Patient was discharged on full diet at post of the eighth with regular follow-up after discharge. And in regular follow-up, patient was not having any complaint. Then we do post of CXR, it look normal. Congenital diaphragmatic hernia is extremely rare in adults. And Bocralic hernia is most common one among all congenital diaphragmatic hernia. This is due to incomplete fusion of pleuroperitoneal fold during early fetal development. It remains asymptomatic in many adults. It usually occurs on left side.
Hello, Dr. Mehul.
Yes, sir.
Can you zoom in the poster a little bit so that we can read it properly? थोड़ा zoom in करो. Enlarge. Discussion.
Sir, this is maximum that I can enlarge. I can't enlarge it more than this.
Fine.
I
Please
can
continue.
zoom out, but is unable to. This is the maximum it can do.
Right. Okay. Thank you. Please continue. Mehul, please continue.
Yes, sir. It remains asymptomatic in many adults. It usually occurs on left sided and is common in male. It's more 62% chances than in male.
We reported on a rare case of Bogdale hernia in adult male with intrathoracic sphenic flexure of the colon, stomach, and spleen who presented with non-specific abdominal symptoms. In congenital diaphragmatic hernia, content was herniated above, causing ipsilateral collapse of lung and shifting of heart to right side. Death is identified only in 10% of patients. Most common cause of death in congenital diaphragmatic hernia is pulmonary hypoplasia greater than pulmonary hypertension. Diagnosis in antenatal period by USG with suggestive of venous shift away from right side, congenital hernia, loop of intestine, stomach, liver, and face.
May our time for presentation is over. Kindly, please, judges, ask the questions.
So you should be able to describe and classify the various congenital diaphragmatic hernia.
There is two: Morgagni hernia and Bogdale hernia. Morgagni hernia occurs in right side, anterolateral side, anterior side, and Bogdale hernia occur in left side, more common in left side, posterolateral side. I am presenting the case of Bogdale hernia, which occurs in left side, posterolateral. In my case.
That you should be mentioning somewhere on the poster before discussion. Your diagnosis. Hello.
Hello.
Yeah, you should have mentioned that somewhere on the poster before your discussion or in your conclusions. We have not seen what your conclusion is.
Sir, in discussion, sir,
Hello.
Yes.
Mehul.
Yes.
Dr. Mehul.
Yes, sir.
You said that there was no significant history, and this is a congenital hernia. So, what are the significant histories? What histories you are going to take to rule out that there is no other cause for the hernia? Which history are you are going to take?
Any pneumonia, cough.
No, you have said that this is congenital. So, which history, which significant history you are taking that this is not congenital, this is only congenital and nothing else? Can it not be traumatic hernia due to some trauma?
Traumatic history. There is no.
Is there history of trauma?
No, sir. No.
And patient did not have any breathlessness or anything like that? Only abdominal pain?
The patient have only abdominal pain since 3 days. A similar attack occur before 15 days. Rest, no any complaint. Hello.
Time for questioning is over. Can you please move on to the next participant?
Okay, yes.
Dr. Princey, are you there?
Yes, ma'am.
Okay, just give me 1 minute. I will share your presentation. Is it visible? Kindly start, Dr. Princey.
Good afternoon, everyone. I am Dr. Princey Bhatti, third-year resident from Department of General Surgery, PDU MC Rajkot. With respect to Dr. A.M. Rajaguru as my co-author, today I will be presenting a poster on rare case of right-sided Bogdale hernia in adults. So I begin by defining Bogdale hernia as failure or incomplete fusion of lateral, costal with posterior or crural components of the diaphragm, with the intra-abdominal contents extending into the thoracic cavity through the defect. That's a type of congenital diaphragmatic hernia which typically presents in childhood and is rare in adults. First described by Vincent Alexander Bogdalik back in 1848. As few as 100 cases have been reported in the literature, with fewer of them, like 20 cases of right-sided Bogdalik hernia and in adults. Iterogenic acquired diaphragmatic hernia can also be seen as a complications of pediatric liver transplants and liver resections. References have been enclosed. Now I begin with the case report of 75-year-old female, hypertensive, who presented in the emergency department with right-sided upper abdominal pain, colicky progressive continuous, not tested with any other, not aggravated or relieved by any factor. Associated complaints, vomiting for 2 days, non-bilious, non-projectile, with the patient giving past history of hospitalization for dengue and right pleural effusion 8 months before the before admission. Negative history for trauma, no any history of cough, shortness of breath or chest pain. On examination, patient was found to be vitally stable and conscious oriented. On auscultation, air entry was decreased in right lower and middle zone of the right lung. Sluggish bowel sounds were present over right side lower chest. On abdomen examination, abdomen was found to be soft, distended, right upper and lower quadrant tenderness. With routine investigations were done, only raised WBC counts were found, rest were not found. Chest X-ray findings. Chest X-ray image has been shown here. The findings suggested intra-abdominal contents over right side of the chest and a gas shadow above the right side of the diaphragm. USG was done, USG abdo-pelvis and chest. Multiple dilated bowel loops at right lumbar region was seen, and single peristaltic bowel loop over right hemidiaphragm with right-sided mild pleural effusion was noted. Patient also underwent CECT abdomen plus thorax, which suggested right-sided diaphragmatic hernia with intestinal obstruction with right-sided moderate and left-sided mild pleural effusion with a diaphragmatic defect of size approximately 2.6 into 2 centimeters of dimension. The CT images have been shown. The first one is the median plane with the blue arrow pointing towards the defect. The second one is the axial plane, and the third and the fourth images are the sequential images of coronal section. First showing the defect and second showing the bowel contents herniating from the diaphragm. And management, the patient was immediately taken for emergency laparotomy. Please concentrate on the images below. On exploration, our 10 centimeter size of ileum segment was found to be herniating through the defect. Hello.
Yes, please continue.
Continue.
On 10 centimeter size segment of ileum was found to be herniating through a defect of approximately size 3 by 3 centimeter placed right posterolateral of the diaphragmatic ring. The first image is showing the intestinal contents herniating. Then diaphragmatic defect after reduction, the hernial contents were easily reduced, and the second image shows the diaphragmatic rent after reduction of the contents. Then the diaphragmatic rent was primarily closed in 2 layers. The third image shows the diaphragmatic rent being repaired, and the last one shows the complete repair of the diaphragmatic rent. A right-sided chest drain was also placed, and drains were placed, and post-operative period was uneventful for this patient. Discussing the above case report, approximately 1.1726% of all the diaphragmatic hernias is accounted by the Bogdalik hernia. Right-sided hemidiaphragm is protected by the liver, and closure of the right pleuroperitoneal hiatus occurs earlier in fetal life. This is the reason of right-sided Bogdalik hernia being rare than the left side. Symptoms of patient if present in adult patients when symptomatic present with the symptoms of thoracoabdominal complex. Our patient presented with typical features of abdominal complex, abdominal pain and vomiting with intestinal obstruction, that is stage 3, and a hernial sac has been reported to be present in 10 to 38% of such cases. However, in our patient, no such hernial sac was present. CT scan, CCT abdothorax is usually the modality of choice in these days. Characteristically, Bogdalik hernia is characterized by posterior lateral location, which was also found in our intraoperative findings. Surgical repair is mandatory, and management being reducing the abdominal contents back into the abdomen and repairing the defect. Right-sided defects are commonly dealt with thoracic or the thoracoabdominal approaches. Francis first reported the successful laparoscopic repair of the diaphragmatic hernia back in 1994. So I would like to finally conclude my presentation by saying that right-sided Bogdalik hernia with a small bowel obstruction in adults is a rare disease, and accurate diagnosis and prompt intervention is required for favorable outcomes.
Okay, so this patient, have you completed?
Yes, sir. Yes, sir.
Okay, I should congratulate you in completing in time with such a nice speed. What about what about the presentation? Why is the patient present at age at 75, you said?
Yes, sir.
And she must be having, she had, you mentioned some previous medical history also.
Yes, sir.
So why do you think that this diagnosis would have been missed out at that time?
Sir, at the time when she was admitted to ICU for dengue, she was diagnosed with pleural effusion on chest X-ray and USG, but a CT scan was not done at that point of time. Also, patient was not getting for pleural tapping of pleural effusion at that time. So that time might be because of lack of CT scan. Because CT being the modality of choice, the diagnosis might have been missed at that time. And now she presented in the stage of intestinal obstruction and complaint of abdominal pain, and we did a CT scan. So the diagnosis was made.
Okay, so intestinal obstruction, this was the first time that she had.
Yes, sir.
Okay, was there any abdominal distension in this?
Yes, sir.
You not mentioned abdominal distension.
Yes, sir. Mild abdominal distension was also seen with the abdomen being soft in consistency with tenderness.
Tenderness. Okay, why would you get tenderness in this case?
So because a patient had intestinal obstruction. This time it might have happened that the contents have been obstructed. The bowel that had herniated now presenting with the obstruction, so she has tenderness.
But
When,
why tenderness in the abdomen?
Sorry, sir.
Why was there tenderness in the abdomen when there is an obstructed bowel in the chest?
So the distal bowel segments would have been dilated. That is why tenderness would have been.
Not the distal. Proximal would dilate.
So there was another single dilated bowel loop in the lumbar region also, right side lumbar region.
So proximal would dilate if this is the only cause of the obstruction. Otherwise, the distal would not get dilated, and dilated bowel loops will not give rise to tenderness.
Time for the candidate is over. Can we please move on to the next candidate?
Okay, Dr. Vinit, would you like to ask her something?
We can continue.
Thank you, sir. Next candidate is Dr. Navneet. Are you there?
Hello.
Dr. Navneet Kapadia.
Hello.
Yeah, you are audible.
Hello. Good afternoon,
Please,
everyone.
please start with the presentation.
My case is Boerhaave syndrome. Boerhaave syndrome is spontaneous rupture of esophagus associated with 70% survival with surgical intervention. Mortality and morbidity are directly proportionate to time between the diagnosis and appropriate surgical intervention. Delayed in diagnosis and surgical intervention may result in sepsis, hypovolemia, and shock, which eventually led to a fatal condition. A case of Boerhaave syndrome was diagnosed rapidly and timely. Surgical intervention was done, resulting in survival of the patient. A case report: a 50-year-old male patient presented to emergency department with complaint of sudden epigastric and retrosternal pain. Pain was moderate in severity and developed suddenly after forceful vomiting. Patient was occasional alcohol drinker. He had no other significant medical or surgical intervention in past. On physical examination, patient was conscious, oriented, and febrile. Pulse rate was 100 per minute, regular, and blood pressure was 80 by 50 millimeter of mercury in right arm supine position. Blood pressure was normalized to 110 and 70 millimeter of mercury after pushing to point of normal saline. Per abdomen findings were unremarkable. The chest and cardiovascular system were within normal limits. The total leukocyte count were 15,000 cells per microliter. Hemoglobin was 16 gram per deciliter. No significant abnormality were detected on ultrasound or chest X-ray. The CT scan abdomen was done, which showed dilated lower thoracic esophagus and presence of multiple gas pocket in lower paraesophageal region and minimal contrast leak, suggestive of Boerhaave syndrome. There was no evidence of pneumomedia syndrome or pneumothorax. After diagnosis of the condition, the patient was immediately started on high broad spectrum antibiotic injection meropenem and clindamycin, was posted for surgery, left side thoracotomy and repair of esophageal rupture. Intraoperatively, there was a 1 by 1 centimeter transmural rupture of lower thoracic esophagus, and brownish color fluid was coming out of the perforation. Perforation was repaired with non-absorbable suture Mersil 20, left side intercostal drain was placed, and for the enteral nutrition feeding jejunostomy was done. Post-operatively, patient was shifted to ICU. On post-operative 2, patient developed MI and ventricular tachycardia, which were a non-complication of thoracotomy and were managed with appropriate blood thinners, and patient was extubated on post-operative 4. On post-operative 6, rice tube was removed and gastrographic study was done, which was suggestive of minor contrast leak. For that, patient was kept NPO and enteral nutrition continued from feeding jejunostomy. Patient was shifted to ward and is recovering well. FR rupture of esophagus or Boyhouse syndrome is a spontaneous rupture of esophagus that results from the sudden increase in intraesophageal pressure combined with negative intrathoracic pressure. This rare condition is associated with high morbidity and mortality and is fatal in the absence of therapy. The occasionally non-specific nature of the symptom may contribute to delay in diagnosis and a poor outcome. The incidence is 3.1 per 10 lakh per year. Among esophageal perforation, approximately 15% of spontaneous are spontaneous perforation. The esophageal perforation usually occurs on left posterolateral aspect of distal thoracic esophagus, results in contamination of mediastinal cavity with gastric content. This leads to chemical mediastinitis with mediastinal emphysema and inflammation, and subsequently bacterial infection and mediastinal necrosis. If untreated, sepsis or organ failure may result. The clinical feature of Boyhouse syndrome depends upon the time elapsed, location of the perforation, the degree of leakage, and time elapsed since the injury occurred.
Dr. Navneet, please kindly conclude your poster.
Here I have presented a rare case of Boyhouse syndrome, spontaneous rupture of esophagus following retching and vomiting, which was timely diagnosed and appropriate surgical intervention was undertaken, and this will result in the prevented the patient from deadly complication of this condition.
Okay, have you completed?
Yes, sir.
Okay. Which are two questions. One is, how do you clinically suspect? Because this, as you said, is a fatal condition if not treated, diagnosed and treated in time. What are the early signs on which you will suspect? And second question is, what are the other causes of rupture of esophagus? Answer both the questions one after the other.
First is a classical history, that is retching and vomiting, forceful vomiting against the closed epiglottis, followed by severe retrosternal pain, and followed by the symptoms of mediastinal, that is fever and hypotension. That will diagnose the will
raise a
probably
suspicion.
diagnose suspicion.
Okay. Then confirmation.
And, for confirmation, first we will take a chest X-ray, which show the air in mediastinal cavity, or occasionally there will be a pneumothorax also, and subq emphysema will be there in some case.
And the second question.
Sorry, what
other causes. This you mentioned rupture of esophagus. What are the other causes of rupture of esophagus?
The most common is the iatrogenic, due to endoscope, any instrumentation, endoscopic and all. And other causes like Barrett's esophagus, eosinophilic esophagitis. In such case, forceful vomiting can lead to a spontaneous rupture of the esophagus.
Okay, the other examiners, please. Dr. Rajan was there, I think. Dr. Vinith, I can still see him.
Yes, sir.
Do you consider ICD insertion first?
Yeah, yes, sir. If there is a pneumothorax. Hello.
So then if some esophageal content may come inside the before you go for the CT.
Yes, sir. Look, sir, in this case, there was no any sign of pneumothorax, and patient was vitally stable, and SpO2 was 196. So even in CT
In
scan,
this
there was no
case,
any evidence of pneumothorax.
in this case, you remove the right tube and then do the dye study. It is possible that you can do first dye study and then remove the right tube.
Sir, for gastrography study, we have to give oral contrast, and for best result, we have to remove the rise tube so that we can see the entire length of esophagus, and if there is any minor leak, that can be visualized on.
You cannot
So can we please move on to the next participant?
Yes.
Okay.
Thank you, sir.
Thank you, sir.
Dr. Pushpa, are you there? Okay. Is it visible?
Yes, ma'am. Thank you. Good morning, faculty. Good morning, colleagues. I'm Dr. Pushpa from Apollo Hospital, Gandhinagar. I'm presenting a poster on large chest wall defect after mucormycosis, which was managed with dermal regeneration template and negative pressure wound therapy under guidance of Dr. Sanjay Shah and Dr. Manjulata Anchalia madam. Necrotizing soft tissue infections is characterized by rapidly progressive necrosis of skin and adenoid tissue. It requires prompt radical and often multiple surgical debridements. Fungal NSTI by zygomycetes group are associated with the high mortality, and trauma is an important mode of acquiring the cutaneous form of disease. We report a case with large pleura deep chest wall defect after multiple debridement for fungal NSTI who underwent successful reconstruction with NPWT and dermal regeneration template. My patient was a 57-year-old diabetic gentleman who was presented in the emergency department with an abrasion, red purple discoloration, and severe pain on right side of chest wall following a trivial trauma happened 7 days back. For that, he underwent IND for 5 days back, and then he continued to deteriorate clinically and hemodynamically. So he was referred to our hospital. On arrival, he was febrile, hypotensive, tachycardic, and tachypneic. Local examination revealed a diffuse tender necrotic patch of skin and soft tissue of about 18 into 15 centimeter with purulent discharge on the right anterolateral chest wall. Blood investigations revealed a hemoglobin level of 9.5 gram per deciliter, RBS of 298 and milligram per deciliter, TLC count of 36,000 per mm cube. His HbA1c level was 6.9%. CT scan was done which was suggestive of cellulitis and marked necrosis of the underlying muscles of the right chest wall. So emergency surgical debridement was performed after adequate resuscitation. Intraoperatively, there was extensive necrosis present extending deep till pectoralis major muscles. So there was a very less bleeding while dissection. So a major debridement was performed and tissue was sent for histopath and microbiology laboratory, which turned out to be positive for fungal infections or mucormycosis. A patient was managed in ICU, liposomal amphotericin B and antibiotics and other supportive management was continued. But continuously his conditions were deteriorating, so repeated debridement were performed for 3-4 times. Therefore, there was a large part of pectoralis major muscles with medial part of serratus anterior, external intercostal muscles, anterolateral segment of 4 to 8 ribs. Internal intercostal muscles were removed in subsequent debridements. And subsequently, the visible lung was covered with the partially preserved latissimus dorsi flap, which also got necrosed partially, probably due to poor blood supply and further debridement. So after clinical improvement with the with the ventilator care and antibiotic and antifungal treatment. When culture negative report came out negative, then negative pressure wound therapy was applied to the flap to achieve a fast granulation tissue and angiogenesis. To cover the large central large row area on the pleura, we applied a dermal regeneration template. Repeated debridement were done as often as required. The outer layer of DRT was removed on day 19 when good neodermis formation was confirmed. Then STG was harvested from thigh and applied on the neodermis on day 19 after meshing. Patient was discharged to home with wet dressing on the skin graft. There was good graft uptake and normal donor site healing in the follow-up visit. My images are showing the initial presentation image after the debridement showing parietal pleura. Then vacuum therapy applied, then granulation after NPWT, then we applied Integra Edge dermal regeneration tablet, and this is the image of follow-up. Mortality is very high. Mortality is very high and management is challenging in necrotizing soft tissue infections. Hemodynamic instability usually persists after post-operatively also. Infectious spread and progressive skin necrosis require further debridement as often as necessary. Autograft reconstruction may be restricted by limited donor site availability or questionable underlying wound bed viability in massive defects. Since the skin defect was large and tissue culture was sterile in our patients, so we choose to apply a negative a dermal regeneration template to cover the defect. A bi-layer dermal regeneration template allows immediate tissue coverage, protection from the microbial invasion, less painful wound care, and thin autograft requirement. So decreased donor side morbidity and healing time with less hypertrophic scarring. DRT consists of an inner dermal substitute layer forming neodermis and outer silicon layer, which need to be removed subsequently, and epidermal autograft must be placed on the neodermis. Active secondary wound infection is a contraindication to the DRT as it prevents neodermis formation. Our patient underwent successful neodermis formation requiring a thin graft just for epidermal coverage without any donor wound site complications.
Dr. Pushpa, please stop. I'll request the judges to please ask questions.
Okay,
Yes.
we can ask her to conclude. It is only 2 lines.
Okay, please conclude your post.
Thank you, sir. Fungal anesthesia of the chest wall poses serious challenges to the clinicians. Dermal regeneration template offered the advantage of neodermis formation without the risk of skin autograft harvesting in a patient with an exposed lung. Therefore, our case highlight an important clinical option to consider for patient with massive chest wall, soft tissue defect exposing lungs with failed mucormycosis flap, and in whom full thickness skin graft would be a high risk.
It was a failed myocutaneous flap, not a mucormycosis flap.
Yes, sir. Yes, sir. Sorry.
Okay. Dr. Rajan, sir.
Yes, sir.
Would you like to ask her something?
I like what is the cost? It is very cost effective.
Sir, it is really costly. A size of 20 into 15 centimeter size cost around 50,000 to 75,000. But it is actually useful in very large defect.
Okay, so you are trying to justify by saying that because you have tried everything, all debridement and even the myocutaneous
Yes,
flap.
sir. Yes, sir. That is why we use it as a last resort.
Okay.
Because we didn't have an option to harvest a large skin graft from this patient.
Why was it so?
Sir, because the patient was very thin and his BMI was low.
This was a localized wound infection or a generalized infected condition.
Yes, sir. Also, there was generalized. His condition was not very good. So, because he was having blood infection, increased TLC counts.
What are the other options to cover that to reconstruct the chest wall, you know?
Sorry, sir.
Which are the other way to reconstruct the chest wall?
Okay, sir. We have already used latissimus dorsi flap. Then we can also use a free flap or full thickness skin grafting.
What is the most feasible flap?
Yes,
Free
sir?
flap? Most convenient free flap for the chest wall reconstruction.
Tram
Large
flap.
defect.
Tram flap, sir. Transverse rectus abdominis muscle flap.
Anterolateral thigh flap.
Yes, sir. Hello.
So shall we move on to the next participant?
No, I was waiting for Dr. Vineet if he wanted to mention something.
Okay.
Is he around?
Yes, he is there. Vineet sir, would you like to ask any question? Sir, he's online. Maybe he's away from the.
Okay, no problem. Okay, then we can proceed.
Dr. Shrimoy?
Yes, ma'am, I am present.
Okay, just give me one minute. Okay, can you start your presentation?
Good afternoon. Good afternoon, doctors. Today I shall be, my name is Dr. Shrimoy Biswas. I am second year general surgery resident at BJMC Medical College in Civil Hospital, Ahmedabad. Today I shall be presenting an interesting case of Meckel's diverticulum causing intestinal obstruction. So first let us introduce to what a Meckel's diverticulum is. Do we all remember the vitellointestinal duct which connects the gut tube to the yolk sac from our embryology? Sometimes in 2% of the population, the vitellointestinal duct remains persistent, and if it is persistent in its proximal half, then it forms something called a Meckel's diverticulum. This is present on the antemesenteric border and it contains all three coats of the bowel wall. It has its own blood supply from a branch of the superior mesenteric artery. Sometimes this Meckel's diverticulum can create complications. It can create complications in the form of hemorrhage. It usually contains a gastric mucosal component, which is responsible for the hemorrhage. Sometimes it can cause diverticulitis, which might clinically seem similar to appendicitis. It can cause intestinal obstruction by means of a volvulus around the vitello-umbilical band, which connects the Meckel's to the umbilicus. Or it can cause an intussusception, which might be ilioileal or ileocolic. It can also be incarcerated as part of an inguinal hernia, which is named a Litter's hernia. Then again, it can form chronic ulceration, and then again, it can cause perforation. Now we come to this particular case, which I'm going to report, wherein a young adult male, 19 years of age, presented to our emergency with sudden onset of colicky mid-abdominal pain with multiple episodes of bilious vomiting and constipation for a duration of just 1 day. On examination, patient was vitally stable. His general examination was unremarkable. Per abdomen was uniformly distended. Umbilicus was central, abdomen was tense, and there was a periumbilical tenderness. On PR examination, there was ballooning present. We investigated the patient in form of blood investigations. Blood investigations revealed normal results. AXR revealed multiple air fluid levels. On USG, it showed dilated small bowel loops with to and fro movements, largest diameter of 35 millimeter. We further went ahead and did a CCT of the patient, where it showed dilated small bowel loops and it revealed a Meckel's diverticulum in a paramedium location. A plan was taken to do exploratory laparotomy, which we went ahead and did with a mid-midline incision. It revealed small bowel loops dilated till the medialium. A 10 centimeter long, 3 centimeter wide at the base diverticulum was found 30 centimeter proximal to the IC junction with a vitello-umbilical band attached, extending to the anterior umbilical wall. And we saw a classical representation of how the bowel wall caused a volvulus, 360-degree volvulus again around that band. So we did a band release and 360-degree derotation. Bowel was healthy with preserved peristalsis. We did a resection and anastomosis. Post-op period for the patient was uneventful. Our man was discharged on post of day 6 with no further complications. Histopathology revealed a non-specific inflammation and mesenteric lymphadenitis.
Dr. Srimay, kindly conclude your poster.
Coming to the discussion, MECUS is the most common congenital anomaly of the small intestine, and 80% of the time it is asymptomatic. Most common presentation being bleeding. Now, diverticulitis can occur in 20% of symptomatic presentation, and axial torsion leading to obstruction is a complicating but life-threatening complication. Hence, as a take-home message, we need to remember as a differential diagnosis that a complicated MECUS diverticulum can cause cases of acute abdomen. Thank you, and I would like to thank my PG teacher, Dr. Amin, for assisting me and giving me the opportunity to do this presentation.
Examiners, please ask the questions.
Why did you subject the patient for CCT instead of proceeding for exploration, right, with the X-ray and the USG?
Yes, sir. Sir, patient was a young man with stable vitals. So we wanted to rule out, to explore the cause of why he might be having an intestinal obstruction. And since we got to get the CT done on the same day, so we went ahead and did a CECT. And then explored the patient.
Otherwise, also your plan of management would have been the same.
Yes, sir.
Okay. Your intraoperative findings, the measurements you said it is not fitting into any of this rule of two.
Sir, yeah, we had a long MECUS diverticulum, as we can see from the pictures. Yeah,
So
maybe because of the dilatation, the length, I think.
Okay, whatever the reason, this is not a mandatory kind of a thing. This is a common thing.
Common finding.
Okay, it is just a common finding. But your poster, you have highlighted that rule of two. It is occupying almost 2/6 of the poster, whereas your case is not fitting into that. So you should have given less importance to that rule of two. That's
Yes,
that
sir.
you have given for the poster design I am talking about.
Yes, sir.
Okay, and what was new in this intestinal obstruction in this case?
So here we could see that this is a case of intestinal obstruction where MECUS and volvulus around it was the sole reason for the cause of intestinal obstruction, which is MECUS may be present in 2% of the population, but it is symptomatic in only around 20%, of which intestinal obstruction is an even rarer case. And here we got to see that it had a narrow base along with a volvulus around the band, and it was the sole cause of obstruction in an adult patient.
Intestinal obstruction is quite common in MECUS diverticulum in the presentation. We are not talking about
adults.
Asymptomatic. In symptomatic, the intestinal obstruction is quite common. Okay, you said there is a narrow base. Was there a narrow base? Okay, you have done a
Yes, so as we can see from the picture, it was dilated in the distal part, and there was a constriction.
You mentioned that you wanted to do a resection anastomosis. Why? How much segment of the intestine did you remove, resect, and why?
Sir, after this question, can we move on to the next participant after this question?
Sure, sure. If the others don't want to ask.
Sir, at the base it was 3 centimeters, so we resected that in a wedge form, and we wedge form with the base of the triangle forming 3 centimeter and the whole length of the whole width of the bowel.
Other examples, please.
What is the approach to the incidental finding of MECUS diverticulum you find during the appendicectomy?
Sir, in case of appendicectomy, if we have a normal looking appendix, then we have to look for MECUS diverticulum, especially in young patients.
We always see for the terminal ileum.
Yes,
if you
sir.
found a MECUS, what is your approach in case of acute appendicitis?
Yes, so if the appendix is normal looking, then the cause may be a MECUS diverticulitis. So if that means it is a symptomatic MECUS. So if it is symptomatic MECUS, and if we can either plan.
You don't get my question. Appendix is acutely inflamed, and along with that, you find a MECUS.
Okay, so then we have to we have to palpate, we have to see the length of the MECUS. If it is more than 2 centimeters long, then we can go ahead for resection. Age of the patient we have to see. If it is a young patient, especially less than 50 years of age, then we can plan for resection of the MECUS. We have to palpate and see if the base of the MECUS is thick or if it has a thick wall or if there is any palpatory finding. Also, if the patient presented had any complaint of per rectal bleed. In such cases, we can plan for a resection. Now, if there was a case of bleeding, then we would go for resection anastomosis. If the base is narrow, then we can go for only resecting the part of the meatus and then suturing the defect or putting a linear stapler. Or if there is a on palpation, if there is a thick at the base, or if the base is broad, or if there was bleeding, then we have to go ahead and do a resection anastomosis.
Can we please go on to the next candidate? We are running short of time.
Okay, thank you.
Thank you, sir. Thank you, sir.
Dr. Virank.
Yes, I am here.
Okay, just give me 1 minute.
Can I start?
Yes, please start.
Okay. I am presenting a case report on gastric duplication cyst under guidance of Dr. Jaini Said, sir. Introduction. Gastrointestinal duplication cyst is defined as a spherical structure with a muscular coat lined by mucous membrane commonly occurring in the ileum. Gastric duplication cysts are rare phenomena and account only for 2 to 9% of all gastrointestinal duplication. They can be found anywhere in the stomach, with the majority being located on the greater curvature of the stomach. The majority is circular, communicating and surrounded by smooth muscular cord. Gastric duplication cysts are rarely diagnosed in the adult population and occur more commonly in young children, who may present with symptoms of abdominal pain, gastric outlet obstruction, or palpable abdominal mass. Clinical importance is ectopic tissue can include gastric, duodenal, and pancreas tissue. Case presentation. The patient is 10-year-old male with no previous surgical or medical history, with no significant family history, presented to our institute with complaint of abdominal pain since 5 days and also complaint of vomiting pain in located right upper quadrant and pain exacerbated by food. The patient also reported increased postprandial fullness followed by multiple episodes of nausea and emesis. On examination, routine blood test and plain chest radiograph were unremarkable. The patient underwent diagnostic evaluation by a CT scan finding suggestive of chronic appendicitis. For confirmation, we planned diagnostic laparoscopy, in which found a cyst-like structure which is suggestive of gastric duplication cyst, and we do exploratory laparotomy for surgical excision. Discussion. Duplication of gastrointestinal tract is a rare congenital anomaly. Most common site in alimentary tract duplication cysts most frequently affect the ileum 35%, the esophagus 19%, jejunum 10%, and stomach 9%, and colon 7%. In 35% of patients, gastric duplication cysts coexist with other congenital anomalies such as annular or heterotropic pancreas or vertebral anomalies such as spina bifida. Most commonly occur female compared to male, 8:1 ratio, with the majority of cases being diagnosed in the pediatric population. Common age group for gastric duplication cysts is the first 3 months of life is a common presentation and rarely after 12 years of age. Preoperative workup, magnetic resonance imaging, and more recently endoscopic ultrasound. Although gastric duplication cysts are a rare entity, they can present with multitude of symptoms. Patient presentation. Adult patient can present with abdominal pain, nausea, vomiting, dysphagia, dyspepsia, abdominal distension, and potentially anemia. Weight loss can also occur secondary to abdominal pain. A very small subset of patients can remain asymptomatic. Hemorrhage, perforation, malignancy, or complete gastric outlet obstruction can occur based on location or type of ectopic tissue present. Treatment modalities. Multiple treatment modalities have been reported in the literature, including inoculation, formation of cystogastrostomy, and even endoscopic removal. The mainstay of treatment is surgical excision of the cyst. Complete excision is recommended not only for symptomatic relief, as seen with gastric outlet obstruction, but also because of the risk of malignancy degeneration. Though rarely reported, there have been at least 14 cases of adenocarcinoma diagnosed in gastric duplication cyst after resection in the English literature. If malignant transformation is suspected, surgical resection is the treatment of choice. Conclusion. In conclusion, although rare gastrointestinal duplication cysts are unique entities that are often detected after significant growth with development of compressive symptoms, they are often diagnosed post-operatively by careful pathological examination, and treatment of choice is complete surgical resection. Thank you.
Rajan sir or Vineet sir, if you would like to ask any questions.
What is the approach to the asymptomatic duplication cyst of stomach? If it is asymptomatic, what are the indications of the surgery?
We do size of the cyst.
Incidental finding while laparoscopy.
If during laparoscopy is incidental findings, we go for surgical excision because it is chance of to do conversion of malignant formation.
How many percent?
From up to till now, only 14 cases are reported for malignant transformation.
But asymptomatic, can we treat it conservatively?
Based, sir, yes, sir, we can try. We can go for conservative, but it's depend on its size.
What is the size? Like you said that the depends on the size. So which, if it's a very
Sorry,
small
sir, we can't. I can't hear you.
what is the size? Size which what should be the minimum size that we have to excise if it is asymptomatic?
If the size of gastric, if the size of cyst more than 2.5 centimeter, we do for surgical excision.
Sir, time for discussion is over. Can we please move on to the next participant?
Okay.
Okay. Thank you, sir.
Dr. Jay.
Yes, I'm here.
Is it visible?
Yes, yes. Thank you.
Start.
Good afternoon, everyone. I'm Dr. Jai Chotalia, third year resident at Pramukh Swami Medical College. Under the guidance of Dr. Jitesh Desai, I'll be presenting an unusual case of cystic lesion between head of pancreas and duodenum. The identification of cystic lesion within the retroperitoneal space is a rare event that possesses a surgeon challenge of difficulty diagnosis and management of the patient. My case report: a 40-year-old female presented to our OPD with complaint of abdominal lump since 20 years, and lump was initially of small size, and it progressed up to current size covering the lower quadrant of the abdomen. It was associated with nausea, no other bowel bladder abnormality, or no any history of weight loss. On examination, there was a large, firm, freely mobile retroperitoneal mass of approximately 10 into 7 centimeter, occupying the right hypochondrium and right iliac region, which was associated with mild tenderness. Lab data suggested total counts of 8.2, and serum amylase was 123, and serum lipase was 355. On further imaging, on USG, it suggested there is a complex cyst present in right iliac and right hypochondrium region. So we the patient underwent for CT scan, which revealed a cystic lesion with the internal septation in right supraumbilical region, possibility origin from the head of pancreas. Intra of finding, cyst was approximately 12 into 10 into 10 centimeter, as shown in the picture, in retroperitoneal region, arising from the first part of a duodenum, and it was attached to the head of pancreas, but it was completely not adherent to the pancreas. The cyst was densely adherent to the first part of duodenum, which was excised, and end-to side gastrojejunostomy was performed. On histopathological examination, we had sent two specimens. One was retroperitoneal mass, and another one was the duodenum. The first specimen showed a thick-walled cystic structure without lining epithelium. The wall showed infiltration of the foamy macrophages and marked variable mixed inflammatory cells. This suggested the pseudopancreatic cyst, and the second specimen showed the focal atrophic edematous changes. Discussion. We are presenting a case of 40-year-old woman who presented to our clinic with large abdominal mass. The CT scans revealed cystic lesion with internal septation in right supraumbilical region. The patient underwent cystoduodenectomy for the cystic lesion, but the cyst was found completely free from the pancreas, only adherent to the first part of duodenum. We reviewed the case report and describing this case a rare condition in medical literature. There are two possibilities near the head of pancreas and duodenum, whether it could be a duodenum duplication cyst or ectopic pancreatic pseudocyst. As the literature says, both can be present there. In our cases, the cyst was not adhered to the pancreas. It was adhered to duodenum. So we resected the duodenum along with the cyst. We suspected it to be the duodenum duplication cyst, but after the histopathological report and discussion with the pathologist, we came on a conclusion that it was an ectopic pancreatic pseudocyst. Ectopic pancreas is an uncommon condition. It usually found in GI tract with 24 to 38% being seen in stomach and 9 to 36% seen in duodenum and 0.5 to 27% in jejunum. It usually on laparotomy, even when the symptomatic preoperative diagnosis is difficult. We present a patient who underwent cystoduodenectomy for the cystic lesion in the region of pancreatic head and duodenum. Histopathology revealed a pseudocyst formation in ectopic pancreas in the duodenal wall. Conclusion: this is a rare and difficult to diagnose preoperatively and present problem in management of the patient. We wanted to share this case in which we could have gone for the preoperative ultrasonography, endoscopic ultrasonography, or upper GI-scopy to rule out ectopic pancreatic pseudocyst for better management of this patient.
The floor is open for discussion.
Hello. In
Hello.
this case,
Yes, sir.
which part of duodenum you have resected?
Sir, first part of the duodenum, sir.
First part of duodenum. Have you resected the pylorus?
Yes,
or along with the duodenum?
no, sir. No,
You have done
sir. The portion.
gastrointestinal
No, sir. The
reconstruction
portion
was-
which was adhered to.
Hello.
Sorry, sir. Hello.
Ah.
Yes, sir.
Which part of duodenum you have removed? Now, how much?
Sir, the part which was adhered to densely adhered to the cyst, that part only was removed, sir. So it was
So why gastrojejunostomy was done?
Yes, sir.
Why? Duodenum is not primarily closed, or what?
Sir, the remaining part of the duodenum was closed, sir.
The continuity is there, or completely removed? That I
No,
am
sir.
not getting.
First part of the duodenum was removed, sir. So continuity was not there. So that's why we went.
Pylorus is preserved or not?
Yes, sir. Preserved, sir.
Preserved. So which
Yes.
gastrojejunostomy you have done? Which gastrojejunostomy you have done?
Sorry, sir. Hello.
You have done the gastrojejunostomy in this case.
Yes, sir.
So where you have anastomosed to jejunum, to stomach?
Sir, on the greater curvature, sir.
So you have closed the pylorus?
Yes, sir. We have closed the pylorus, sir.
Pyloric end.
Yes,
Okay.
pyloric end. Yes.
Okay.
And Dr. Jay, you said that this was a
Hello.
Yes,
Hello.
Dr. Jay, can you hear me?
Yes, sir. Yes, sir.
You said that you have done an end-to-side and gastrojejunostomy. Now you are saying that you have done an anastomosis with a greater curvature. So how can that be an end-to-side anastomosis?
Yes, sir.
End-to-side would mean that it is either.
Yes, sir.
And what I understand, Dr. Rajan's concern was that whether you have removed only the adherent portion, that much partial wall of the duodenum, or have you completely transected it from one end to other?
No, sir. We have resected the adherent part only, sir.
So only adherent part, if you remove, that means that it was not a complete transaction.
Complete. Yes, sir.
So what Dr. Rajan's concern was that you could you have it closed, that defect primarily, or why did you require a gastrojejunostomy?
So we have closed the defect for continuity, sir.
Sir, can you please move on to the next?
Okay.
Participant?
Dr. Vinit was asking something, but he could not be heard.
Yes,
asking that he said that it was an ectopic pseudocyst. So there is no in histopathology nowhere it is written that there is some ectopic pancreatic pseudocyst. So why you are saying like that?
Sir, actually, sir, pancreas was free from the cyst. So we came on the conclusion that it is an ectopic pancreatic tissue, as shown in the histopathological report, sir.
No, but it's not shown. You have not written anywhere.
Sir, in the histopathological, sir, first specimen showed pancreatic tissue, sir.
Does a pancreatic pseudocyst contain pancreatic tissue?
Yes, sir.
It will contain or it will not contain? That is what sir is asking.
So it will contain, sir.
Sir, please let us conclude with the
Okay.
posters.
Thank you, sir.
Thank you.
So now we'll begin with the paper presentations. Dr. Raman, are you there?
Yes, ma'am.
Okay, just give me one. Okay, you may start, please.
Good afternoon, everyone. Myself, Aman Balar, third year surgical resident at GMC Surat. I'm going to present a paper on clinical study of various forms of acute pancreatitis in a tertiary care center, a retrospective study. I'll start with introduction. Acute pancreatitis is an acute inflammatory process of pancreas with variable involvement of regional tissue and remote organ system. The average mortality rate in severe acute pancreatitis approaches 2 to 10%. Acute pancreatitis is broadly classified, the Atlanta classification, as mild, moderate, and severe. Most cases of acute pancreatitis fall into the mild category with favorable recovery. However, 15 to 20% cases of acute pancreatitis are severe and may result in prolonged hospitalization and local as well as systemic complications like SIRS, multi-organ system failure, and death. Nearly 80% of cases of acute pancreatitis worldwide are caused by gallstone obstruction and alcohol intake. Other causes like hypertriglyceridemia and drug accounts for the rest. Early confirmation of etiology by radiological investigation like ERCP and MRCP within 48 hours and clearance of the stone from common bile duct followed by urgent cholecystectomy within 3 to 9 days gave excellent outcome. In mild attacks of pancreatitis, a conservative approach is indicated with intravenous fluid administration and frequent but non-invasive observation. However, if the patient has a severe attack of pancreatitis, then a more aggressive approach is required with the patient being admitted to a high dependency intensive care unit where the patient is monitored invasively to ensure hemostasis of cardiovascular, respiratory, and renal system. This study was conducted to observe the clinical presentation of various forms of acute pancreatitis treated in Department of Surgery, GMC Surat. Material and method used were this was a hospital-based retrospective study on 100 cases of various forms of acute pancreatitis in the Department of Surgery and Government Medical College Surat from January 2019 to December 2019 to find out the clinical presentation of acute pancreatitis patients. Institutional ethics and research committee approval was obtained to conduct the study. The diagnosis of acute pancreatitis was based on presence of appropriate clinical evidence associated with an elevation of serum lipase. Patients were classified into mild, moderate, and severe acute pancreatitis based on Renson's criteria and Glasgow scoring system. Patients with chronic pancreatitis and malignancy were excluded from the study. Result, the most common age group in which acute pancreatitis was seen was in third and fourth decade, which was 39, followed by in second and third decade, followed by fourth and fifth decade. The most common etiology was found to be alcohol, which was 62% out of 100 cases, and 23 where gallstone was the second most common cause with 23 cases. Disease severity was compared with mortality. Mild cases were most common with 83 cases, and moderate cases were 11, and severe acute pancreatitis was seen in 6 patients, with mortality seen in 2 patients in severe acute pancreatitis. Local complication included collection, edema, ascites, pseudocyst, necrosis, abscess, and only 22 cases were seen with no local complication. Most common complication was pancreatic edema in 52 cases. Most common symptom was pain, which was almost in 100% patient, and followed by vomiting in 28% and anorexia in 25%. Discussion: acute pancreatitis is a complex condition which varies from mild self-limiting inflammation to rapidly deteriorating condition which poses a serious threat to life. In this study, the age range of the patient was 13 to 70 years with a peak incidence was in the third and fourth decade, 67%. Basilic MG et al. Found median age of presentation as 53 years. In our study, in most cases, 62% were due to consumption of alcohol. 23% of the patient had documented gallstone-induced pancreatitis. Shiv Shankar et al. found alcohol consumption in 45.8% of cases and biliary microlithiasis in 88.3% of cases. The clinical presentation of varies from cases to cases depending on severity of acute pancreatitis and any underlying comorbidities. Mild acute pancreatitis present with minimal organ dysfunction and uneventful recovery, while severe acute pancreatitis associated with local and systemic complication and high mortality. The presentation in our study correlates with study by Nitesh Negi, Jatinder Mukhtar, where it was 100% and study by Michelle S. and Rao DS et al. In our study, 83 patients were diagnosed as mild acute edematous pancreatitis, 11 were moderately severe, and 6 patients were severe acute necrotizing pancreatitis type, with similar result as seen done by Ramo R et al. In Kerala and Alapat et al. Study in North India. Out of 100 cases, 77 cases were managed conservatively and rest 23 cases were managed surgically by ERCP followed by laparoscopic cholecystectomy in 3 to 9 days of attack of acute pancreatitis. 3 cases of pancreatic infected necrosis were subjected to necrosectomy and debridement. In the present study, local complications were encountered in form of pseudocyst 9%, necrosis 5%, and pancreatic abscess 3%. There were no mortality among the patients who were kept conservative and 2% mortality in the patient who underwent operative procedure. In the studies of Edward et al. And IC Funnel et al., the mortality was 6% and 10% respectively. Conclusion: acute pancreatitis is one of the leading cause of increased morbidity and mortality to society. In our study, out of various types of acute pancreatitis, mild variety is most common. Conservative management have favorable outcome in any form of acute pancreatitis. Operative management in severe acute pancreatitis associated with high morbidity and mortality.
Okay, Dr. Raman. Hello.
Yes, sir.
Hello.
Yes, sir.
So you said that you managed a few cases within 3 to 9 days with cholecystectomy, laparoscopy. So
Yes, sir.
what was the reason? Like, didn't you want the pancreatic, patient abdomen to settle down? Why you went for early cholecystectomy?
Sir, it is it is seen in various studies that following ERCP guided removal of stone from common bile duct, gallstone induced pancreatitis, it is better to go with ERCP followed by cholecystectomy, sir, for better outcome, sir.
No, sir's question is regarding the timing. Your conclusion, you mentioned that most of the cases can be treated conservatively.
Yes, sir.
So was it a conclusion from this that it was not a good idea to operate and do a cholecystectomy, and that is why you think that the conservative treatment has a favorable outcome?
Sir, in mild and moderate cases, conservative treatment was favorable, but in severe acute pancreatitis, where in cases like necrotizing pancreatitis, the morbidity and mortality increased with operative.
No, your conclusion says that operative management is associated with high morbidity and mortality. So does this mean that your cases in which you have done an operative intervention, in that you got a high morbidity and mortality?
Yes, sir. As compared to
have you concluded this last sentence from your cases?
Sir, out of 3 cases of pancreatic infected necrosis, two cases were disease, sir. So in severe acute pancreatitis, we can say that if we go for operative management, mortality is higher, sir.
So you should not. Is that what you're trying to conclude with this?
No, sir, but we don't have any other options.
No options. You're talking about these many cases and your conclusion from your study. There was one more interesting point that I noted, that there were 19 males who had gallstones and only 4 females who had gallstones.
Yes, sir.
And you mentioned about post-surgery. Some etiology you mentioned as post-surgery also. Which was the surgery? Could you identify?
The patient who underwent
no, etiology. Come to the etiology.
Yes, sir.
In your tables.
Yes, sir. Sir, post ERCP, yes, but post surgery, sir, in cases of.
So those 2 male patients who got acute pancreatitis post surgery, what was the surgery done?
Sir, cholecystectomy was done, but the stone.
No. This was before acute pancreatitis. Okay, fine. You have mentioned about pseudopancreatic cyst formation. So, what was the duration of a follow-up of all these cases?
Sir, after this question, we'd like to go on to the next participant.
Okay, ask
Thank you, sir.
Dr. Rajan also.
In why in acute pancreatitis you want to do this ERCP so early? In which cases you prefer? Because ERCP itself.
So you're not audible.
Dr. Rajan, your internet connection is unstable, I think. Your voice is breaking. Can you please repeat the question?
In gallstone pancreatitis, why when they are going for ERCP? Because ERCP itself leads to pancreatitis. It is one of the complications of ERCP.
Sir, if the cause is a gallstone pancreatitis, sir, ERCP guided removal of the stone would.
How will you choose? How will you choose the patient? What are the criteria for choosing the patient for emergency ERCP? Most of the cases, what are the criteria in which you prefer to go for emergency biliary tract?
Sir, stone causing double duct dilatation.
Major removal of stone resolve the
Sir, your voice is again breaking.
tower.
Not audible.
Sir, the connection is, I think, unstable. Sir, please let us move on to the next participant as we are running late by about half an hour.
Okay, just a minute. Dr. Vineet. Dr. Vineet?
Yeah, yes, sir, I'm here.
Can we ask Dr. Aman the same question? Dr. Aman?
Yes, sir.
In a pseudopancreatic cyst, how much is, do you find any pancreatic tissue or not?
No, sir. No, sir. We don't find any pancreatic tissue in pseudopancreatic cyst, sir.
Okay, fine. Thank you. Next case, please.
Dr. Afreen, are you there?
Yes, I'm here. Audible?
Yes, you are audible. Can you see the screen?
No, not yet. Yeah, fine.
Okay, please start.
Okay. Myself, Dr. Afreen from SMEMA, going to case present on management of solid organ injury in patients of blunt abdominal trauma. Directly go to the introduction part now.
Yes.
During past decades, management of blunt injury to abdominal organs has shifted from operative to selective non-operative management. Trauma is the leading cause of death and disability in developing countries and the most common cause of death under 45 years of age. Non-operative management is the standard of care of hemodynamically stable patient with a blunt abdominal injury. The management of patients with solid organ injuries has changed since the introduction of technically advanced imaging such as ultrasonography, multi-scan computerized tomography, interventional radiological techniques, and modern intensive care units. There has been great improvement in non-operative management in solid organ injury in recent decades. Safe management with abdominal injury requires careful selection for non-operative management, meticulous monitoring, and follow-up. Abdominal injuries require surgery in about 25% of cases. 85% of abdominal traumas are of blunt character. The spleen and the liver are the most commonly injured organs as a result of blunt trauma. Clinical examination alone is inadequate because patients may have altered mental status, distracting injuries. Initial resuscitation along with focused, that is fast and CT abdomen are very beneficial to detect those patients with minimal and clinical undetectable signs of abdominal injury and are a part of recent management guidelines. Non-operative management can be divided in either observation alone or angiography and embolization followed by close observation. Non-operative management is a standard protocol for hemodynamically stable solid organ injuries. Pre-hospital transportation, initial assessment, thorough resuscitative measures, and correct diagnosis are of utmost importance in trauma management. Patient developing signs and symptoms of hypovolemic shock and aggressive blood loss requires emergency laparotomy. The prevalence of conservative treatment must be based on the hemodynamic stability indices as well as the lesion severity and on the general trauma severity. Thus, the main objective is to clinical presentation of abdominal trauma and to identify the parameters most useful to guide conservative management, to identify the cases where conservative management can be implicated and successfully, and to study the cases where operative line of management is mandatory. Material methods. I have taken 50 patients for management of abdominal trauma patient which came in SNEMAN for a period of 12 months. It was a prospective observational study, and patient selection was by convincing sampling. Inclusion criteria was all patients of abdominal trauma who came in SNEMAN. Exclusion criteria was who were hemodynamically unstable and had confirmation of intra-abdominal free fluid, which were taken immediately to laparotomy, and the patients below 12 years of age. Initial priority was given to maintain airway circulation and breathing on vitals, and after initial resuscitation, detailed clinical history, physical examination, laboratory test.
Dr. Afrin, can we directly go to the your paper?
Yes.
Instead of material and methods.
Results.
Yeah.
Okay. On the basis of the conclusion, out of 50 patients, the 14 patients were younger than 20 years of age, followed by older, which were more than 44 years of age, and 28 were between age 21 to 44 years. So mean age was 30 years of age. It is some young patients which were more affected. Current study and in sex distribution, 40% were male as compared to 10 female patients. So it concludes that males are more vulnerable because they are most exposed out hazards of road traffic accidents. And the road traffic accident was the commonest mode of blunt abdominal trauma in this study, followed by fall and assault. In organs which were included, spleen was the most common organ included, followed by liver, kidney, intestine, and blood, and other followed injuries. We did conservative management in 29 patients, out of which 21 were of operative management. Out of 19 patients, splenic injuries, 8 patients underwent exploration and splenectomy. 72% patients with liver injury were managed conservatively. All 5 patients with intestinal injury were underwent exploration and repair. 3 of them treated by primary perforation repair, 1 needed resection and anastomosis, and 1 underwent sigmoid loop colostomy. Discussion. Blunt abdominal trauma is a arduous task given to the best of traumatologists. Injuries ranging from single organ to multi-aging multi-organ trauma may be preceded by blunt abdominal trauma. Abdominal findings may be absent in 40% of patients with hemoperitoneum. Sometimes clinical evaluation of blunt abdominal injuries may be masked by other more obvious external injuries. Non-therapeutic laparotomies have significantly reduced with proper and timely applications of imaging methods in blunt abdominal trauma. Patients along with physical examination. Unrecognized abdominal injury is a frequent cause of preventable death after trauma. The patients who have sustained blunt abdominal trauma may have sustained injuries and simultaneously to other systems, and it is particularly important to examine for injuries of head, thorax, and extremities. Vigilance and care of injuries in any of the system may take precedence over abdominal trauma. In this prospective study, the predominance of young males has been observed as they are most mobile population of the society. Male to female ratio is 4:1. Mean age of the patient was 37 years of the present study. Most common mode of blunt trauma is RTA, followed by assault, followed by fall from height. Abdominal injuries are commonly associated with other injuries, and this may complicate the management and affect the outcome. In this study, 27% patients had other associated injuries. The most common were extremity injuries that occurred in 11 patients. FAST was the commonest tool used to diagnose patients with abdominal injuries. The spleen was the most common organ to be involved. Splenectomy was the most commonest mean of treatment of splenic injuries. Prolonged hospitalization is associated with an unacceptable burden on resources of health and undermines the productive potential of the population through time lost during hospitalization. In the study, the hospital stay ranged from 1 to 19 days with mean stay of 5 days. Conclusion. Hello. Conclusion. The management of solid organ injury.
Please, can you briefly conclude the session? Your time is over, actually.
The conclusion is non-operative management has been recently as a most common method for blunt solid organ injury. FAST is the most common modality we are using, and thus treating the patient with mostly with the conservative management rather than operative management.
Examiners, please ask the questions.
Hello.
Yes, sir.
Now, what is the role of CT scan of abdomen?
Sir, if the detailed, it is the most common investigation of choice for detailed evaluation of the organ injury.
So you have used the fast. Whether
Sir,
you have
it is
done the
it is the initial investigation of choice, sir. It is the first. Initially, we cannot do CT scan of the patient coming to our casualty, sir. It is the first method of investigation to rule out the trauma patient, sir.
Okay. In your case, how many patients you have to explore once you have decided whether you are going for the conservative management of solid organ? How
Yes,
many patients you need to re-explore afterwards, later on, within 40 to 5 days?
Okay, sir. The patients which are kept on conservative management are basically measured vitally. That is, pulse, BP, SpO2 all are measured. AT charting is done. Based on these aspects, if the patient is deteriorating in 24 to 42 hours, then we will do a repeat CT. Or if the patient is more deteriorated, then we will directly explore the patient.
Whether you have included the patient with associated abdominal injury in this case?
No, sir.
If patient has some visceral perforation,
Yes, sir.
that patient are included in this case, study or not?
No, sir. No.
If later on they detected visceral perforation,
Then we need to explore, sir.
explode. Okay.
Yes.
The one thing is you have in your study spleen is the most common.
Yes, sir.
So it is something contradictory. Usually liver is the most common.
Okay, sir.
Sir, can we please move on to the next contestant?
Okay.
Thank you, sir.
Thank you, sir.
Dr. Kuldeep. Dr. Kuldeep, are you there?
Hello. Yes, I'm present.
Can you see the slide?
No. Yes, I can see now.
Please begin and be.
Good afternoon, judges and fellow residents. Today, I'm presenting the paper on prospective study of true cut biopsy versus fine needle aspiration cytology of prostate in patients with lower urinary tract symptoms. Next, introduction. It is often difficult for the examining finger in the rectum to decide whether the enlargement is due to benign or malignant or inflammatory condition of the prostate, such as chronic inflammation, specific or non-specific, prostatic abscess, prostatic calculi, or benign hyperplasia or carcinoma of prostate. Prostatic obstruction must be diagnosed as early as possible so that definite treatment can be instituted to relieve the patient's symptoms and also to prevent the sequel of the obstruction. Determination of histological nature of lesion is the only positive method of establishing a definitive diagnosis. A suitable and simple technique of obtaining biopsy material and aspiration material from prostate of definitive diagnosis is essential. Next, aims and objective of the paper. Aim is a comparison between true cut biopsy and FNAC in lesion of prostate gland, and objectives are to study the diagnosis accuracy of FNAC and true cut biopsy of prostatic lesion in same patient, and to study the complication between FNAC and true cut biopsy. Inclusion criteria is age is greater than 40 years and patient with a prostatic lesion diagnosed with digital rectal examination and patient with symptom of LUTS. Exclusion criteria is age less than 40 years and patient not giving consent for procedure and patient with bleeding disorders. Methodology. A prospective comparative study of true cut biopsy versus FNAC of prostate in person with LUTS was conducted among 20 patients in Department of General Surgery, City Hospital, Bhavnagar, starting from July 2020 to September 2020 for a period of 3 months. Patients were chosen for the study on the basis of clinical history and digital rectal examination. Patients with the LUTS symptoms and enlarged prostate on DRE were further subjected to a PSA screening through blood examination at pathology lab and ultrasound for measuring prostate volume at radiology department of our hospital. Patients were explained about prostatic biopsy procedure, both true cut and FNAC are done blindly transrectally and following after the given consent by patient, and the patient are subjected for FNAC and true cut biopsy under local anesthesia. Specimen was sent to Department of Pathology, Government Medical College, Bhavnagar and histopathological and cytological evaluation. Result: in our study of 20 patients, 12 patients were diagnosed BPH via Trucott biopsy and 6 patients via FNAC. Total four patients were diagnosed carcinoma prostate with high serum PSA level. Is FNAC had diagnosed 3, while Trucott biopsy had diagnosed 5 with prostate carcinoma. Chances of prostatic malignancy are more with prostatic volume increase more than 50 cc. In Trucott biopsy, pain was seen in 9 patients after procedure and bleeding in 6 patients after procedure, while in FNAC, pain was seen in 6 patients and bleeding was seen in 2 patients after procedure. So, in conclusion, out of 20 patients by Trucott biopsy, diagnosed case of BPH were 12, carcinoma of prostate were 12, and chronic prostatitis were 2, while FNAC diagnosed case of BPH 6, carcinoma of prostate 2, and chronic prostatitis 1. So these are the table and chart regarding the various diagnoses via Trucott and FNAC procedure. BPH was in 20 patients, BPH were diagnosed in 12 patients via Trucott, and FNAC diagnosed 6 patients. Carcinoma prostate was in 2 patients, and FNAC were 2 patients. Chronic prostatitis in 2, and while FNAC was 1. And Trucott biopsy was a result non-significant in 4 patients in 11 patients in FNAC. Next. Distribution of complication according to method of diagnosis. We can see that Trucott biopsy post-op hello. Trucott biopsy was pain was seen in 9 patients, while in FNAC on 6 patients, and bleeding was present after a procedure in Trucott 6 patients and FNAC in 2 patients. Next. Conclusion. So in our study, favor that Trucott biopsy is more accurate in diagnosis of BPH and carcinoma as compared to FNAC. Though the complication like post-procedure pain and bleeding are more with Trucott biopsy, it can be managed easily. In developing countries like India, FNAC is FNAC is more preferred due to its simplicity, very low cost and least invasive, and very less or no complication. Overall, our study suggests that Trucott biopsy is superior to FNAC in diagnosis and management of prostatic disease.
I would like to ask the faculty to please ask questions.
I would like to ask, in all patients, you go for the FNAC and Trucott, or any role of serum PSA?
Sir, if a patient's serum PSA is more than 4 nanogram per ml, we can go for a Trucott biopsy, and we should also consider the age of the patient.
Your paper presentation title was FNAC and Trucott in LUTS. You have not mentioned any regarding the serum PSA level.
Yes, sir. In this study, sir, we have included the patient with serum PSA more than 4 nanogram, and we have done
that you have to mention in your inclusion criteria.
Yes, sir.
The serum PSA is more than 4, then the FNAC or Trucott will require.
Yes, sir.
Otherwise, won't. All LUTS patients won't require this.
Hello.
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 All patients will not require FNAC and Trucott.
Yes, sir.
So you have to take inclusion criteria. Serum PSA should be more than 4.
Okay.
Hello.
Hello. Sir.
Hello.
Yes, sir.
Was there any specific criteria, or it was a randomized?
Sir, you are not audible. Can you please speak a bit louder?
Hello. Hello.
Hello. Kuldeep.
Sir.
Was there any? Did you do some was this randomized, or you specific patient you did Trucott, specific patient you did FNAC? What was the criteria of selecting that which patient you have to do Trucott and which patient you have to do FNAC?
No, sir. We included all the patient with LUTS symptoms with age greater than 40 years and serum PSA level more than 4 nanogram per ml.
I was asking, how did you divide the patients? In which patients you have taken Trucott and in which patients you have taken FNAC? That
Yes,
is
sir.
what is-
In all patients, we have done the TrueCut and FNSC
All
both.
patients you have done FNSE as well as all the patients.
Yes, all patients. And we have compared the diagnosis after the results, histopathology examination.
Can you please go on to the next presenter?
Yes, yes.
Okay, thank you, sir.
Thank you. Dr. Khushbu is there?
Yes, ma'am.
Kindly start your presentation.
Good afternoon, everyone. Myself is Dr. Khushbu Badami. I am a third year resident of the Department of General Surgery from GMC Surat. I am presenting a paper of retrospective observational clinical study of pediatric anorectal malformations in tertiary care hospital of South Gujarat. Introduction: a properly functioning rectum is unappreciated gift of greatest price. Anorectal malformations are frequently encountered anomalies that represent an important component of pediatric surgical practice. In India, it is about 1:1600. It may be the part of a syndrome, or it may be the non-syndromic, or it may be the sporadic or familial. Anorectal malformation comprises a spectrum of disease. Some of these defects are minor and easily treated with the excellent functional prognosis, and while others are complex and difficult to manage. Their functional prognosis is poor, and frequently they are associated with other defects, mainly in urinary tract, that may threaten the patient's life. And the main concern for the future of the children with the anorectal malformation is bowel control. In addition, urinary control is sometimes a problem, and in extreme cases, sexual functions are also compromised. The objective of this study is to document types, subtypes, and management of congenital anorectal malformation and the other anomalies associated with anorectal malformation. This is a retrospective study of case series. In these, 30 operated cases of anorectal malformation from the 2018 to 2020 in a department of the general surgery with patient less than 14 years of age who were managed surgically were included. Data regarding the clinical presentation investigation carried out for the diagnosis, management with procedure, and outcomes were reviewed, collected, and evaluated from the records, and the assessment from the records were done according to the Wingspread classification. In our study, out of 30 patients, the 14 patients were the male and the 16 were the female. Out of 14 male, 8 had high anomalies, 5 had low anomaly, and 1 had intermediate one. And out of 16 female, 12 had intermediate anomalies, 2 had low anomaly, and 1 had a high anomaly, with the 1 case of cloaca. All the anomalies were diagnosed clinically after performing routine investigations. Ultrasonography of the abdopelvis with the ultrasonography of the skull and the X-ray chest with the X-ray invertogram were done to reach the clinical diagnosis. And the 2 cases were referred to our center along with the MRI abdopelvis with the whole spine. The 5 patients presented to the center out of 30 with the stoma in situ for the further management, and out of 5, the 1 presented with the stoma prolapse. And the most common mode of presentation in our study was passing stool from the abnormal passage followed by the not able to pass the stool since birth. Other presentation were the distension of the abdomen, stoma in situ, abnormal absent anal opening, bulging perineum, and the ectopic anus. The subtypes which were present in the study, the most common subtype was the rectovestibular fistula, which is of intermediate type, followed by the rectourethral fistula, rectovaginal fistula, rectoprostatic fistula, anocutaneous fistula, rectovesical fistula, rectal atresia, cloaca, membranous anus, anal stenosis, and ectopic anus. And associated congenital anomalies. More common was the renal agenesis or ectopic kidney, followed by the hydronephrosis, bifid scrotum, cardiac anomalies, and so on. In management, the 14 patients were managed in the single stage operation, which mainly was simple anoplasty and the cutback VY-plasty, limited posterior sagittal anorectoplasty, posterior sagittal anorectoplasty, and anterior anorectoplasty. The other 16 other patients were managed in a multi-stage operation. In stage one, the stoma formation was done. In stage 2, the definitive management was done, and in stage 3, the stoma closure was done. Out of 30 patients, the 2 patients took DAMA and the 3 patients were expired. In 3 patients, the 2 were the male with the high anorectal malformation, and 1 patient was a patent cloaca, who was a female. In the comparative study, in all study, the incidence of anorectal malformation in the male was high. In our study, the incidence among the female were high. Comparative incidence of type of anomaly in our study, the intermediate variety was most common. In others, low variety were common. All the cases were taken from the records. So the incidence estimation is not possible. Among the distribution of the low anomalies, anocutaneous fistula was commonest in males in the Liverpool series and anovestibular in females. In our study, the 8 of the 30 patients had low anomalies, while in intermediate ones, the rectobulbar urethral fistula is more common in males in the Liverpool studies, while in our study, the 8 were the rectovestibular fistula and the 3 were the rectovaginal fistula. In high anomalies, the rectoprostatic urethral fistula was the commonest in the Liverpool series, and in our study, the 2 cases were the rectoprostatic fistula.
Dr. Khushbu, kindly conclude your paper.
Okay. In conclusion, the female sex is more commonly affected. All over intermediate anomalies are commonest, but high and low are more common in the males, and intermediate are more in females. Associated anomalies are common with the anorectal malformation. In our study, the 56.6% were associated with the other anomaly, and the PSARP approach in treating these patients offers more accurate correction. And mortality is high with the high lesions, as these patients are associated with the serious associated anomaly.
Thank you. The floor is now open for discussion.
Hello, can you hear me?
Yes, sir.
Okay, I take it that this was a retrospective study, not a prospective one. So probably
Yes.
you have not seen the patients, you have only collected the data. But you talked about staging in the operative procedure. Which colostomy would you prefer and why? In which cases?
Sir, most commonly we preferred transverse colostomy. In high variety, uh, we may require the sigmoid. Matlab in if sir, transverse colostomy will be preferred.
Why is it decided? On what basis do you decide whether you want to do a sigmoid or a transverse colostomy?
Sir, sigmoid will be available in the definitive procedure in second stage, in high variety, in high type of anomaly.
So you want to do stage procedure in which variety?
Sir, mostly in high variety and some intermediate type.
Okay, low variety, what is the treatment?
Sir, in low variety, we may go for anoplasty, cutback anoplasty or a VY anoplasty. Or if there is only membrane, so we can do the dilatation or the incision.
Okay, so in those cases, you will not require a protecting colostomy, proximal colostomy.
No, sir. Low anomaly, low type of variety, we may not require.
Okay. You were mentioning about syndromes in your introduction. How
Yes,
many,
sir.
how many cases did you find this associated other syndromes, and which was how many was there? What were those
Sir,
anomalies?
Most common is the vectoral. In our study, we have found the congenital anomalies, which more common were the urogenital, and followed by cardiac anomalies, and then Down syndrome. And so most common is the vectoral anomaly.
Hello.
Yes, Dr. Rajan sir.
What about the pouch colon? What is the approach to the pouch colon if you found during the colostomy of the ARM? Anorectal malformation, you take the patient for the colostomy and you found a pouch colon. So how will you differentiate it preoperatively, and what is the approach to the intraoperative? Do you know?
So preoperatively, we can find out with the help of the radiological investigation in the form of the invertogram or the dye study or the MRI, or intraop. In intraop, if we found pouch colon, Sir, I don't know.
So can you please move on to the next candidate?
We are getting late.
Okay.
Thank you, sir. Dr. Gopal.
Okay, thank you.
Hello, ma'am.
You are there. Just give me 1 minute.
Am I audible?
Yes, you are audible.
Can I start, ma'am?
Just 1 minute. I'll share your screen.
Okay. You can start speaking, Dr. Gopal.
Okay, myself, Gopal Kavale. I'm a third-year resident in general surgery in Swimmer Medical College. My PG guide is Dr. Harish Chauhan, sir. My topic is intercostal drainage tube in chest trauma, analytic study, and comparative study. Introduction. Trauma are the leading cause of death in the first 4 decades of life, mostly caused by road traffic accidents falling down from heights and firearm injuries. Chest trauma divided into penetrating and blunt traumas according to the wound on chest. In India, blunt traumas to chest is more common than other injuries on chest. Approx 1.3 million deaths due to road traffic accidents. In this, 45% deaths are due to the blunt trauma over chest. Blunt traumas lead to hemothorax, pneumothorax, rib fracture, and sometimes laceration or contusion on the lung. Penetrating traumas are mostly related to stabbing and gunshot, and they usually present with lung or other thoracic and abdominal organ injury. Mortality related to penetrating trauma is high compared to blunt, and more than 90% patients not able to reach the hospital alive. How to manage the chest? Management of chest trauma divided into 3 levels of care. First is pre-hospital trauma life support. Second is in-hospital care for trauma life support, and third is surgical trauma life support. Initial management based on advanced trauma life support. After it, for any life-threatening injuries like airway obstruction, tension pneumothorax, open wound, cardiac tamponade should be treated first. In hospital, chest trauma treated by surgeons for hemothorax, pneumothorax, flared chest, rib fractures. Emergency chest X-ray sensitivity is 60%. For USG thorax, for which sensitivity is 87% done. Then, according to the diagnosis, treat the patient. Thoraco-vascular surgeon needed if blood loss is high. Massive subcutaneous emphysema, penetrating chest trauma, and hemoptysis. According to clinical features of a patient, chest drain can be placed on the trauma location, outside hospital, or in the trauma center, or even in the first 24 hours after hospitalization of the patient. Intercostal drainage tube is the first step of management for blunt chest trauma. In ATLS and British Thoracic Society guidelines suggest the use of large bore ICDT, which is 28 French or 30 French, in case of acute hemothorax, which allows the better access of blood loss. Aims and objectives. Aims are to analyze the benefits and limitations of the ICD tube in cases of chest trauma. Inclusion criteria: ages between 15 to 50 years, and patients with unilateral chest traumas. Exclusion criteria: immunocompromised, no traumatic hemothorax, pneumothorax, or pneumothorax, open chest traumas, chest drain in situ on arrival. Now, intercostal drainage tube. ICDT
Please, can
is
you go on to your paper presentation? This is all theory.
Okay. Materials and method. Next slide, please. Materials and method. An observational study done on 15 cases of chest trauma required hospitalization. A case was included when patient was having a chest injury with or without rib fracture, for those with pneumothorax, or hemopneumothorax. Diagnosis was initially made by chest X-ray, and further communicated further CT of the chest was performed in suspected cases of lung parenchymal injury. Management of the patient was followed and recorded in terms of morbidity and mortality. We excluded the patient who already had a chest drainage tube in situ on arrival, and those patients presented was not the result of the trauma, which was a spontaneous pneumothorax like in Cox etiology. Discussion. In this study, all patients managed conservatively. All 15 patients had same history, similar history like RT or the fall down, and patient come with the chief complaint of respiratory distress. Examination of chest and USG thorax and chest X-ray are first line of investigation. And after investigation, ICD insertion ICD insertion was done. Immediate output from the ICD was noted. Patient's respiratory condition was improved and maintained oxygen with decrease in respiratory rate compared to on admission respiratory rate. In study, the mean duration of ICD was 4.56 days, and case scenario of male-female ratio is 8:2. And Etiology ratio of hydrothorax, pneumothorax, and hydropneumothorax are like 6M, 2M, 2. Majority of patients with chest injuries were managed non-operatively, which is in agreement with other studies. ICDT was the mainstay of treatment for the majority, like 95% of the patients. The role of prophylactic antibiotics in ICDT remains issue, but our institutional policy is to administer a single dose of broad spectrum parenteral antibiotic prior to the ICD insert. A recent meta-analysis concluded prophylactic antibiotic treatment reduces the risk of development of infectious complications like fire. ICDT insertion improvised patient respiratory condition and decreases further mortality related to chest trauma. Most procedures, X-ray and USG thorax compared to previous X-ray and USG thorax shows lung expansion, decreased space occupying collection, and on oscillation amount of crepitation decreases than previous studies. On second and third day of follow-up, decrease the collection around the lung, improve the chest expansion, maintain the respiratory rate of normal, and decrease the oxygen requirement. Decrease in output in ICDT compared to the admission output. On fourth day, patient shows overall bad respiratory condition and less than 26 output in drain, blunting of CP angle improvised, and showing lung expansion in USG and chest X-ray.
Dr. Gopal, your time is over. We'll have to go directly to the conclusion.
Conclusion. Chest trauma occurs in a significant number of trauma patients and commonly affects young males of productive age group. This study emphasizes and highlights the fact that more than 90% of the chest injury can be effectively managed with careful initial assessment and simple emergency surgical procedures like intercostal drainage tube with thorough clinical examination, relevant investigation, close monitoring, pain relief, and aggressive chest physiotherapy, timely referral, and appropriate management. Most of the serious chest injuries as well as associated injuries can be managed successfully with ICDT incision and drainage of lung space occupying collection. Multidisciplinary approach.
Dr. Gopal, please, I'll like you to stop. The examiners may ask the questions.
You are supposed to make conclusions from your study. So from your study, what have you concluded? Whatever number of 15 cases you have taken only. Blunt chest trauma.
From the analysis of my study, I have compared my study results from the other studies.
What is it? What have you concluded?
Sir, actually, sir, I had a chart prepared for the 15 patient, but due to lack of slides, I cannot put here. We can show that
that is you are supposed to present in your conclusion. What have you concluded from your study of 15 cases?
Sir, my conclusion is ICDT should be the first line of management for the any chest traumas in which
that is standard. That is standard operating procedure and a standard treatment protocol for chest abdominal, blunt chest trauma.
Yes. Other than that, while comparing to the other studies, I also concluded that in British scenario, it was said that 28 to 30 French ICDT is required, but some other studies also stated that pigtail insertion is also as helpful as the ICDT.
In your 15 cases, have you used small bore drain or pigtail
Yes, sir. Yes, sir. Yes, sir. We have used 18 goes for the pneumothorax, sir. 18 French ICD tube we have used.
No, but the British study is talking about hemothorax.
That is for the collection, hemothorax and pneumothorax, sir.
No. Your British study is mentioning that large bore catheter 28 to 30 French is what you have mentioned in your paper. 28 to 30 is for draining of blood. So have you done that draining of blood with a smaller bore in your study?
Sir, in our study, we have used 24 French ICD tube, which works quite well, sir.
Okay, and
pigtail no issue and no post-op complications.
Okay, where have you used pigtail and what was your finding?
Sir, actually, I didn't use the pigtail. While compared to the other study, I have seen.
So you cannot make a conclusion.
I cannot make that conclusion.
Yes.
Can we conclude this presentation and go on to the next one?
In which chest injury you would not like to put ICD?
Sir,
in all chest injury you put ICD?
Sir, in traumatic while in open rib fracture or flared chest, we should go for the intervention, thoracic surgery for the fixation of the chest bolster. In that case, ICDT may lead to
Yeah, I would,
the
you have heard about hemoperitoneum we treat conservatively in solid organ injury. Can we treat the hemothorax conservatively?
No, sir. Hemothorax are more likely to develop the pyothorax. So in hemothorax setup, we are used to go for the isolated insertion.
So can you please move on to the next?
I think we should conclude now. We should conclude and go to the next.
Dr. Rajvi, are you there?
Yes, ma'am. Yes, ma'am, I'm here. Am I audible?
Yes, you are audible. Please start your presentation.
Yes. Good afternoon, everyone. Myself, Dr. Rajvi Gohil, third year surgery resident from Medical College, Baroda. Today, my topic is comparison between percutaneous pictal catheter drainage and Malacot catheter drainage in management of liver abscess. My introduction. Liver abscess is an important cause of morbidity and mortality in tropical countries. India has the second most burden of liver abscess among all other countries. After thorough routine blood serological examination and ultrasound abdomen for abscess, patients are given antibiotic therapy. Patients not responding to parenteral antibiotics therapy within 48 to 72 hours are subjected to ultrasound guided aspiration if the abscess cavity is less than 5 cm in diameter and percutaneous catheter drainage for cavity more than 5 cm. The present study is intended to evaluate USG-guided percutaneous catheter drainage using pictal catheter and Malacot catheter, assess its response and morbidity, mortality, and complications rates of the procedure. Next. The aim of the study is to compare between pictal and Malacot catheter drainage in management of liver abscess, and the objectives are to compare the time for total resolution and reduction of abscess cavity at 15 days, 1 month, and 3 months, clinical improvements in case of like symptoms like pain, fever, and abdominal pain, number of days catheter in situ, complications rates, and duration of hospital stay. Next. The inclusion criteria are the patients who have liquefied and aspirable liver abscess and more than 5 cm diameter requiring drainage. And the exclusion criteria are liver abscess less than 5 cm in diameter, pregnant patients age less than 18 years, HIV patients, altered coagulation profile, multiple ruptured, partially liquefied, and aspirable and non-aspirable liver abscesses. This study is done in SSG Hospital, Baroda between December 2020 to August 2021. It is a prospective randomized control trial done in 58 patients, in which 48 are male and 12 are females, in which technique pictal and Malacot catheter were inserted in randomized patients according to standard technique. Patients were assessed daily till the day of discharge for clinical improvement, and a USG abdomen was done at 15 days, 1 month, 2nd month, and 3rd month to look for reduction of cavity size. Now, this is the table showing there are total 58 patients, from which 32 patient has undergone pictal drainage and 26 patient undergone Malacot drainage. Out of 11, this is the size of abscess in which pictal and Malacots are inserted. And the second table shows the result in reduction of size less than 5 cm. At the end of 15 days, about 6 patients who undergone pictal drainage has reduction in size less than 5 cm, and at the end of 15 days 4 patients who had undergone Malacot drainage has reduction in size less than 5 cm. At the end of 1 month, both Malacot and pictal has 13 patients undergone reduction in size of abscess, and at the end of 3 months, at the end of study, out in case of pictal drainage, 23 patients has reduction of size in abscess in case of pictal, and 25% Malacot, 25 patients had undergone reduction in total size of abscess in case of Malacot drainage, which is statistically significant. Next, the comparison of results of days for clinical improvement. In case of pictal, it takes 3.28 days, and in case of Malacot, it takes 1.96 days. Comparison of duration of hospitals. In case of pigtail, it is 11.75 days, and in case of Malacot, it is 9.76 days. Out of total 32 patients of percutaneous pigtail catheter insertion, one patient developed catheter block, one patient developed biliary fistula, in 2 patients catheter dislodged, and 1 patient developed rupture abscess. And only in 1 patient out of 26 patients percutaneous Malacot catheter insertion, only 1 patient developed rupture of abscess. The catheter blockage was managed by regular flushing of cavity with metronidazole antibiotic and normal saline. In case of persistent block, catheter was removed and new catheter was reinserted and IV antibiotics were continued. Next, the conclusion. There is a conclusion of this study. The incidence of liver abscess was seen in higher incidence in male than females. The higher incidence of liver abscess was noted in age group in 50 to 60 years, and the most the location of abscess was more in right lobe than the left lobe, and the pus culture sensitivity was the most common organism was E. coli, followed by Staphylococcus aureus and Proteus. It was noted that on the 3rd month, pigtail catheter reduced the size of abscess cavity efficiently to less than 5 centimeter in 23 cases, whereas Malacot catheter reduced the size of abscess cavity to less than 5 centimeter in 25 cases. The difference in the resolution of cavity size was significant. The Malacot catheter drainage proved to be better. Average duration of the number of days is for clinical improvement in terms of reduction in resolution of symptoms in pain, fever, and abdominal pain. With pigtail catheter, it is 3.28 days, and with Malacot catheter, it is
Rajvi,
1.96 days.
I'm sorry, I'll have to stop you here.
Okay.
Okay,
Can you
Rajvi.
please ask the
Hello.
question?
Yeah. What was the size of your pigtail and Malacot when you have inserted?
Sir, it is 16 number. Hello.
Both
Am
of
I-
the same size?
Yes, sir. 16 number Malacot and 16 number pigtail catheter.
And how long did you put the pigtail and Malacot in your
Sir,
patient?
the removal of pigtail and Malacot is when the drainage output was less than 20 ml for 3 consecutive days. And the reduction of cavity size is 25% from the initial size on ultrasound. Then we can remove the pigtail and Malacot catheter.
Average, how many days like in your study? Like 10 days, 15 days, how many days like average you have removed the pigtail and Malacot?
Sir, average 12 days. In case of Malacot, it is 9 to 10 days, and in case of pigtail, it is 11 to 12 days. Sir.
And Malacot, how did you insert pigtail? So everybody is knowing. How did you insert the Malacot with the flanges?
Sir, Malacot was inserted via use of guide wire, sir.
By use of guide wire.
Yes, sir.
First,
First
because
we
Malacot,
inserted.
the end of the Malacot is closed. I mean, you know, it has got flanges, but the tip of the Malacot does not have any opening. So how
Sir, it has opening for guide wire. So first we inserted needle. We have after that we insert guide wire, and following guide wire we dilate the we inserted
that I
dilator.
know, but the tip of the Malacot, the red
Yes,
rubber
sir.
Malacot, tip of the Malacot does not have a opening. Which Malacot
Sir,
you are using?
Sir, we are using the PVC, sir. Hello.
Yeah, I understood, but I'm not very convinced. Is it having a opening at the tip?
Yes, sir. Yes, sir. It is having opening. We can guide wire inserted. We can guide wire, sir.
The time for discussion is over. Can we please move on to the next candidate?
Thank you, sir.
We have a poster presentation by Dr. Darshil. Actually, the candidate had BCBR examination in the morning, so we have kept him here.
Hello, ma'am. Am I audible?
Please, there is a lot of background noise from your end. Can you please go to a more silent area?
Yes, ma'am. Sure. Now, ma'am.
Still, there is a lot of background noise.
Mm,
Okay, can please start the presentation.
Yeah, start.
Okay.
Start.
Good afternoon, sir. My name is Dr. Darshan. I am a second year resident in general surgery in SUP Medical College. Today, I am presenting a poster on a rare case of trichobrazor in young female. I am starting from the abstract. Trichobrazor are formed masses of undigested hair balls. They predominate in young females during childhood and adolescence and are usually associated with psychiatric illness. This usually develop incidentally and hence at presentation are large in size. Examination may reveal an abdominal mass or halitosis caused by bacterial colonization of the basal. Complications of trichobrazos include upper gastrointestinal bleeding and anemia, secondly due to gastric mucus erosion, perforation, or rarely gastric outlet obstruction. Introduction. Basals are masses formed by the concretion of incompletely digested substance from different origins such as plants, drugs, or hairs. The basal with hair is called trichobazal. Psychiatric illness and mental retardation are commonly associated with trichobazal. The consumed hair is retained between the gastric folds and resists to peristaltic movement due to its slippery surface. The hair is then denaturated by gastric acid, becomes black due to oxidation, and compacted with the food to form an immersed mass. Trichobrazol reaches past the small intestine and sometimes even into the colon, producing a long hair-like extension of hairs is called Rapunzel syndrome. The insidious development of trichobrazol accounts for the delayed presentation and large size at the time of diagnosis. Some types of basals, including small trichobazols, can be removed endoscopically. Larger trichobazols are typically resistant to endoscopic fragmentation due to the dense hair masses and require surgical removal. Case report. Clinical presentation. A 15-year-old female patient came to SVP hospital on 3rd of September with complaint of generalized abdominal pain since 3 days, associated with vomiting and constipation since 2 days, no complaint of fever, bleeding per rectum, burning mature or sticky stool. My clinical diagnosis is small bowel obstruction. On examination, per abdomen was soft and distended. Per rectal examination was NAD. On admission, vitals were normal. My blood investigation was within normal limits. We have gone for the X-ray, AXR, standing X-ray. There were multiple air-through levels, and on CSCT report. Can you just? In my CSCT abdominal report, intraluminal debris with air foci giving motile appearance noted involving stomach suggestive of phytobasal most likely associated with reactive inflammatory wall thickening involving fundus body and pylorus of stomach with narrowing of the pyloroduodenal junction in intense homogeneous enhancement of the bowel wall noted in right iliac fossa involving distal ileal loop and resultant dilatation of the proximal and mid ileal loop with faces mostly phytobasal within the ileal loops in right iliac fossa. Possibility of stricture in distal ileal loop most likely. Transient intussusception at the level of mid jejunal loops with distally dilated jejunal loops. Mild ascites were present. On operating findings, ma'am, can you just?
Yes, we can read. Please continue.
On operative findings, 4 centimeter vertical incision was kept over anterior surface of stomach 3 centimeter middle to greater curvature, and stomach cavity was reached and large basal approximately 20 by 10 centimeter was removed and sent for HP. Primary closure of stomach was done by Vicryl 20 in continuous interlocking manner, and serosal sutures were taken by Vicryl 20 in continuous interlocking manner in Lambert fashion. Bowel work was done, and from 20 centimeter proximal to IC junction, basal was palpated proximally, bowel was dilated and distal the bowel was collapsed. 3 centimeter incision was kept along long axis of ileum, and approximately 5 by 4 centimeter basal was removed, and from proximal bowel contents were evacuated, which was containing hair. Primary closure was done by Vicryl 20 in simple continuous interlocking manner, and serosal sutures were taken by Vicryl 20 round body in simple interrupted manner. 5 liter of saline was given.
Dr. Darfil, please conclude your poster.
Yes, ma'am. In my conclusion, trichobrazol almost is a disease occurring in the second decade of life, more common in young females, and should not be forgotten as a rare differential diagnosis in patients presenting with vague abdominal pain. Complications are not infrequent, and has timely diagnosis and management is crucial. Laparotomy removal still remains the gold standard therapy for the most cases, and psychiatric evaluation, counseling, and treatment are an essential part of the management and rehabilitation.
Thank you. Examiners, please, will you like to ask some questions?
This intestinal obstruction, what was the reason?
Mainly there is a large trypoblazor was in a small intestine, in stomach, and the small part of hair ball was also found in the just 20 centimeter proximal to the IC junction. So,
the trichomonas in the
mostly
stomach was not the cause for the intestinal obstruction. The segment which might have detached and has gone and got
Yes,
obstructed.
sir. Sir, the segment which has detached and gone to the in ileum, that is causing the obstruction. Hello.
Sir, did you get any psychiatric evaluation of this patient done?
Yes, sir. Yes, sir. We have did the psychiatric evaluation at that time, but from the psychiatric department there was no active management at present.
So they have not diagnosed any psychiatric condition, is it?
No, sir. No, sir. They have not diagnosed any psychiatric at that time. They just told, sir, every yearly they told them to every yearly follow up. Nothing else, sir.
Dr. Rajan, Dr. Vineet, sir, will you like to ask any questions?
Yeah, I think no. You can conclude this.
Okay. Thank you, sir.
Now we have our last participant, Dr. Hetal, will be presenting a paper. Hetal, are you there? Hetal? Hetal, are you there? Please start your presentation. So she's online, but you can't hear her.
Maybe she is not ready for the presentation.
Dr. Hetal?
Is this the last presentation anyway?
Yes, sir, this is the last presentation. So can you please give me 1 minute? I'll just call her and confirm.
Yes, sure, please do.
Thank you.
Darshil got lucky because we were waiting for the other candidate and we could not ask him so much questions.
I think there is some network issue with her. She's again and again coming and logging. Sir, there is some network issue with the candidate. She's online, but we are unable to hear her.
What to do?
Wait for some time.
Sir, please guide. What should we do?
Hello. I think we can just see the presentation. We can just see the presentation, and then she can just give some concluding remarks also. Unnecessarily, we are.
Fine. Yes.
We can see the presentation.
Could I just make a suggestion where your presentations are presenter is from your institution only? Can they all be around somewhere nearby your station only?
So from next time we'll keep it in mind.
Yes,
Actually,
because,
sir, I think she has her emergency today, so she might be in trauma.
Okay.
Fine. Then we leave it. Ketla baki rahe beta? Any
Sir,
more left out?
This is the last paper, sir.
Okay.
I'll just go through it once.
You called her up.
Run through it once so that.
We'll leave it then. Not an issue.
Okay.
Minister, what do you say?
If she has prepared it well, she can present it at some next session or something.
Okay, sir.
Yeah, fine.
Let us save.
That is fine.
Let us save this presentation.
Yeah, we'll leave then.
Yeah, we will leave. I think that would be best, because if she is not available, then we should leave.
Then it will be a waste of this paper.
Yeah.
Okay.
No, we'll use it in some way, sir. Thank you. We'll help her out in that way.
Right.
Thank you, Dr. Rajan, Dr. Harsh, and Dr.
Thank
Vivek,
you.
sir.
Thank
Kindly
you.
please send me the mark sheets of the candidates, sir.
Yeah, or you can send it
Hello.
either as a WhatsApp picture or JPG, PDF. Everything will be fine.
Okay.
Okay.
Thank you.
Thank you, sir.
We'll leave that. Thank you.
Thank you for having
Conclude the
us.
session. Thank you, sir.
Thank you for having us. Best of luck.
Thank you.